Kuna mic hapa, kuna sound. Go. Weka zote mbili. Ndio kibodi. So moja itaenda excel. Wadadi hata waambie mtu ashike hiyo. Kabla ya kusema sound. Weke zote mbili, usiweke moja. Hiyo ni kamera. Sienda, itakuwa kwa jack. Simeka jack. Ndio hiyo. Alafu sauti. Ndio. Hapo. For now,
Yeah. You cannot use the small ones like they are smaller. Okay. Hey.
Good morning. Hello, hello. Testing, testing. Good morning. Am I audible?
Morning.
2, 3 testing. Good morning. We are good to go. Right. Good morning, everyone. Let me take this opportunity to welcome us to our second day of our conference. Hoping that we had a good session yesterday. I know we have very interesting presentations for the day, but to set us off, I want to request our Reverend to give us a word of prayer. And then I'll request the chair of the first session, Dr. Muthuka, to take over immediately after the word of prayer. Thank you.
Good morning. This morning, I'd like to share from the text of Luke chapter 10, verse 19. Luke chapter 10, verse 19, the Bible says, "Behold, I've given you authority, tread on serpents and scorpions, and for all the power of the enemy, and nothing shall hurt you." The Bible this morning is reminding us that the power and authority given to us as medics, given to us as people of God, that will begin power to tread, to step on serpents and scorpions, and for all the power of the enemy, and nothing by any means shall hurt us. Let us pray. Our God and our Father, help us to fight against poverty, ignorance, and diseases. O Lord, give us strength and energy to fight our enemies of poverty, ignorance, and diseases. May you bless our government, bless our President, Dr. William Ruto, and his entire government. We pray for the Minister of Health, even as we carry on the health coverage for all of us as we realize our Vision 2030. Lord God, may you bless Kenya Medical Training College, bless and equip the board of directors, equip the board chair, equip our CEO, Dr. Kerry Uruch, and all managers working under him. Father, bless our researches and trainings in our institutions. May you provide our sponsors and guardians with the strength to stand with us in all programs towards training for better health. Equip our students with wisdom to become multidisciplinary professionals. Equip our facilitators today and our presenters with the knowledge and equip them today, even as they do their part as medics. In Jesus' name we pray. Amen. May God bless us.
So thank you, Chaplain, for today. We appreciate and acknowledge this session. We had intense discussions yesterday. We were touching on concept of data repository and management of data. You recall the challenge that was yesterday as per the keynote speaker regarding the issues to do with the trend. We are in the 5th generation. And if we could recollect that from yesterday, we transit to today. Today now we have another theme, which we are going to have. The theme is enhancing universal healthcare coverage through implementation of the primary healthcare networks. We should be aware that universal healthcare coverage is a vehicle towards Sustainable Development Goals 2030. And we should understand that we have just about 7 years, or let me say 8 years before we reach that stage. And we are mapping, by virtue of monitoring and evaluation, we are mapping whether we are achieving these specific goals or we are on the right trajectory after every 4 years. We should have done that in 2022. We are yet to understand if we have some areas to amend, because we have the second phase now of the next 4 years and then the last phase towards 2030. For the call of all the researchers in terms of implementing the strategies that we put across, we should ask ourselves, are we really on the right trajectory? You as a researcher, you as a Kenyan, wherever you are, you should ask yourself in terms of universal healthcare coverage, what are you doing to impact to the society, or what are you doing to contribute towards the achievement of the same? 8 years is like 80 days when things are not well mapped. So we need to be more adept with those principles. Today, we will be having that keynote speaker as a plenary session. However, Dr. Mohammed will be having this session much later. For now, we'll be benchmarking on the scientific papers that we have to present for today, which are going to be intense also, just like yesterday. And these papers are, of course, pre-recorded, and the authors who are presenting those papers will be, of course, attending to the answer and question session after the presentation of the same. We'll be having one paper on experiences of frontline workers in quarantine sites for COVID-19 in Kenya. This is a qualitative study, which is principally authored by Kevin Oruko, and the co-authors are Agutu, Ahomo, and Mwangi G. The other paper is practices and perceptions of blood donation among clinical medicine students in Kenya Medical Training College, paper authored by Mugwe and Manyara Lucy. The other paper would be utilization of post-abortion contraceptives among adolescents in Makueni County. This paper by Jerry and Musovia James. And then another one would be perceptions of volunteers on the effectiveness of KMTC. These are run free medical camps in enhancing access to healthcare by vulnerable communities. This paper is authored by Obasa et al. Now, based on the timings, we might be finding it applicable to compress, and we might include other papers for today. Tomorrow being the last day of this conference, we might want to bite the much we can for today because we don't know the expected of tomorrow. Now, I'll be giving out the session as per the recordings that are there with liaison with the one Francis Gashanja. I think you should also play a role, you guide us on the same. If there could be any amendments that are being done within the process, we'll be having back and forth consultations. So my name is Dr. Mbuka John, and I'm your chair for this morning session, and you are most welcome. In the meanwhile, let me be confirming the presence of Kevin Oruko or the representative for the same. Kevin Oruko, okay, good. Then let me also confirm the presence of Mugwe J. Mugwe J, this is a paper by a student. This is awesome in our midst to have a student, and this is what we are calling upon. We need to start having this knowledge translation to students. It's a picture that should illuminate that students can as well do what is supposed to be done as per the mandate of KMTC in terms of training and research. Those were the words of our able CEO yesterday. And I'm also impressed to see students as one of the presenters for today. Should I also confirm the presence of Jerry R? You are standing in, James Musovia. And then Obasa. Obasa, you're here. As okay, and then we could be having some extra papers based on the timings. And we will know which papers are those as time goes by, as we are being guided. So as we wait for So I think we are yet to listen to the first and we move to Q&A. Thank you so much.
Hello, my name is Mulhan. I'm a nutritionist and also a co-author and executive of the study, Experiences of Frontline Workers in Vaccine Sites. Hello, my name is Mulhat. I'm a nutritionist and also a co-author. I'll be taking you through the study, experiences of frontline workers in quarantine. So we'll go over from background all the way to conclusion. In 2019, we had the first case of COVID-19 being reported in China. In Kenya, we had our first case reported in March 2020. Following the outbreak of COVID-19, a number of measures were put in place to curb the spread of the disease. One of the measures was a 14-day mandatory quarantine to all those who may be exposed to the disease. There are a number of people working at the quarantine facilities. They included a team of well-trained medical professionals and also auxiliary service providers who addressed issues of meals, even cleaning or some security. The main objective of our study was to describe the experiences of frontline workers and their auxiliary counterparts working in the quarantine sites at KMTC. According to Robertson, 2004, frontline workers need to be heard and listened, and then their needs and concerns addressed appropriately. Thus, the objective of our study. Our study design was a qualitative phenomenological design, which basically means lived explanatory experiences of these frontline workers and their auxiliary counterparts. So data was collected between July and August 2020 at KMTC premises. KMTC had 43 campuses that were set up as quarantine facilities. As of May 2020, 21 of the 43 campuses were operational. Out of the 21 operational quarantine facilities, 3 were chosen purposely as the study sites. Interviews and small group discussions across the research sites. We had a total of 27 participants taking place in both in-depth interviews and small group discussions. The data collected therein was then analyzed using NVivo, which is a software for analyzing data, qualitative data. Our results are shown. We had 13 in-depth interview participants, 62% of whom were 31 to 40%. We can also see that we had a large percentage of 79% of small group discussion participants being female. The participants were of different educational levels. They also played different roles professionally. We had drivers, we had administrators, we had cleaners, we had security guards. We also had the frontline workers such as the nurses, clinicians, even social workers. So the two main themes came up. We had challenges or barriers as the main theme. We also had motivators or coping strategies as another theme. And barriers and challenges, 10 sub-themes came up. We'll be addressing few of these. One is lack of preparedness of both facility workers and clients. So some clients it was reported that some clients said they were lied to, they were not truthfully informed of their stay to COVID quarantine facilities. So when they were picked up, they were told that they were only going for testing, only to end up in quarantine facilities, and you have to spend 14 days there. You do not have your basic requirements. Some had comorbidities such as diabetes and hypertension, and were not even allowed to carry their medication with them. This brought about another sub-theme, clients being uncooperative and being rude to the facility workers. Within lack of preparedness, it was also seen with the facility workers in that initially it was reported that there was no PPEs. So this posed a challenge because they also had fear of infection due to that. You have to work with potentially COVID-19 patients. You do not have PPEs to protect them. One even reported to sharing of masks or having to buy from their own pockets. Another sub-theme that was there was lack of and or underutilization of psychosocial counseling services. Few of the campuses which served as quarantine facilities had psychosocial support that was being offered. Of those that were offered, some felt that their need was put aside, was negated, and attention was only given to clients only. So their mental health was at stake. We also had changing policies and guidelines on COVID-19 measures. So initially, the guidelines stated that there needed to be 2 tests at day 8 and day 12, but then these changed. This changed later on to be only 1 test. And the communication the communication of these challenges was also an issue, which brings about this other sub-theme, coordination and communication gaps. We'll now look into some of the quotes. One says, this psychosocial support nurse says, let me not say nobody, but I guess yes, nobody was very prepared, including myself. And as I'm saying, I didn't know what we were expecting. And you know, the way we were learning about this virus, it's killing tens of thousands. We were feeling that the moment we start interacting with these people, we'll be infected. And we didn't know if we're receiving the people who were already infected. I was actually not prepared. Initially, there was a lot of fear. So we can see from here that different themes are popping up. We have lack of preparedness, we have fear of failure that's being addressed in this quote. Another male cleaner participants mentioned, at times when people realize that you work in a quarantine facility, they used to run away from you. They don't want to come. They don't want to come close to you. That addresses stigma. That was also another theme that cut across from all participants. Things happened very fast. I don't think there was prior training. Training came along while the quarantines were here. Zero prepared. There were no PPEs, the masks we were borrowing from each other. That was reported by a female nurse. Lastly, sometimes, most of the time, when there is change, there is no proper communication, or if the communication is there, it is not reaching anyone. That addresses the sub-theme gaps in communication and coordination of data. On theme number 2, motivators and coping strategies, there were different ways that the frontline workers coped or learned to live with the challenges that they had, taking one day at a time. One of them was self-motivation. They had support from families and friends, gaining experience through in-job training, past experiences, as we shall see later on by 2 participants. Training, PPE availability, good relationship between staff and clients, and lastly, negative test results. So when facility workers will test negative to their routinely testing of the COVID-19, it was encouraging to them. They even say that it was encouraging to see that their clients tested negative and were leaving the facility. That proved that they were adhering to the rules of preventive measures of COVID-19. Some of the examples supporting this are, I encouraged myself since it's work and I asked God to protect me. That was reported from a small group discussion participant. One also said, I think what really helped us was that the test that was conducted and the results turned negative. The negative results proved that we were not infected and the fear reduced. Lastly, I had worked in another similar setting during the Ebola outbreak, so I knew about quarantine. So the only thing to refresh my mind, I'm trying to get new information. What you need to do for me, it was like a refresher to know what was happening here. So this was a public health officer who had prior experience to working during the Ebola outbreak in Congo. We also had another female nurse who had experienced working also in Ebola outbreak in Uganda. So to conclude, the frontline workers faced several challenges, including physical and also emotional. And all this was largely contributed by lack of preparedness, as it was mentioned earlier, and also by the participants. It is therefore crucial and critical to provide comprehensive support to safeguard the health and well-being of these frontline workers by providing psychosocial support or preparations before and during the training, during the training of the cause of response. And with that, I'd like to thank you for your time and for your ears. We now welcome.
Hello and welcome to this presentation. My name is Wambu James Mugwe, and I am a student of clinical medicine, currently in the third year, doing my second semester at KMTC Nairobi campus. And today, blood is a rare product, and this is because blood is a product that has its only source in human beings. There is no way of manufacturing blood for the purposes of transfusion. And as a result, this has caused a shortage that has affected the whole world. And globally, the shortage is such that where blood is supposed to be availed at 305 million units, only 272 units are made available. That was true in the year 2017 from a study conducted by the Washington University. In Africa, the demand for blood is even higher. This is due to conditions such as sickle cell that are higher in Africa. They increase the demand I will be doing a presentation on the study conducted on practices and perceptions of blood donation among clinical medicine students in Kenya Medical Training College, Nairobi. Hello and welcome to this presentation. My name is Wambu James Mugwe, and I am a student of clinical medicine, currently in the third year, doing my second semester at KMTC Nairobi campus. And today, blood is a rare product, and this is because blood is a product that has its only source in human beings. There is no way of manufacturing blood for the purposes of transfusion. And as a result, this has caused a shortage that has affected the whole world. And globally, the shortage is such that where blood is supposed to be availed at 305 million units, only 272 units are made available. That was true in the year 2017 from a study conducted by the Washington University. In Africa, the demand for blood is even higher. This is due to conditions such as sickle cell that are higher in Africa. They increase the demand for blood and blood products. When COVID-19 came along, it cut down the blood donation practices by as much as 25%. This means that people stopped going to the hospital to donate blood, and it has worsened the shortage over time. As a country, Kenya has it worse. It is said that every 10 minutes, 7 patients require blood. This is information sourced from the World Bank. In 2019, we achieved 80,000 units of blood. In 2020, 100,018 units were collected. In 2021, only 186,239 units were collected. These numbers might sound promising. They're getting higher and higher, but compared to the amount of blood that we require per year, which is 500,000 units of blood at least, then you'll realize we're not doing really well. We're not on the right track. The consequences of the absence of blood for transfusion have been there, and they are bad. We have children that require transfusions, children that are suffering from severe malaria, and their chances of mortality stands at 20% when they do not receive blood transfusions, as opposed to those that receive blood transfusion that are having a mortality chance of 12%. And it's not just children, we also have patients of cancer, people who are being treated for cancer, people who have chronic conditions such as sickle cell anemia. Once again, this study was conducted among the clinical medicine students of KMTC Nairobi campus with a broad objective that was to determine the practices and perception of blood donation among clinical medicine students in KMTC. The specific objectives were to determine the social demographic factors, to determine their perception towards blood donation, and to determine the blood donation practices among the same students. This is aimed at increasing blood donation. The study was conducted in KMTC Nairobi campus, a campus that boasts a population of 4,200 students collectively. And for this study, the focus was mostly, again, on diploma and higher national diploma students of clinical medicine. It adopted a descriptive cross-sectional study design where Andrew Fisher's method was used to arrive at 121 participants. The data collection tools were put on Google form questionnaires. After all, we are in the era of technology. Simple random technique was applied in the distribution of questionnaires to ensure that the participants were reached and a good number arrived at. Piloting was conducted 2 weeks ahead of the study, which was done in November 2022. Clinical medicine students, by virtue of being in the medical field, have an understanding of why blood donation should be taken seriously, and they are also at a good position of preaching awareness. And that is why this study focused only on the diploma and higher national diploma students of clinical medicine. This study included any student member of the clinical medicine department that was willing to participate, but excluded any student that was absent during the period of the study. At the end of the study, 100 students had participated, 51% of whom were male and 49% of whom were female. A majority fell in the 18 to 24 years age bracket. That age bracket had up to 73% of the participants in total. On the perception of blood donation practices, most of them considered blood donation a good practice. Up to 73% of the participants thought that it should be encouraged, while 27% were of a different opinion. 84% of the participants considered blood donation a safe activity and cited reasons that included that it is a practice that has been there for such a long period of time, and over the years it has been perfected and the risks have been minimized. 39% of the participants have donated blood. Of this number, 81% are willing to donate again. 84% of the non-donors are willing to receive a transfusion. The reasons for not donating among the 61% that have not donated included fear of donation, which is a reason that was cited by 23 out of 61 of the participants, and 22 of them cited that they have never been asked to donate, and that's the reason why they've never donated. So far, we have established that 39% of the study participants had donated blood. Of the male population, a good 43% had donated blood, while amongst the female, 41% had donated blood. This number does not differ very much and is not of any statistical significance. It differs from a study that was conducted in Sudan, where 45% of the male population had donated blood and 21% of the female population had donated blood. The difference was bigger there. Of the students that had donated blood, 14 of them had donated once, 6 had donated blood twice, and the trend continues in a downwards manner, where it shows that the number of people that had donated blood reduced as the frequency of blood donation increased. 59% were in the 18 to 24 age bracket. 79.5% reside in urban areas, and most of them had donated blood to help the relatives that needed blood. In conclusion, this study found that the prevalence of blood donation was at 39%, with a slightly higher prevalence amongst the male. Only a small portion of students think that blood donation is risky. This study recommends the creation of awareness on blood donation services and their importance in KMTC, and allaying the anxiety around blood donation practices in order to encourage blood donation. I'd like to thank the Almighty for the gift of life. My deepest gratitude to my research supervisor, Dr. Lucy Manyara, for her guidance and sound advice. I'd also like to acknowledge Mr. Alex Tra of the Clinical Medicine Department for his support, and my family for standing by my side throughout the process. The references will be provided. Thank you.
in the 7th Biennial Scientific Conference. My name is Zachary Mbasa, a lecturer in KMTC Makindu, Department of Nursing. I'm presenting this study with that was co-authored together with other colleagues, which list you can see here. The study is entitled Utilization of Kenya Medical Training College, Volunteer and Free Clinics in Enhancing Access to the healthy care to the vulnerable communities. Now, as a background to this study, as you are aware, most of our rural communities in developing countries, Kenya being one of them, they are faced with a number of challenges, healthy challenges. They are, most of them that are preventable diseases and unnecessary deaths arising from such diseases like diarrhea, malnutrition, pneumonia, and communicable diseases like hypertension, cancer, and diabetes. Now, you will also notice that there is evidence to suggest that most of the health facilities that these people can access have only the very basic services, if any. They are very basic. They are very health facilities are scarce, and they are far apart, so that most of these people do not access them. The bulk of our communities usually are uninsured, or they come from low economic statuses, and therefore they don't have access to services even if they were offered elsewhere. Now, in mitigation, the local NGOs that are available and the GOK have established a number of services, some of which are volunteer and free clinics, and others like the mobile clinics that was established by the First Lady, the Beyond Zero campaigns then, some years back, to address some of these challenges. Now, despite these challenges, concerted efforts from the GOK and the non-governmental organizations, there still does exist healthy disparities in our populations, and the healthcare access of our population to quality healthcare remains a challenge. And in the wisdom of KMTC, and as a way of giving back to the society as its corporate social responsibility, it has designated campuses to organize medical camps to surrounding communities. For example, Makindu has had the privilege of organizing a number of these, and it has witnessed very high turnouts, which indicates that the potential to use volunteers and to work with the communities to be able to bridge this gap. However, there is no documented evidence countrywide with regard to our MTCs on how, on the services that they organize with regard to the most frequently sought services during these free camps, and the services that people, when they come, they lack, and the associated challenges, and if any existing potentials do exist during this offering of these services that can be leveraged on moving forward. And this, therefore, was the gap that this study sought to solve. We sought to gain insights into the frequently used services, missed services, and the challenges that do exist when we are offering KMTC, volunteer and free clinics, or what we commonly call medical camps, and the available opportunities. And these are the specific objectives that can arise from or arose from the aim of the study. Now, we employed an exploratory research designed to have an understanding of these challenges, and we purposefully selected 3 KMTC campuses in the regions that we categorized as hardships or hard-to-reach areas, namely Mbooni campus in Makueni County, Nyahururu in Laikipia, and Kabarnet in Baringo counties. We also had one health facility that KMTC Makindu has partnered with before, called Kaskeo Health Center in Makueni County, so that they can also give us their insights. Now, the people we collected data from are people who had previously volunteered in KMTC run clinics or medical camps, namely the faculty and faculty members from these campuses, community opinion leaders from the surrounding communities, and the local administrators and representatives from these health facilities. And in general, we had face-to-face interviews, and we were conducted, and we recorded the data, which we then transcribed and thematically analyzed to see the patterns that were arising. And the data that we came up with was analyzed and presented in figures, tables, and it's also narrated. Now, Out of the 16 key informants, because this was purely a qualitative study, the services that were pointed out, the themes that emerged from the analysis of the data, that these are the services that most people sought when they were coming to the free clinics: curative services, immunization services, routine maternal and child health services. Most of them came to be sensed or to be made aware about communicable and non-communicable diseases. We also addressed reproductive health issues and drug and substance abuse. Education was shared. We also noted that most of the people sought services that we were not able to offer. One of these things is that we turned most people went home without getting medications that had already been prescribed, and they did not get specialized services. They were very disappointed, especially with regard to cervical cancer screening. They were not able to be adequately followed up for the conditions that we had identified. And then most of them, when we referred them, we didn't know whether they arrived where they were referred or whether they ever went for the referrals. The challenges we also faced that were faced by most of these medical camps that were reported in the campuses that we visited was that there were lack of volunteer motivation, because most of them felt that they were not adequately facilitated. And then the stakeholders, most of them saying they were not well involved right from the beginning so that they can adequately mobilize their people. And then there were also, there was a feeling that the services offered were not comprehensive enough to take care of specialized services, referral services, and other services that the people could not get, especially bearing in mind that the available facilities were very far, so people could wish to get comprehensive services during these camps. Now, we also assessed whether there does exist resources in the community that will be leveraged on moving forward. We have found that there were staff who are healthcare workers and non-healthcare workers coming from the KMTCs around, which could be the staff and the students. We also found that the nearby facilities could be leveraged moving forward if we were to bridge this gap. We also had a very good network of community health volunteers and community health assistants, and they do exist in most of their counties that we visited. Secondly, we had adequate infrastructure, namely what we call the soft infrastructure, that is the social networks, made up of the community units, receptive communities, diaspora networks, daughters and sons who are living health outside the counties, all the places where they come from, but they can come back to give the society. And it was widely reported that they are willing to come back, the Nimakumi Initiative and religious networks, and the traditional medicine. Now, we also had infrastructure, which we call hard infrastructure, the physical infrastructure, which are the hospitals, the medical equipment, the buildings, either the hospital buildings, the churches, and the chief's camp. All these could be leveraged, and the most important thing is that we had a receptive community that was willing to partner with whoever was willing to solve the challenge of healthcare access. Now, as part of the discussion, our findings are not very unique, because previously there have been studies that have identified that the local rural communities do not have access to healthy care, because most of them, they are constrained by finances and they don't have insurances, although most want to get immunizations and curative and preventive services. Now, the second thing is that we observed a very high turnout and the utilization of immunization services during medical camps. And previous studies have shown that when the facilities are far apart, they are missed opportunities. So when these camps are there, most of them turn up. And this study also observed that if stakeholders are involved, most people are well mobilized and they tend to have very high turnout. And this has also been observed in previous studies. Now, in conclusion, therefore, this study notes that the community acknowledged that medical camps and free services are very important in bridging the gap to the services that they receive. It provides curative and preventive services to the marginalized communities, and it's a very important aspect with a very huge impact. And therefore, this study also acknowledged the challenges of inadequate resources, lack of stakeholders' involvement, and limited provision of services during volunteer camps. and volunteer motivation hinders the success of these camps. And therefore, in recommendation, this study suggests that to be able to maximize the impact of these volunteer and free clinics, we need to address some of these challenges like resources, stakeholder involvement, and widen the scope of the services that we would provide and motivate the volunteers. Secondly, and we also need to engage these stakeholders more early enough so that they are able to participate and motivate their people. This will maximize the impact of these medical camps moving forward. The second aspect that this study recommends is with regards to further studies. The study recommends that perhaps the use of quantitative approaches in vitro studies to gather data on the frequency and the patterns of service utilization in medical camps may provide richer data that will be able to augment qualitative data so that we have a better understanding of these challenges and the patterns of use. Secondly, this study recommends that we conduct a comparative quantitative studies across different regions to assess the utilization rates of KMTC, volunteer and medical clinics, what we call medical camps, and any other medical camps that are held to identify any variations between different contexts and different communities so that any intervention in future is tailored from the data. Now, having said that, this study declares that there was no conflict of interest other than us working as part of the KMTC and having provided some of these services. There was no any conflict of interest, and that this study was sponsored and funded by KMTC, for which we are very grateful. Thank you for listening to me, and these are the references, and thank you for listening.
Good morning, everyone, and welcome to this presentation. This study has been conducted by two individuals, lady staff of Makueni County Government working at Makindu Level 4 Hospital, called Direction Jane Buge, and myself, James Musovia, presenting in this conference. It's about utilization of post-abortion contraceptive among adolescents in Kibwezi Sub-County, Makueni County of Kenya. Clandestine abortions remain a public health issue in many of the countries worldwide, due to restrictive abortion laws. In Kenya, in 2012, 464,690 induced abortions were reported in a sample of 246 Kenyan health facilities. And 17% of these were among adolescents aged between 10 to 19 years old. And 1 in every 10 of these reported cases, there was a report of repeated induced abortion. And this reveals gap in post-abortion contraception. Justification: accessible and consistent use of contraceptive has the potential to reduce maternal mortality by between 25 and 35%. This according to WHO 2013. It continues and says, well-integrated post-abortion contraceptive services can reduce the mortality by a further 15%. And therefore, the results of this study can inform policies on adolescent sexual and reproductive health aimed at making contraceptive services more accessible to adolescents. Problem of the statement. Family planning, counseling, and provision is the most overlooked among the elements of post-abortion care. We have got quite a number of the elements. In Kibwezi East sub-county of Makueni County, adolescents have the lowest contraceptive preference rate of 2.6 in the entire county. An approximate 20 adolescents receive post-abortion contraceptive service every month, according to the sub-county records. And there's no documentation in existence on issuance of contraceptives to adolescents after abortion. Majority of adolescents are denied contraceptive commodities because they are single and below the age of 18 years. This is more of culture and practice. And Kenya lacks policies that comprehensively address post-abortion contraceptive among adolescents, according to the Center for Reproductive Rights in 2010. The research questions were, what demographic factors promote utilization of post-abortion contraception among adolescents in Kibwezi sub-county? How do health facility characteristics influence adolescents' use of post-abortion contraceptive in Kibwezi sub-county? And how does the perception of contraceptive among teenagers in Kibwezi East sub-county influence their use of post-abortion contraception? The broader objective was to assess the utilization of post-abortion contraception among adolescents in Kibwezi East sub-county, Makueni County, Kenya. While the specific objectives were to examine the demographic factors that promote utilization of post-abortion contraception among adolescents in Kibwezi East sub-county, Makueni County, to determine the health facility-related factors that encourage adolescents in Makueni County, Kibwezi East sub-county to use post-abortion contraception, and to evaluate adolescents' perception of contraception and how this affects the use of post-abortion contraception among these adolescents in Kibwezi East sub-county of Makueni County. The methodology, the study setting was Kibwezi sub-county of Makueni in Kenya. The design was a descriptive cross-sectional design where adolescents who had received post-abortion care services were sampled at one particular point in time and their data collected. Sampling techniques is that Kibwezi sub-county was purposefully sampled because it had the lowest adolescent contraceptive preference rate in the entire county, while Kibwezi East sub-county hospital was also purposefully sampled as it was the only facility offering comprehensive post-abortion care services in the sub-county as at then. The study participants were chosen through consecutive sampling as they sought for other services at the facility. So it was kind of a retrospective kind of a study. A study population, the adolescents who had received post-abortion care services in Kibwezi sub-county hospital, with the inclusion criteria being adolescent girls aged between 10 to 19 years who had undergone abortion and received post-abortion care from the hospital and who are willing to participate in the study. The exclusion were those adolescents who met the inclusion criteria but were unwilling to consent to the study. Fisher-the-Tal formula was used to arrive at the sample size. The population was less than 10%. Therefore, we went for the second stage of the formula. Key in this formula is that the proportion of the participants who took up the post-abortion contraception based on a similar study in Kisumu by McKenzie in 2018 was at 76%. So our P was 76% and our margin of error was 5%. So from the calculation, the sample size was 100 participants. So data collection, we used self-administered questionnaire, semi-structured questionnaires. So the variables were, the dependent variables, the utilization of post-abortion contraceptives, while the independent variables were the demographic factors, age, marital status, adolescence, guardian, level of education and income and religion. Health-related factors was another independent variable where we looked at the attitude of healthcare professionals, availability of long-term reversible contraceptives, and availability and use of youth-friendly services, and adolescents' perception of contraceptives like perceived benefits versus perceived side effects. Ethical consideration is that we sought and got permission from Makueni County government, reference given. Information, informed consent was also obtained from every participant interviewed, and high degree of confidentiality was maintained throughout the study. In results, this table summarizes the demographic factors which we compared with post-abortion contraceptive uptake and use. Like you can see, the guardian, whoever was in charge of these adolescents, was not significant in terms of their uptake or not of contraceptive. Same case to whether they had a source of income. But other factors like the level of education, as that when we interviewed them, the religion and the age of these respondents were significantly associated with the uptake for post-abortion contraceptives. This table, second table, is giving us a correlation between health system factors and the utilization of contraceptives. As you can see, whether an adolescent was cancelled on contraceptive during the post-abortion care was not significant, just the same as at what point they took up the contraception, be it immediately following the abortion or after some time. But other factors like their being knowledgeable and their awareness to whether there is existence of youth-friendly services in the hospital and their perception, so that attitude of the healthcare, and the question was asking them to describe how these people treated them. These two factors were found to be significantly associated with the uptake of post-abortion contraceptive among or in these adolescents. The third table is on the influence of perception of these adolescents and the uptake of post-abortion contraceptive. And as again you can see, their perception as to whether the contraceptives were beneficial to them in terms of reducing chances for unwanted pregnancy, whether they led to loss of fertility, and whether they also caused unpleasant effects, was not significantly associated with their decision to uptake or not the contraceptive, just as the benefits of the contraceptives, whatever they perceived were the benefits in prevention of pregnancy, in prevention of sexually transmitted infection, and also population control. What was significant here was the influence of their religion, in terms of utilization of post-abortion contraceptives. In discussion, age was a significant factor in terms of utilization of post-abortion contraceptive, and the use increased with an increase in age. And this finding correlated with a Kenyan study by in 2015 that observed that post-abortion care services use increases with age among adolescents. And another study in Ethiopia by Mekuria in 2019, which found that increased utilization of contraceptives increased with age. And this could be attributed to increase in level of knowledge and also exposure to contraceptives as age increases. Counseling on post-abortion care was also found to have a positive correlation with utilization of post-abortion contraceptive. And the more adolescent girls were counseled on contraceptives, the more likely they were to use post-abortion contraceptive. And this finding is consistent with our research on post-abortion family planning in Ethiopia, which found that women who received counseling were 25 times more likely than those who did not receive counseling to use a contraceptive method. The level of education as well as the religion had a significant influence on the utilization of post-abortion contraception. And this correlates to a study in Nigeria, which showed that a majority of Christians use modern contraceptive methods when compared to Muslims. And another study by Yusuf in 2014 attributed the low uptake of contraceptive among Muslims to the religious teachings, which discourage use of modern contraceptives. Presence of adolescent-friendly services also significantly influenced their provision of the services, and this could be attributed to premarital sex being considered a taboo in many African cultures. In conclusion, post-abortion contraceptive counseling, the level of education, the age, and the religion are major positive determinants of utilization of post-abortion contraceptives among the adolescents. And in this recommendation, we recommend that more girls need to be enrolled to school and complete the education, as this empowers them and broadens their mind on many current issues, including contraception. Religious leaders need to sensitize on teaching their followers on the importance of contraception to prevent unwanted or unplanned pregnancies. And the integration of reproductive services such that there is a clear link between post-abortion care and family planning services, specifically for adolescents. And in this case, refresher training on post-abortion care for healthcare workers, as this works to improve their attitude as well. Teaching sessions for the youth on contraception and available contraceptive services to help dispel myths surrounding the same. Thank you.
Okay, thank you, James. I think on that note, we have just about 10 to 15 minutes for Q&A. Just the questions could be so many. Just give a priority to one question that is of more importance to you. Then you can put the question down on paper. I think the researcher is here, and it is prudent that those who are presenting, you carry your questions and try to attend to them. So we might have maybe like 3-4 questions. Each should not go more than one question for the sake of time. We just have about 10 minutes for that session. Anyone with a question? Yes, we start with Manara Lucy.
Question to the first presentation. To attend to an engineering job. What is what's in school? And would you recommend contraception to be introduced in school? And my other question to the first presentation. Communication was a key, one of the key. Communication was a key aspect for the success of the COVID prevention during that time. So what can we learn moving forward for these other non-communicable diseases and basically our hospitals? So what can we learn about the lack or whatever was there communication in the other services, health services in the country?
So you note that down? Anyone? Yes, Chachi Lokumo, just one question, very brief.
Maybe to the last presenter, in terms of ethical consideration, now that there were adolescent girls, and maybe if you could expound more on how you went about ethical consideration, being that some of the participants were less than 18 years of age. So were they accompanied by the parent, or how did you go about the concept?
Okay, anyone? Yes.
One of your specific but your data, your design was descriptive cross-section. How then are you going to evaluate perception now that this is a descriptive? I thought this will generate qualitative data and not quantitative data. Thank you.
So I believe we are also expecting some participants who are online. Maybe as we wait for those questions, just one last person on board, just one, if there is anyone. Well, on that note, let's see what those who are online are following as that is being prepared. Presenter number 4, not number 4, the student. When you're reporting your data, give evidence. Give evidence, like when you say 25% was reported decline in blood donation practices. You need to give evidence. Is it from KDHS or from where that is etiquette of research? It's just a comment all the time so that we can rely on your results. It's just a comment.
All right. Online questions. One is to Mr. James Mogwe. Kindly explain why the donation cards are of no importance to the donors. Why are we students being brainwashed that the card comes in handy when a relative or even self is in dire need of blood? This is a discouragement to frequent blood donors like me. And then a question to Mr. Zachary Ombasa. Are the free medical camps part of the KMTC community social responsibility projects? If no, what is our objectives? What is our objective as an institution? If yes, what have we achieved?
So those are the online questions. We allow the presenters to attend to those questions. Please be as brief as possible and explicit in the matter of time. Who goes first?
Thank you so much for the opportunity. My name is Marcia Gutu from KMTC current campus. I'm standing in for our principal investigator, Mr. Kelvin Oruko, and the team. And the question on communication being a key aspect when it comes to handling various health issues. Our thoughts are, or rather my thoughts are that it's important because for us to be able to use the guidelines, the latest guidelines, then we need that information. So because the guidelines keep changing in the area of health, then it is important for everyone to be at par so that we are giving the best care and therefore having quality. Thank you.
The other question was for Mombasa or James.
Thank you. One of our followers has asked whether medical camps are part of the KMTC CSR. Yes, medical camps are part of what KMTC is giving back to the society for many reasons, including bridging the gap to the communities that we serve, that has given us students to be able to impact them in different ways other than training. Now, regarding what we have achieved so far, when we were going around collecting data from the volunteers and the opinion leaders in the communities that KMTC has reached, and as you are aware, KMTC has reached to almost every county because we have about 70 campuses as of now. So the communities acknowledged that those medical camps have really impacted the community and they have bridged the gap, but they want those medical camps to be sustained because they are a one-off event. So with regards to the statistics of how these services are utilized and how the numbers of the people that turn up, and I think that's what we recommended moving forward for a quantitative study to be able to have figures. So in the subsequent studies, we should be able to have figures to compare the different regions and the uptake of these services, because not all the areas have the same uptake of the services. This time round, we went to marginalized communities we may have to do a comparative study countrywide to be able to share those findings in subsequent conferences. Thank you.
So James.
Thank you. So there was a question on whether these girls were in school. 35 of these girls were in primary school, 38 were in secondary school, and 13 had were actually in tertiary level of training. So now the question here is whether the researcher would advocate for providing contraceptives to these girls when they're in school. And this is how I would like to approach this. We looked at these girls, they became pregnant in the first place. That was actually not what we are looking at. What we are looking at was after they procured an abortion, and after healthcare workers worked so hard to stabilize these young girls, probably after provision of the emergency care in terms of evacuation, in terms of control of bleeding, would there be need now that they are sexually active to provide contraception moving forward to avoid a repeat of the same? Because from our background and literature review, there is evidence, clear evidence that like 1 in every 10 of these abortions, clandestine abortions, is actually a recurrence, having happened some other time. So with this in mind, it would be prudent in our own wisdom that now that they are sexually active and we could have maybe less control, the advice would be we provide post-abortion contraceptives because they have come to hospital. They have sought services, post-abortion care services. And among the components of this post-abortion care is provision of post-abortion contraception. There was a question on ethical issues. And the question was, these girls were aged between 10 and 19. So who gave consent? If you look at WHO, in many of its publications on matters sexual reproductive health, at some point it says that we can also get consent from a minor when the study is aimed at providing information on sexual and reproductive health issues, that which is going to gain or provide more benefits to the subjects, more than harm to the subject. And it was on this basis that we went forward and interviewed this girl. Actually, if you look at the methodology properly, you'll find these girls, we did not interview them immediately they procured the abortion because of the stigma around them. But we targeted those girls who had come to the hospital for other services, and then the interview went backwards to see whether at some point in their lives that procured an abortion and what had happened. By that time, the assumption was that they had overcome the trauma and they were willing to discuss about the same. Then lastly, there was a question on the methodology. Kindly allow me to respond to this one after some moment as we continue with the conference. Thank you.
That's okay. The last one. How the questions been addressed?
There was a question on
questions for you.
Thank you. I'll be responding to the question from our online viewer concerning donor cards and why they're of no importance. In my opinion, I believe that that question was outside the scope of the current study, as different institutions of blood donation have different policies for what they do with the cards, what the card might guarantee you. And I feel like it would be better if a different study was done to focus more on the interaction of the donors at the specific sites as compared to answering it from this current study. Thank you.
So I think on that note, there could be some more questions. Please, you can put them to the researchers. You can as well keep posting them for those who are viewing us online. The questions will be addressed to the sake of time. Now, we have our keynote who is ready now to present for us online on the subject issue of enhancing universal care coverage through implementation of the primary healthcare networks. That able presenter today is Dr. Mohammed, who is the head of division, primary healthcare services and family medicine in the Ministry of Health. So we'll be following this presentation right away, and from there we will have an interactive session. So you're welcome, Dr.
Am I audible?
Yes, Dr.
Okay. Good morning, ladies and gentlemen. I'm honored to be in this meeting. I'm not found, I'm out in my master, but we thank these are one of the benefits of Corona. It us to online where anybody can present. Wow. So I want to take you on a brief presentation on the Department of Primary Health updates. Okay. So maybe we can proceed. I don't know who has the control on the slides.
Yes, we are working on the volume, Dr. Some minute we see there can be more people. We may go on now. We may go on. Yes, we can hear you clearly now.
Good morning once again. My name is Muhammad Mohammed from MOH, Division of Primary Health Care. I don't know who's controlling the slides, eh? Or am I the one to control it? Because I can't do it from my end.
Would you like if we control the slides from this end, sir?
Yeah, I would love to.
Okay. All right.
Because I'm trying from my end, and it looks like I'm not able to.
All right. Let's. We can also make you control your slides, which sounds much better.
Great. Thank you. Okay. That will be much. That will be great. That will be, yeah.
Okay, just a minute. We have our tech to make you the. Can you be able to share your screen?
Let me try to share screen. Just a minute.
Yes.
Just a minute. Let me try to share it first. Let me now try to share it.
We are now able to see your screen. We can see your screen. What we cannot perceive is your sound from your end. Probably you are on mute. He is actually talking. Dr. Can you hear us? We cannot hear you from your end. We can see your screen, however, we can't gets to hear you.
Can you hear me?
Yes, we can hear you now.
Oh, you can hear me. Thank you. Thank you. Okay. Yeah. So I'll just take you through this brief presentation on updates on primary healthcare in the country. Okay. So primary healthcare is clearly you can see is an essential healthcare made universal, accessible to all individuals, acceptable to them through their full participation and at the cost they can afford. Individuals, household, or community are the core of primary healthcare. You have to bring them on board for you to have it. Well, UHC clearly is affordable, accessible, acceptable, available, and high quality health for all Kenyans. So primary healthcare, they came to realize that it's the only gateway to primary healthcare. As you can clearly see during the Alma Ata in 1978 and the Astana, the accompanying vision they had was actually for primary healthcare in the 21st century, and of which the countries made commitment on that, and they came up with concerted efforts to orient all our health system towards primary healthcare so that we can achieve universal health coverage. And a vision of primary healthcare in 21st century, it emphasizes on comprehensive PHC. When I say comprehensive PHC, there are things of comprehensive PHC. Number one, we should have health in all policies. That is or multi-sectoral action. Number two, empowering of individuals, families, and community. And the third one was actually integrating health services. So what was the vision? The vision of our division is a health, productive, globally competitive nation. The mission is to ensure progressive, accessible, affordable, resilient, responsive, sustainable primary health services of the highest standard for all Kenyans. Our goal is actually to improve coordination of care to ensure patients receive the right care in the right place at the right time and at the right level. So what are our mandates as a division? Our mandate is number one is to develop policies, legislations, guidelines on primary health care services and family medicine. Is to set standards and quality assurance for primary health care services, referral system and family medicine. Is to give technical assistance and capacity building support to counties on primary health care services and family medicine. Conducting research to improve primary health care services and family medicine. The other one is partner coordination and resource mobilization. So what our achievements as since operation under the Department of Primary Health Care, Primary Health Services and Family Medicine? We've developed policy documents to guide implementation of primary health care in the country. The first one we developed was actually the Kenya Primary Health Strategic Framework 2019-2024. And we actually costed this primary health care framework. The other one we developed was the Primary Health Care Network Guidelines 2021. And we also developed an advocacy, communication, and community engagement framework for the primary healthcare in Kenya, 2021 to 2024. We were able to disseminate the primary healthcare policy documents to counties in clusters. That was on March 2021. We also provided technical assistance to counties to institutionalize primary healthcare through setting up PHC department, and of which most of the counties currently they have what we call the PHC coordinators. So PHC as a driver for UHC, universal health coverage requires a strong primary health care that should be attained through number one, increased community coverage of community health units. And as a country, currently now, I think we are at 100. We were able to achieve that. Improving primary health care facilities to provide integrated, coordinated, and quality health care. And through PCN, we're going to achieve the second bullet. And ensuring multi-sectoral engagement in healthcare. when I say multi-sectoral engagement, we have what we call the social determinants of health. So when it comes to health, we need to pull everything so that we can move together. So why impact? Why PHC? What is the impact of investing in PHC? Number one, it will give you high quality, low cost of care, and cost-effective care for people and communities. Number two, it supports more equitable distribution of health and reduces the healthcare inequities in populations. Number three, it serves as an early warning mechanism or an early warning indicator in case there is a disease outbreak before it becomes an endemic. We can preempt it. And number four, PHC clearly empowers individuals, families, and community to be active decision makers about their health. Yeah, and lastly, it improves health through access to more appropriate services. So the targeted investment in primary health care amplifies efforts to improve health in continuum of life from birth to age. Guiding policies, this is what is guiding us. Clearly, you can see the first column, actually, it's the Kenya Constitution talks about primary health. The Kenya Health Act talks about it, and the Kenya Health Policy actually talks about it. So we have the Kenya Human Resource for Health and Standard that guides us. We have the Scheme of Service for Community Health Services Personnel, of which we actually revised it. It's actually in the Public Service Commission. We planning to launch it soon. And the last one is the Universal Health Coverage Sustainability Financing. We have the Kenya Primary Healthcare Strategic Framework. We have the Primary Health Care Network, and we have the addressing the social determinants of health. What is the status of primary healthcare services in the country? You can clearly see health facilities. The density is 2.2 facilities per 100,000 population. Approximately, we have 7,240 primary healthcare facilities, of which 50 to 60% is actually government owned. PCN established so far, we've established 18 PCNs, and we have a mandate of having 315 PCNs in the country. And when I say 315, I mean every sub-county in this country must have a primary care network. When it comes to health product and basic equipment, the mean availability of basic equipment is 77%. Health facilities with all basic equipment is 24%. So essential medicines is at 44%. Dispensary on average with essential medicines at 7%. When it comes to HRH, which is the core, the pillar of health, we are at density, we are at 1.38 per 1,000. And clearly WHO says we should be at 4.45 per 1,000. So we are still behind in that. So we are targeting the 4 paradigm shifts. Clearly you can see on the left, there is the current state we are in and what we are projecting. You can agree with me that currently we are so focused on curative approach. Curative approach, we don't even do screenings the way we're supposed to do, but we're supposed to go to preventive and promotive approach as opposed to curative. Okay. Non-comprehensive and vertical services. You can clearly see we have a lot of, okay, for example, the services we have, they are non-comprehensive, they are vertical. You can have a lot of implementing partners, for example, who are in one county, but they are different partners, they are doing different things together. But with primary healthcare, when you go to PHC, we like to do it a comprehensive and integrated services. Whatever we have, we just make everything a one-stop shop. Yes. We have fragmented primary healthcare services. If we even go down to the counties and everything, you can see facilities are close to each other, but they don't communicate on what they do and everything. So patients, it ends up patients being self-referral to themselves. That's why you go to most of our facilities now, you see For example, you can go to Nairobi, Mbagathi, Mama Lucy, or any other county referral hospital. You see the patients who are there, majority of patients who are there, almost 76 to 80%, are patients who can be seen at the lower facilities, level 2 and level 3 health center and dispensary. Yeah, and that's why now we want to move towards primary care network services, which will strengthen delivery at all, from sub-county hospital, level 3, level 2, up to the community level. Currently, we have non-sustainable financial support, but with PCN, we're going to have a resilient financial support. So what is the goal of all this? The goal of all this is to enhance preventive and promotive care to reduce demand on healthcare commodities. I'll give you a snap view, but we've updated this. This is about our current set of community health system in the country. When you look down there, you can see community healthcare workforce. We were at 94, but currently now I think we are at 100%. I forgot to update this one. It's a community health unit coverage is at around 94%. What we are lagging behind is on the community health assistants or community health officers, who are the supervisors of this community health unit. We are at 34%. Okay, and maybe to explain to you, is someone asking a question? Okay. Am I still audible, please? Yeah, okay. Yeah. Clearly,
go.
Yes. Okay. A community health unit is supposed to cover a population of 5,000. And we believe a household has 5 people. So that will be 1,000 households. And each community health unit has 10 community health personnel. What do you call it? Practitioners. Yeah. So 10. So each community health person will have 100 households. I started from this because this is a pillar of PCN. It's a pillar of PCN because this is our first level, actually, the community health units. So I'm taking you through the PCN now. PCN is actually an administrative health region comprising of primary healthcare referral facility, that is the hub, and the spokes. The spokes is actually the level 2s and level 3. Okay. And when I say we want to implement this thing in every sub-county, we want to make the sub-county hospital to become the referral, which is the hub, which is the level 4. So the referral hospital becomes the hub, and all other facilities that within that sub-county becomes the hub. Yeah, you can see the hub is actually the level 2, the health centers and the dispensaries, and you can see the bottom of the ring of this graph is actually the community health units. So these community health units are linked to a level 2 or a level 3. One thing you have to know, these community health units are linked. They have households they take care of. So they have the data of the households. So they are linked to a specific dispensary within that region. So the patients will know that if they are sick through this community health unit, this is where you're supposed to attend. This is where you're supposed to go to. And like before, where patients just move anywhere. So we have different dispensaries, different health centers below there. So we link there with the network. You link as this community health unit to actually the spoke, which is actually a health center under dispensary. Yeah. So the patients are seen at this level. Yeah. And when you see the hub there, in the middle, we have what is called multidisciplinary team. You can see the arrows up there that shows there is upward and downward referral. So the services that are not at this level 2 and level 1 is being brought down. We believe in equity. A patient who is at level 4, the services get there, he should also get it at level 2. So how do they get it? Is by making sure that the multidisciplinary team, which comprises from the sub-county team, multidisciplinary team, will be moving down. It's more of an outreach sort of. If a patient is diabetic, if a patient is hypertensive, there's no need of this patient to go to this referral hospital because, okay, we incur a lot of expenditure when it comes to health, out-of-pocket expenditure because of transportation and all that. So with primary care network, we bring the services down to the people. So the services that are not at this level, the multidisciplinary team will bring it down. Whether it's medical outpatient clinic, if a patient is diabetic, if a patient is hypertensive, should be seen at these facilities. The multidisciplinary that comes down, whether it's lab services, the multidisciplinary bring the lab services, it is drawing blood for patients, taking it to the hub and relaying back the results and everything. Yeah. Okay. So what is the goals? What is the goal of PCN? Is to increase efficiency and effectiveness of health services for patients, particularly those at risk of poor health outcomes. What is the main objective? Is to improve coordination of care to ensure patients receive the right care in the right place at the right time at all levels of care. All levels of care. What is the purpose? To lower cost of health care for individuals, in families and community, improve patient experience, and also improve the clinician's experience. So what is the purpose? What's the purpose of primary care network? Number one is to foster integration of care across all levels of health, whether it's from the community level up there, you foster integration. Improve efficiency of the health system by providing care at the optimum level. When I say optimal level, I mean the lowest level a patient should receive. There's no need for a patient to travel from here just because of a services. The services, with PCN, the services comes down to the patient. Okay. Then ensure no one is left out. To have an efficient referral system, both upward and downward. When I say upward is referral. A patient cannot be seen at this level, can be referred to a certain level. And when I say downward referral, is the services that come. Yeah, goes up to the community level, where screening and everything can be done at the community level. Yeah. So sharing of resources across all levels of care. It improves data flow. You believe me, if you want to find out how your patient is, you can easily know from your SPOC, from your hub to your SPOC. You can follow. You can know this patient comes from here. It's this community health unit that referred this patient. You can follow. You can even do household visits and for better decision making. So we've already, with the support of implementing partners, we were able to implement 18 PCNs in the country. I forgot to update it. We have 18 in the country. With support of implementing partners, like UNICEF actually helped us. We started with one in Kisumu, but Kisumu has moved now. They have the 4 PCN. Kisumu has 7 sub-counties. So, and they already have 4 now, but they are projecting by the end of the year, before the end of the year, they're gonna implement in the other 4 sub-counties. Garissa has PCN in all its sub-counties, okay? It's the county in the country that has PCN all across. Busia has 1 sub-county, Kilifi has 1, Samburu, Pokot 1. We also did with the World Bank project. We actually sensitized 5 counties, that is Makueni, Mombasa, Kakamega, Marsabit, and Nakuru. AMREF supported us in implementing in 1 sub-county in the coasts, that is Kwale, that is Lungalunga. Yeah, the others we are still doing inception meeting, and the good thing, the Ministry of Health, Kenya Kwanza government is actually focused so much on primary health. Umesikia afya bora mashinani. So we are actually on a high-speed mode to implement in all other remaining sub-counties. So that is that. So what is the criteria of establishing a PCN? You must have 1 level 4 facilities, that is a sub-county facility. When you have that one level 4 facility, that should be your hub. Then you have the others. The other, when I say the SPOCs, which are actually depending with the level of your sub-county, all the dispensary that comes under that sub-county now becomes the SPOC, and at least a community health unit per 5 community health unit per facility. Yeah. And also there's evidence of public-private partnership to establish between county government and private sector. As a case in Kisumu, when we started, we actually started in Nyando sub-county, and in Nyando sub-county, there's a facility that is called Awasi Mission Hospital, and Awasi became one of the hubs also. So, yeah. So what is the criteria of establishing a PCN? Clearly, when you establish a PCN, geographical and distance determine how you're gonna establish your hub and spoke. We want to simplify life for people. We don't want to make it hard. For example, if you want to link a community health unit, you should link this community health unit to a facility that is very close to them. It doesn't make any point for me to refer you to a facility that is far away when you have one that is close, okay? So geographical area determines, because by the end of the day, we want to make life simple and not complicated. So you only link the community health unit to the spoke, or the spoke that are close to them, and the hub equally the same, okay? The population size to determine the number of levels of community units. Clearly, you might go to a place that is densely populated. You can't dictate that it's supposed to be this amount only. Well, you can go to other places like Garissa, where you see the population is scarce. You can't say that one community health unit should serve 1,000 households. It might not get. So it depends with, I believe, different scenarios give you, different areas gives you different scenarios, yeah. The other thing is availability of different cadres of human resource. As I clearly say, you need multidisciplinary team. And what the component of multidisciplinary team should have a doctor, a nurse, the sub-county level, a clinical officer, lab personnel, you know, yeah, a farm tech or a pharmacist, okay? So you should have all those cadres available before you start. So availability of adequate financial resources to support the establishment. Then you can't say you start PCN when your equipment and supplies are not in place. So you have to, you also have to make sure that the equipment and supplies are there, and functionality of the facility health services. So what is the process? As I told you, we established 18. The process we did was actually first to establishment of the governance and coordination structures. When we go to a county, the first thing we do, we sensitize the county leadership. Then from county leadership is them to pick the sub-county they want us to implement on. So after they pick the sub-county, we do what is called, we conduct a baseline survey, assessment of community health need, facility, and you know, and partners, you know. With this, when I say baseline survey, we look at all the pillars of primary healthcare. We look at leadership and governance. We look at health financing. We look at health product and technology. We look at HRH. We look at service delivery. All those. Okay. Then after doing the baseline survey, we do the mapping of the hub to serve as a population in a defined area. Then mapping of the spokes and the community health unit and link them to the hub, okay? Then mapping and registration of households, taking into account health profiles of each household. That is normally done, it will be done by the community health unit. And as you clearly know, we are actually launching what is, sometime this month, June, we are launching what we call the EKIS, Electronic Community Health Information System, okay? Yeah. So identification of financial requirements to establish a PCN, then gazettement of the PCN, setting up a monitoring and evaluation system to monitor the PCN. So financing of PCN structure by itself is meant to encourage funding and support to the primary healthcare. Okay, so for success implementation of PCN, the hub will need to be cognizant of health financing principles, of resource mobilization and pooling and strategy. Yeah, so like the funds that are there, national government equalization fund, conditional grant, counties, like counties, what we are trying to do, we are trying to come up with a bill that is called FIF bill, Facility Improvement Fund, whereby we want primary facilities, whatever they collect, made up from NHIF, from what, they retain it and they use it at that facility level. So long as you have good leadership structures in place, yeah, community participation, yeah, I believe, yeah, that is it. So we've done costing estimate of operationalization of PCN, where we came up with 4 scenarios. We said we set up PCN from zero investment, assuming that we don't have health facilities, assuming that we don't have healthcare workers, assuming that we don't have equipment and everything. We costed it at that. Then costing the second scenario was costs of setting up a PCN based on needs, that is gaps, the incremental cost. Then the third scenario was cost of setting up a PCN, assuming the current HRH and infrastructure is adequate. And the fourth one is, of which I believe is where we fall all of us, is cost of setting up a PCN, assuming HRH, commodity and supply and infrastructure are available. Yes. Asanteni sana.
Well, thank you so much. Thank you so much, Dr. We applaud you for that good presentation. And from this end, we want to appreciate the intense message that you have communicated to the audience, both physical and online. And I believe the pertinent issue that I've discussed is touching more on trajectory towards Vision 2030. And I will be allowing the congregation, both online and physical, to maybe put on some comments as well as some questions, which maybe you can be able to address if you're able, sir. Before I give that, mine is just on this proportion of 34% in terms of the quantitative value for the primary healthcare workforce. Talking of Almata and Astana, what do you perceive could be now the differentiating factor between Almata and Astana? What differences are there that we now want to address from 2018? And now looking at the key area of this proportion of that 4%, we are moving towards 2030. When you talk of funding the healthcare units in terms of the costings, the ones which have zero investment, the ones that are already working, where do you think the healthcare workforce, which is now talking of community health promoters at the primary healthcare level, relative to the training institutions like Kenya Medical Training College? We understand that most of the students or young ones across the country, not everyone is able to afford the tertiary level education. Do you think that could be the gap? Probably economic strides are making parents not be able to cater for the children to go to pursue the same courses. What do you think the government can do in terms of fortifying this? For example, like picking a huge proportion of these willing students to come and pursue the same. Looking at this 34%, we are still very far, and we are talking of 8 years to SDGs. Those are comments or questions, maybe. What do you think? What is your take on that? And then I give back to the congregation and the online viewers, if you have any comments. I don't know if you want to address one by one, or you can put them together, then you address them after. Daktari, are you with us? Yes, we've lost you. We cannot hear you from this end. Francis, are the systems working okay from this end? I just want to explain.
Yeah.
Daktari, are you online? Are you with us? We tend to be losing you somehow. maybe network or connectivity issues, probably you can try to adjust kindly. Well, in the meanwhile, the communication you can be, for those who are online, you can be posting your questions. For those who are physical, you can find a modality, or now you can share the questions as you wait to see whether the Dr. will be able to connect. We can see you, however, we cannot be able to hear from your end.
Hello.
Yes,
I'm struggling. I'm really struggling here.
Sorry about that.
Yes. Can you hear me?
Yes, we can hear you now. We hope you will not. We hope it will be smooth. We can hear you now. Kindly.
I even lost you, but your question I did not hear it because
I can repeat it if you can hear me. Can you hear me from your end?
Yes, I can.
I will be very brief. I will be very brief. I was just looking at a pertinent issue of this Alma Ata and then again Astana, the Alma Ata of 1978 and then the Astana of 2018. As a country, what is that differentiating factor between 1978 and Astana of 2018? What is that we are not able to address as a country now based on your knowledge? And again, we talking of this that 4% proportionate coverage in terms of the healthcare workers at primary healthcare level. We are talking of SDGs Vision 2030, which is just next 7 years. Do you think we'll be able to optimize that to 100%? And when you're talking of funding units at the primary healthcare level in terms of infrastructure and what have you, what of the human resource for health that are actually trained purposely for that? And that's why I was asking, do you think approaching trainer institutions, for example, like Kenya Medical Training College, to fortify that, not because we cannot train those numbers, however, the guardians or those who are taking care of the school fees might be compromised. Do you think the government from your end and the Ministry of Health could give that proposition whereby they can enable KMTC to increase that number in terms of KMTC putting the structures in place, and then the Ministry of Health try to do some kind of funding for the students who are not able to fund themselves? That was a comment, stock a question, Dr.
So Alma Ata, from Alma Ata to Astana, clearly what was there was we were not able to achieve when it comes to it completely. So, but with
we have lost you again. Sorry about that. If you can still hear me, Dr. Can you hear us from your end?
That's no problem. We'll be using that's wrong. So maybe it's
so members online, you might continue posting your questions. We hope we'll be back online from our keynote speaker.
This one.
So you may continue posting your questions, and we prepare for the next plenary session. We might be getting in touch with Dr. Mahmoud. He seems to be having some technical issues of connectivity as he has dropped off. However, that session is very crucial to address the pertinent issues that we are discussing, especially for primary healthcare and where training institutions would come in. Because when you look at the number of 34%, and we are talking of achieving 100%, the question should be, how long has it taken us to get that 4%? We should be able to do further analysis and see whether we'll be able actually to reach there. And if we cannot reach, what is that we are doing and what is that what we are not doing? So we need to start putting up some mitigation measures. We hope that the Dr. will be with us. So in the meantime, I think we should be expecting session 4 to start with a plenary session on healthcare financing. I bet I should be letting this to the next chair. That should be Dr. Chibichi Maswani, co-chaired by Dr. Agaki Gishero, and the rapporteur is Caroline Oyugi. So you can start preparing yourselves, and if there is any further communication before we start having the transition stage, we need that to be communicated on time. So,
yes, Chair.
Yes.
When it comes back, we should now be asking the questions, because for me, I hit a question here.
Yes.
For Daktari.
Yes.
Now that he has gone away.
Yes.
When he comes back, will I be allowed to ask the question?
Yes, you'll be allowed to ask the question.
I'm really interested.
Yes, you just put down the question. We'll try to locate him so that even if it's after this session, because I know he's struggling and I know he was ready for those questions. These are very key area, and he has not addressed any of the question. He's tried to address my question and then he dropped off. And I understand for a keynote speaker, that is what is most important. So we wait. You will be able to ask that question. For those who are online, you can continue posting the questions and we'll be recording.
Thank you.
Yes.
No, we asked them to bring next.
This PhD was committed. When we made that from the time go, from the time you are doing that. When you were trained in 1988, 87, that's the time when I've been trained. And these activities we were doing, was changing. That's when our community-based healthcare. That's going to community health street network, network. It's going to network as an approach. Whereas what I've changed to what I'm going to train.
What have they realized?
Yes,
so that they increase the capacity.
Yes, and that is
when you're online with the capacity issue, yes, then it should come out clearly.
Children. Papaya. Papaya. You notice I want to buy. I'm trying to get out of the she's okay now.
Okay.
She's on.
Good morning, still good morning. Good morning to all participants and welcome to session 4 of this scientific conference. The theme is for this session 4 is healthcare financing. And we'll start with a plenary presentation on social healthcare financing, benefits and challenges by Dr. Isabella Maina. Dr. Isabella Maina is a public health specialist with a bias towards health system strengthening and management. She has a keen interest in implementation of the universal health coverage agenda and health reforms in general. She's an accomplished and resourceful person with extensive experience in healthcare programs, management, and leading various aspects of health systems to enhance performance. Isabel has extensive experience in health systems planning, health services organization, public health programs, design and execution, organizational systems transformation, health financing reforms, monitoring and evaluation within the health system in Kenya and beyond. Isabella looks forward to a time when the world shall have no communities left behind. Welcome Dr. Isabella to give her presentation. And at the end of the presentation, we'll give all our participants an opportunity to interact with our presenter through asking questions. And without further ado, welcome Dr. Isabella Maina.
Okay, so thank you very much for that introduction, Dr. Maswan. I hope you can hear me. Please confirm that the PowerPoint can be visible from your end.
Yes, it is. It is visible.
Fine.
Hopefully
All right.
Online.
All right. Thank you. Thank you very much. So I'll take us through social health insurance. The topic of the day is the benefits and challenges. I have titled it Key Considerations, but in those key considerations, we shall be seeing the benefits and challenges as we discuss. It is a general presentation, but then each of us as participants will try to adapt and tailor it back home. For example, in Kenya, we may think of the NHIF as we discuss the key considerations of social health insurance. And basically the health agenda, the health financing agenda in the country, for example. So the first slide is to welcome you, and I have 10 key questions that perhaps will show us where we are in terms of social health insurance and the key benefits and challenges thereof. So the first question is obviously what social health insurance is. I know the topic on the program is social health financing, but insurance is a way of health financing. So if you think of health financing, there are various mechanisms of health financing. Social health insurance is one of them. You could also finance health through tax. For example, what we get from the exchequer, that's through the budget lines that we get from Treasury. We could also finance health through the private health insurance. We have Britam and the rest, UAP. We could also finance health through community insurance. We have people coming together in the communities and they contribute towards health. The many Harambes that we also have. We could also finance health through the out-of-pocket payment. So the social health insurance concept arose from, the self-help groups that people have. For example, ladies are good at having the self-help groups. Then group insurance, people in the same occupation coming together to contribute towards insurance for their health. But then the concept then developed to just not consider the people in the same socioeconomic background, but bring other groups of people. So when you think of social health insurance, you're thinking of different groups people from different socioeconomic status. That is a mix of the rich and the poor, so that the rich are subsidizing the poor. You have a mix of the sick and the healthy, so that for me, if I'm healthy and I'm contributing, then I know that I'm subsidizing those who are sick. We have a mix of the formal and informal sector. For example, in Kenya, for all of us here are in the formal sector, but we also have our mothers and our grandmothers who are in the informal sector. And the little that they contribute, we also want to subsidize them with what we are contributing for some of us who have some sort of paycheck. Then the young subsidize the old, because we know that the young persons, they rarely anyway get sick. They do, but rarely. But we know when we are the age in which we are in, then the risk of falling ill is very high. So then that risk is then reduced by, bringing everyone together. Not reduced, but risk pooling. We pool together, the old and the young and so forth. And the goal is to improve people's health with financial protection. So financial protection here means that you do not fall into the risk of, becoming more poor, or the risk of going into poverty as you seek health services. So we want you to be protected, so that as you're seeking your health services, that does not drive you into poverty, or for those who are poor, does not drive them into further poverty. And the idea is that health insurance is not meant for, making profits. So what can be done with social health insurance? What are the benefits? We know currently in Kenya, for example, the financial protection does not cover everyone. We still have a lot of people who are paying for health services through out of pocket. So the idea is, how can we expand the protection to everyone? And then we've already talked about risk pooling and cross subsidy, so that, the sick are subsidized by the healthy, the young and the old. And we have seen that on the formal and informal sector. And then the principle involves compulsory contribution and membership across all the population. Right now, as we are in the country, for example, we have mandatory contribution for the formal sector. I know the NHIF Act was passed so that it is mandatory for all to contribute. But perhaps, enforcement to make sure that those in the informal sector are also contributing, because voluntary contribution is not sustainable. I'll contribute today and not contribute tomorrow. But then for us to have a successful social health insurance, we must have some critical areas to look into. One is stable economic growth, contribution according to the income level. And I'm sure for those in Kenya, you have heard about graduated premiums, where people will contribute on the ability to pay. You contribute on the ability to pay, but then when it comes to accessing the services, you access the services based on need. You are not denied because you contributed less than the other person. The contribution is on ability to pay, but then you access service based on the need. Then we must make sure that we have a viable contribution collection system. So if, for example, you're collecting from the informal sector, and informal sector are diverse, there are those who are rich, there are those who are very poor, there are those who are in the middle. You have a system for collecting from all those people. For the formal sector, easy because it's paycheck, it's payoff from the paycheck. But for the informal, then we should have a good system of collection. Then distribution of the population, then we must know how is our population distributed? How is the economic status? Who is in which quintile, wealth quintile? So that if you are having graduated premiums, then we know who should be paid for. For example, the very poor, who should pay a certain amount and who should pay more than a certain income group because it's graduated. Then ability to administer the pooled funds. So you'll have lots of funds. And of course, we have NHIF that is pooling the funds right now. If you think of NHIF as our social health insurer, and of course, stewardship by the government. The next question is, how will social health insurance contribute to our health system's objectives? because in the health sector, even KMTC is leading us on this conference. Our health system goals is to ensure that people are healthy, is to ensure that we have equity, is to ensure that we meet people's expectations. So how does social health insurance contribute to that? So the question then we need to ask ourselves is, how will it help us improve the health of our people? And of course it does, because of, reducing the financial barriers. If I'm unwell and I do not have the necessary resources to seek health services, I'm likely to stay at home. So therefore, impoverishing me in terms of the health status. So the earlier I get that financial access, the better, so that I'm able to seek services. And you know that when somebody is healthy, how that happens with economic development and so forth and so forth. Then in terms of reducing inequalities, being responsive to people's expectations, people expect to us in the health sector to meet their needs, for example. And of course, fairness in financing, we've already talked about contributing on the ability to pay graduated premiums, so that all of us are not, to give an example, are not contributing 500. If I am, let's say if I'm a housewife, I'm contributing 500. Dr. Maswan there is working as a lecturer in KMTC and is also contributing 500. It means in terms of ratio contribution, I am contributing more as a housewife. So we need fairness so that Maswan contributes based on her pay and so forth. I don't need to go through this, but one of the key challenge is that even as we think about social health insurance, then how do we then ensure that these other services, the community health services, the primary care services are taken care of? There are those public health or population-based services that happen outside the health facility. Because your social health insurance fund, for example, NHIF in this case, will pay the health facilities. But then we know that there are many, many other health services that happen within community. So we must then think about how these will be funded, and we shall see that in the subsequent slide. So does social health insurance necessarily raise additional funding for health? That's the other challenge that we need to think about. Well, it's a benefit and a challenge at the same time. And the caution here, yes, it does raise financing for the health sector, but not necessarily additional financing, because it depends on when people pay. You may pay today and then it's used up, depending on, the need of the people. Sometimes when you have a social health insurance, then the allocation from the exchequer then is reduced. So it's counterproductive. So it's quite a balance. And therefore, the idea is not to see social health insurance as a source of funding. It is a source of funding, but it is not necessarily that you'll have more funding to the health sector. So the exchequer still needs to continue funding the health sector. And we have examples from out there where you have people contributing in other countries, but also Treasury, their Treasury or Ministry of Finance or the exchequer still continues putting money into the health sector. So the next question is, are all stakeholders in support of social health insurance? Another benefit and also challenge to tackle as we talk about social health insurance. And well, this it's dependent on varying interests. For example, employers, the impact is on their wages. For example, if I own an industry and I have to contribute for my people, the impact is on their wage. If people have to contribute, they are likely also to negotiate for higher wages. For employees and unions, of course, the impact on the benefits. For partners, most of them have divergent views depending on their interest. If it's the civil society organization, their interest is that there's inclusion of communities that may be left behind or the vulnerable groups. If it's the private sector, for example, the private insurance, you can imagine their interest. So basically, the interests are diverse. Of course, the government, the interest is to see that people are protected and that they're able to access the necessary health services. So basically, there is need to build consensus and support from all stakeholders anytime that you talk of social health insurance. And I'm glad that in the country currently, I think there's a lot of engagement with the NHIF and the government as well. The next question that we need to ask ourselves, so it is social health insurance anchored on which law? Is there a legal framework to operate within? And the legal framework basically is to define what would be the structures, what would be the governance structures, what are the governing principles, how will the resources be managed, who will determine the benefit package. And the benefit package here is we contribute what are the services that we are entitled to. So for example, we are contributing to NHIF. So what services am I entitled to when I go to seek services in a hospital or all the way from, the community? Even NHIF is covering community health services, may not cover, and we shall see maybe the reason why. Then how do the health insurance agencies, for example, now the Social Health Insurance Fund, interact with the contributors, that is you and I, and the beneficiaries and the service providers? How do they interact with the hospitals and all that? And we need a legal framework to define all these. Luckily for us in the country, we have guiding frameworks. We have the health policy, we have a UHC policy, we have a health financing strategy, but more importantly, we have an act of parliament, the NHIF Act, in 1998, and we are all aware that it was amended in 2022 to include the issues of mandating insurance and other reforms that were included in that amended act. The next question is, are revenue collection procedures technically feasible? So we are talking of collecting from everyone. Collection procedures, are we able to do that from all the members, especially bearing in mind how informal we are, how our, we have more of the informal sector rather than the formal. How do we register members? How do we distribute the membership cards if necessary? I understand from NHIF right now, it's not about cards, it's about biometric registration. But then how do I reach my mother, my grandfather, and so forth in the village to ensure that I register them and also do their biometrics? Then how do we collect contributions, especially for the informal sector? The employer contribution, if the employer, for example, is matching what the employee is contributing, how then do we contribute that, collect that? Government subsidies, for example, right now we have subsidies for the poor and vulnerable population. We have subsidies by the government for orphans and vulnerable children household that go into NHIF. How will that be collected? They are being collected, yes, but these are just general questions. It is happening in Kenya, but I'm raising this to just provoke and just look at the system we have as well in the country. How do we identify members who require subsidies? If you go to the counties, if you go to the villages, have we taken care of all the members who require help? Or are we helping those who may not require help? This is another question to ask ourselves. I know there are people who are registered through the Department of Social Protection because they have the mandate of identifying the people who need subsidies and so forth. Is contribution going to be through taxes? Because you can say, you can decide that contribution is mandatory, ensure that everyone is registered, but then instead of me contributing through from my pocket to maybe pay the premiums, you say we'll get taxed and then the tax will contribute, the exchequer will then contribute on behalf. So you're indirectly paying your premiums. So you pay the tax and then the money is paid to the social health insurer for everyone. So, but then in the country, we know that The government is financing for example, the poor and the vulnerable, and the rest of us are contributing our respective premiums. The next question then to ask again, are the physical and intellectual resources available to set up the social health insurance organization? So you are talking about the social health financing. We have talked about the legal framework, but then who is this organization then that will be doing all these functions? In the country, again, I keep giving the examples. We have NHIF. So you need an organization that receives the funds, it pools the funds, and then pay out the funds to the provider. So NHIF is already doing that. We pay our premiums to NHIF, they collect from the informal sector, they pool those funds together, and then once I receive a service from a hospital, Kenyatta, Aga Khan, whoever is contracted by NHIF, then NHIF is able to pay. The next question to ask is that fund or that organization that is doing that, do they have sufficient personnel and office buildings? Do they have solid procedures for handling health insurance funds to oversee its own operations? Do they have a robust health information system, especially in this era of digitization? Instead of being analog, again, we have systems. We are talking about biometrics registration. I know NHIF is implementing the e-claims. So the issues of linkages of NHIF, of the social health insurance fund system, even to the providers. And here the information system, it's not just on the social health insurance fund organization, but also to the providers themselves, so that then there's interoperability. Yeah, so the next question are, so do we have the requisite resources to set up the social health organization? For us, anyway, here, it's just a general question, but I think we already have an organization. But then the main question we ask ourselves is that, should all the roles be performed by the same organization? For example, defining the benefit package, the insurance benefit package, who should do that? Deciding the provider payments mechanism, how, for example, Kenyatta Hospital is paid by NHIF, through which method? Is it capitation? Is it fee for service? How much? Then who should decide that? Then investigations, should there be any complaints from the users? Should there be any complaint of malpractice, for example, the fraud, either not necessarily from the insurer, the fund, but also from the providers, from hospitals, from the practitioners themselves? How should those be investigated? Then negotiating terms and conditions and contracting of providers. And in our system, we have lots of stakeholders who are involved in all this. For example, we have KMTC, it's involved in accrediting health facilities. It is involved in investigations. For example, if a practitioner, for example, if it's a doctor with a certain malpractice, KMTC has a role. It's a nursing council, it's a nurse, you know, all the regulatory bodies and so forth. So it's a whole concerted effort by all stakeholders. But the question here we ask is, we are asking here, is then how we work together to ensure the success of the social health insurance, including ensuring that we have defined very explicit benefits or entitlements for the members of the social health insurance fund. Question 8, I have 10 of them, so at least 3 more slides to go. What would be the benefits? What benefits will the SHI members be entitled to? I think I've mentioned a little of that. The question is, so I am paying my premiums into the social health insurance fund. You and I are also paying. The other people, Anjiko in the country is also paying. What then is their benefit? So the idea is to look at the depth, that is the range of services. So are we looking at the whole range from outpatient, inpatient, from services to address the communicable conditions? We know now the NCDs are on the rise. Are we looking at the range of services to also address the NCDs? Are we looking at the range of services in terms of preventive, promotive health services, curative health services, diagnostic, rehabilitation, and palliative care services? So that is something that needs to be considered. And I know NHIF has a very comprehensive benefit package that is currently looking at starting even from prevention, including screening services, all the way to taking care of the NCDs, evacuation, and so forth, ICU services, and so forth. And also then look at the height of those services, of the benefit package, and that is the total costs covered by the insurance. So that again, you don't have a benefit package, but when you go to the facility, you have to pay a huge chunk of the amount, while probably the social health insurance will pay less. And the idea and the reforms that are ongoing is that the fund should take up a lot of, the chunk of the money, so that it should actually be like a walk-in, walk-out, so that the fund is taking care of the cost of the service that you have been served with in the health facility. So that again, you're not left with paying a lot of money and then being exposed to that risk of going into poverty as you seek the services. Again, the issue is to ask ourselves, do we have well-costed benefit package? And this goes back to costing our health services to ensure that the interventions we give are cost-effective. If, for example, we ask stakeholders, how much does it cost to offer, to treat malaria, for example, how much does it cost to treat TB in the country, or any other condition? And that then will inform the costs that will be covered by the social health insurance. And then again, important that all stakeholders, and stakeholders here are all of us, patients, providers, politicians, workers, farmers, are also involved in the discussions of costs, in terms of cost and effectiveness, and the scope of the services, and also the cost for reimbursement, so that you have trade-offs, that this is what I'll pay, and then when I go to the facility, I'll access this. This is a maximum that the social health insurance fund can pay for a certain condition in this facility, and so forth. So it's negotiations that happens. Question 9 is then, so you're saying you're taking care of the whole population. You have the benefit ranging from preventive, promotive health services. You're purchasing those benefits from the health facilities within Kenya, be it private, public. Then how will you buy those services? How then does NHIF purchase those services from the health providers? So there are various mechanisms of provider payments, but the idea is to ensure that we are efficient when we are purchasing the services, whichever method we use. Sometimes, for example, in the current scenario, NHIF does pay for outpatient, it pays capitation, paying upfront. And therefore, for example, in a health center or in a level 4 facility, then the people who are registered within that facility or empaneled in that facility then are able to seek outpatient services. For inpatient, it is paid based on the service that you receive, for example, so called fee for service. But there are many methods of payments. The idea is to have a mix of methods that are more efficient. And the final idea when you are paying for services is to ensure that we are paying for output, that you are paying for more health for the money, not more money for health, but it's more health for the money. So you don't just put in money into the system, but you're saying I'm paying this because at least patient A has accessed XYZ services, and those are the outputs. Those are what we are calling the benefit package. You offer the services defined in the benefit package, then I pay you as the health provider. Then last but not least, can social health insurance operate at financial equilibrium? So in principle, the social health insurance revenues from contributions should be able to take care of what you're paying the providers as they seek services, but also should be able to take care of administration costs and potential other services. Remember, you're talking of a social health insurance fund. So you have the organization, you have NHIF, for example, or any other that may be the social health insurance fund. So whatever finances you have should be able to pay for people as they seek the services, to pay for their benefits in the health facilities. The same amount should be able to take for care of the admin fee, cost of paying the health or the workers in the fund, cost of M&E and, running the systems or any other potential other payments. But then the idea is to look at the balance. Should we then make sure that our contributions are so much to ensure that sort of equilibrium? The idea is, and it's a big challenge, is to have a balance between the contribution rates that we agree, and remember most of them are defined based on the how feasible economically, but also there's some sort of political agreement because of the premiums, because the negotiations are beyond just the technical negotiations. You also have the other stakeholders like the political class, you have the oversight bodies, for example, the parliamentary committees on health, Senate Committee on Health, you have the representation of the people also speaking. Just to give an example, some time back, I think there was talk of increasing the contribution for NHI from 500, I don't remember to how much, that was about 3 years or so ago, if you remember, and then there was hue and cry in the papers. So such negotiation is required by all stakeholders so that you have enough finances to take care of the services and also the other costs, but then not so much to ensure that then people are contributing so much. So it's quite a balance. So, and that calls for budget impact analysis and good governance and stewardship of the funds by the government, by the funds, and also oversight by all the relevant people. So I end there. I hope that I have been able to communicate on the social health insurance. I have tried to give the examples from the country, but I really wanted the presentation to be general. Thank you.
Thank you so much. Thank you so much, Dr. Isabella, for that wonderful presentation, very informative. And sorry, I didn't introduce myself at the beginning, and you must have heard Dr. Isabella mention Dr. Maswan. So that is me, Dr. Jebichi Maswan. I work at KMTC, and I'm chairing this fourth session of the conference. And I'm also informed that the previous session by Dr. Mohammed Mohamud, if you have any questions, kindly forward to the Secretariat, who will share with him. He dropped off because of internet issues. So coming back again, thank you, Dr. Isabella. We've listened to the 10 questions and the discussions around the 10 questions. And we realize that insurance is really, for health particularly, is tricky. And but it's something that is achievable for the sake of the health of population, particularly in Kenya, and ensuring that people do not encounter or go into, call it financial catastrophe as a result of paying for healthcare. And from the 10 questions, I think we have an idea of what it takes, the different kind of mixes, and of course, the path that Kenya has just chosen. And at the end, I think the most important thing is saying, being able to have that balance between the revenues, what is going into the insurance and what is going out. So we're grateful for that. And now we'll open up for questions from both the physical audience and our audience online. Kindly, we'll allow, you can raise up your hand, you're here or online, then we can give you the opportunity to ask your questions. But Isabella, just to start us off, so in Kenya, we are talking about, we are the NHIF, and now we are talking about NSHIF. Is there a difference, or is it just a change of name? Or what is the real transformation in this movement from what we have currently to where we are going to, where we are proposing to go to? And then, of course, when we're talking about social health insurance, we're talking a lot about money and people being able to give money. And what we are hearing about is how we are going to put money into this, this new insurance. But how money is spent is just as important, on how we make this money. So I'm wondering, what are the incentives to ensure that people are giving, but that this money is also being utilized efficiently, that there is no wastage, and of course that there is no pilferage of this money in the process. And then lastly, you talked about that equilibrium, between the money, of course, that is going into insurance and then the output, the services that are being provided. So I'm wondering what role then the social determinants, how we are managing these to ensure that we are shifting money also to managing the other aspects of health, particularly in the prevention and other determinants of health, to ensure then that we don't have so many people getting unwell that it drains all these resources that people will have contributed. I will allow you, Dr. Isabella, probably to respond to that. Then as we wait for our audience to ask you a few questions too. Thank you.
Okay, so thank you very much. I don't know whether we have NHIF in the audience. They can assist in this, but I will try my best. NHIF versus the National Social Health Insurance. So NHIF transforming to Social Health Insurance Fund. If you read NHIF, it has basically been dealing with, previously before the amendment of the Act that was passed some early last year, NHIF was National Hospital Insurance Fund. National Hospital Insurance Fund. The word hospital tells you that NHIF engagement was only with hospitals. Now the mandate is being extended, and that was in the act that was amended to ensure that NHIF engages beyond the hospitals. It can engage, for example, the pharmacists going forward. It can engage other providers, for example, standalone labs. With time, we'll also engage, practitioners, for example, at the community level. But of course, that will call for designing how such then will be reimbursed and so forth. And it's happening in other countries, for example, Japan. We already talked about social health insurance and cross-subsidization and ensuring that all are on board. If you look at, for example, the current scenario, we are about 52 million Kenyans. Not all of us are on board NHIF. Most of us in the formal sector are, but the informal sector has been on and off. Quite a good percentage have registered with NHIF, but then they are not able to sustain their contributions. And I think from the data of NHIF, there has been maybe some issues of retention, especially for the informal sector. Let me give the example of my mother, just use my mother as a case scenario. So she will pay today, and tomorrow, because she does not have a source of income, she does not pay unless I pay for her. So she will be a member today. She's registered as a member, but then continuously paying is a problem. Now the change is that we are all mandated to pay. My mother has to pay, but should she not be able to pay, then through tax financing, she'll be taken care of by the government. That means the other change is that all of us will be then on board, the young, the rich, the poor, and then you get the benefits based on need. Whether I need an MRI, if it's in the benefit package, for example, if I need screening, for example, for cervical cancer or breast cancer, then I should get that. So screening, it may be cheap. Let me use the word cheap, quote unquote. I know prevention measures are not necessarily cheap, but whoever else needs, for example, an MRI, they should be able to get that even if they have contributed, even if they have not contributed, even if it's just the government that has taken care of them. So basically we are shifting to the scenario, that scenario I was talking about, the 10 questions. So bring all on board, rich, poor, young and old, sick and healthy. You contribute based on the ability to pay. Right now, if you look at the informal sector, the pay has been, and it's almost the same, 500. I know there are those who contribute about 320 and all that. It's only the formal sector where the premiums are graduated, but then you reach some levels of earning where we are paying the same. And I give the example of Dr. Maswan earning more than me, and we are paying the same, and then that would be unfair on me who is earning less. So that's a scenario where we are moving to. Now, so the money, spending the money, you need to look at the overall health system, not just the fund. When, for example, if I'm a provider and I'm reimbursed, that money is reimbursed to me as a provider, how then do I spend it? If I'm doing my claims, if I have treated Dr. Maswan and I'm doing my claims to NHIF, am I doing the genuine claim? You see, that is also efficiency. Did I treat malaria and, for example, say it is severe malaria because I know severe malaria is paid for more? Did I maybe treat a common cold and maybe just upcoded the condition to get more money? So you need to look at it from both sides, from the fund side, but also from the provider side. The other thing is to look at how, beyond the social health insurance fund, we need to look at how we enhance the whole aspect of the health system to ensure that there's benefit. Yes, we have the benefits have been defined all the way from prevention to, you know, the curative services that you can think of on all range of conditions that we have. But then we must also look at the supply side. We have the requisite HR. Here we call upon the counties to ensure that we have the requisite HR. Do we have the requisite equipment? Again, the counties come on board. Do we have a good referral system? You know, provision of quality of services. So all those come on board in your question too. How do we then take care of the social determinants of health? I'm trying to look at the slide where we say that as much as you have SHI, for these other community-based services, for prevention, promotion services, for services that happen outside the health facilities, I don't remember, I'll share these slides anyway, but for services that happen outside the health facility, we may need to think about other sources of funding. So the exchequer still has to continue. Yeah, here it is. Sorry, I hope you can hear.
Yes, we can.
Yeah, so if you look at that slide, then this is where your determinants of health stand. Also bearing in mind that determinants of health are just beyond health. We have political determinants, economic determinants, you know, all those. That we work together with the other sectors, for example, the line ministries, to tackle the determinants, but also being mindful that social health insurance may not be able from the beginning to take care of all the interventions. And we may think of preventive, promotive, and interventions happening at the community level being taken care of through a line budget. This is what we call the input financing. So the exchequer then allocates money to the ministry, to the counties. Here again, a lot to the counties because they're the ones in charge of service delivery to take care of such. Over.
Thank you, Isabel. I think my questions are adequately answered. Yeah, and now we open up to the other, the audience to ask their questions. I think what we'll do is we'll have one round of questions. You can write them down and then respond to them at the same time. So now we invite questions from the participants who are in the building, then we can go to the ones online. Thank you. Okay, thank you.
Thank you for the wonderful presentation. My question is about the biometric. We find that because now currently we are using biometric registration and we are supposed to register in a certain hospital. Is it possible that we can acquire the services anywhere you go using our NHIF or the NHI? Thank you.
Okay, thank you. Another question? Okay. Okay, let's see the questions online. We have somebody who's asking, why not social health insurance? Why not cater for all service rebates as opposed to consultation, procedures, drugs, and accommodation? Then we have, oh, that's just a comment. Okay, so, James Sakwa, your hand is up. Would you like to ask your question now?
Thank you very much, Dr. Maswan. I hope I'm audible enough.
Yes, you are.
Am I? Thank you. Dr. Sabella has spoken very well, and I almost stopped asking my question when she talked about when she was looking for somebody from NHIF from the audience, but she has spoken like somebody who works for NHIF. However, I still put my question. I think social health insurance has to do with everything that is social. And because conferences such as this are supposed to inform policy, it's the high time that we consider rebates for other services, so that if I have the cover, I don't have to travel to seek whatever service I want. Because the moment you travel to go and seek a particular service, then it really means that it's no longer coverage. It's no longer coverage, neither is it a cover. Thank you very much. James Swaka from Scientometric University.
Thank you, James. I think it's the same question actually that we had asked. And there's a comment here that says, knowledge is power. Brethren, I have learned that the government has better plans for better life for the people. The PHC and HSI are well elaborated. And they are thanking you, Isabella, for that elaboration and wishing that other sectors would have similar explanations. So Isabella, over to you.
Thank you very much. Again, thank you. Again, the question of biometric, again, I wish NHIF is here. Maswan, if you have anyone in NHIF, I think they can help on this one.
We
but
don't.
I'll also attempt. I'll also attempt on their behalf. I do not work for NHIF, but at least the little I have that biometric registration, you can register anywhere for biometric. One, feel free to register when you're going to access the service. For example, if you are unwell and you're going to Kenyatta or whichever facility, you can register there. You can also register through the NHIF branches, any branch that is near you. You can also register through the Huduma centers, I think. I said I think, but I think, yeah, that can also happen. And NHIF, I know they have also been mobilizing people and holding camps where they go out to register people biometrically. It's better when you have biometric because then now anyone, you don't have to, for example, if it's your child, they don't have to look for your card to go access service. Wherever they are, they'll be able to access, especially for inpatient services. Right now, with the reforms for social health insurance, of course, NHIF will be working to see where people will be accessing services. I may not have all the details and the issues of portability, but then, as I said, it's a whole system thing. It goes with how we are organized in terms of referrals from our counties. Remember, somebody has talked about, I don't know whether you have interacted with the team from primary healthcare. They're talking about the network of primary healthcare, PCNs, primary care networks, how the referrals will happen, because that also influences how the social health insurance fund works within that network. Who gets a reimbursement? How do people move from one facility within the network to another one? How do they move from outside the network to maybe higher levels should the services be required? From Sakwa, I think he's asking about the indirect costs. So then the idea is, again, I want to look at it from the overall system things, ensuring that whatever services that we need in our locality are available. So I come from XYZ county, ensure that I have facilities that can offer primary care services, that I have facilities that can offer, curative services, and should need arise, then I'm referred to Kenyatta. But then I also saw online, you are asking about not just taking care of the rebates and so forth. But I know that with the revised benefit package that the health sector and NHIF has been working on, this a little more costing of what they would take to access a service, so that when they are reimbursing, then the reimbursement are well informed by the cost of the service that somebody has utilized in a health facility. I hope I have answered, but if you get hold of somebody from NHIF, they would probably provide more insights. Thank you.
Okay, is there any other question? Thank you, Isabella. I don't see any. There's one more question. Just one, and then we'll be done.
Sorry for coming back again, but my question is about the those people who are mentally handicapped, or they are in the community and they are not able to take care of themselves. How can they be assisted by the NHIF for free medical, please?
Well, Isabella, I know again that is mainly for NHIF, but let's see how much whether you can attempt that. But we promise we'll invite NHIF. Yeah, okay.
Yeah, you need to invite, but again, let me try from the policy level. We talked about social health insurance generally, and you said about cross-subsidizing. Those who are able to pay, you pay. Those who are not able to pay, we ensure that they access services and they are protected and the government pays for them. Right now, the current proposal is that for the poor and the vulnerable, and here I'm looking at that situation that has been mentioned by the plenary here there as being vulnerable, they are identified for support by the government. Identification is through various mechanisms. Of course, the NHIF does not identify. It is done by the social, I think it's called Department of Labor and Social Protection right now, together with the administration, for example, the chiefs, the sub-chiefs, so that then the Social Protection Department has the names and the household that are poor and vulnerable. And I kept giving examples, for example, the orphans. There are some households that are taken care of, so that such are then taken care of through government subsidies. And one of the reform areas I know is that as the government is looking at moving towards graduated contributions, the people at the bottom of the pyramid are expected maybe to contribute what they can, if at all. And for those who are not able to contribute, then the government contributes through tax financing. So the thing is to link such people with the relevant arms of government through the chief, so that when identification is happening through social protection, such are identified. Just to give an example, 2 years ago, or 1.5 years ago, the government took care of over 1 million, I think 1 million indigents, and they were paid for insurance. So the indigents here, we are not just looking at poverty, you also look at conditions that may hinder somebody from earning an income. The other thing I want to say is that mental health is now well taken care of in the benefit package of the NHIF, actually very comprehensively. Mental health and substance abuse, that is something that previously was really not taken care of very well, but going forward is a good service range for those who may need the mental health services. Thank you, and over.
Thank you so much, Dr. Isabella, for that. Your presentation was actually very good. You've answered all the questions, and even the ones that you felt were really to do with NHIF. I think you've represented NHIF very, very well, and we appreciate. We promise in future we'll invite NHIF also to clarify, but I think you ably answered all the questions. Yes, yesterday we had a presentation on primary health care with the primary care networks. I think we now clearly understand that. So with that, then we've come to the end of this plenary presentation. Thank you again, Dr. Isabella. I think our secretariat will look for you to extend that hand of, shake your hand of appreciation Yeah, because you've done a very good job. With that, we've come to the end of this plenary discussion, and we move on to the next session. So thank you, Isabella. I think we can let you go. Thank you.
Thank you for the engagement. I most appreciate. Thank you.
Okay. Now we have yes, we had the previous presenter, plenary presenter, that was Dr. Mohammed, who did a presentation, and then he dropped off because of network issues. I understand he's now ready to respond to your questions. So online audience, you can type your questions, and the people here, you can also tell us your questions, or ask your questions. Is he on?
Hello, I'm on, and I have questions with me here.
Okay. Please kindly go ahead and respond.
Okay,
Sorry, I didn't.
Fine. I have a question from Thomas Lepepa. He's asking, is the government still sponsoring the family health clinicians who will be coordinating the CHU? I'll say yes, because when you look at the PFN guidelines, the head of the MDT should be either a family physician or a family clinician. So that is still on. The second question he asked, the paradigm shift is real from curative to preventive at community level. So how about the workforce? Can't quite get, because the curative part of it will still continue, and of course the preventive will still continue at the community level. So I can't quite figure what he wanted to ask with that question. So what is the government's role in, a question from Rosemary Wanjiko, what is the government's role in bringing the gap on human resource, for example, employment of the community health assistants? Clearly, as I told you, we have a deficit of the CHAS and the CHOS. Clearly, we are at 34%, and the government is planning to employ them. The Kenya Kwanza government is planning to employ, to make sure that each community health unit has a TO or a CHA in place. So it's working, it's going on, and clearly we came up with a scheme of service. The other day we revised, we had the old one, but we revised the new scheme of service. It's actually at the Public Service Commission, just waiting for it's actually on the final progress, which clearly gives a job description of the community health at different levels. We start with the Tier 3, Tier 2, 1, up to there. It gives them plus the remuneration and everything. And we are at 34, and of course, we're gonna reach 100% for this community health unit. James Sakwa, Daktari, can you shed some light on the improving numbers of healthcare workers in rural? James Sakwa, you can clearly see when it comes to rural, when you look at my presentation of primary healthcare, we are at actually 1.4, 1.7 something. And according to WHO, we're supposed to be at 4.4. Yes. So obviously, when you're implementing this thing, I told you before we implement the PCN, we are doing a needs assessment at that sub-county and everything. And the thing that we are looking for is also the HRH, the human resource, because we believe human resource is actually the engine and the pillar of to drive this thing. Somebody is asking me, KMTC, why certificate courses was stopped for nursing? Certificate was stopped for nursing. This should be revisited, otherwise UHC will be a marriage. I think this question is not meant for me, by James Sakwa. I think he addressed it to the KMTC. Thanks for the good presentation, Daktari. On managing the CHU and its coordination, the government was funding the family clinician. I think I answered that one from the paper. Someone is asking me, what is the reason to engage 94,000 health promoters when we can't engage different cadres at a fraction? We engage 94,000 community health units because they are the
Daktari, we can't hear you. I think your microphone is a little bit far. Just increase your volume.
Okay. Can you hear me now?
Yes, now we can hear you.
Yes. Yeah. So they play a pivotal role because they're going to help us in screening and everything, also passing the messages and all that. So is the shift from curative to preventive? Where are the PHOs and PHCs in this current structure? Because we did not. Currently, PHO and PHC, they are there. And when you look at the multidisciplinary team, they are still also inside there. And currently, we don't have enough. Even when you hear this 34,000, this 34%, we are calling the CHU, who are supervising the CHU. Most of them are actually the public health officers for most of the counties. Yeah. What changed? Yeah, I think basically those are the questions that I was asked. I finished all of them. Yes.
There's one more question for you. Just one more, and then I think we'll take a break. Dr. Manyara, please.
Thank you so much. Thank you so much, Dr. Mohammed. I don't know whether it's good enough. So my question is, you talked about upward referral and downward referral. So I just wanted to know, for patients' records, if I keep on moving from health center to community, where are my records? Is there a place to integrate these records so that I don't keep on giving histories or maybe pictures, my x-rays? Is there somewhere that we have put those records? So my records are somewhere. Thank you.
Okay. Number one, okay, I'll tell you, number one, we are rolling out the EHIS, Community Health Information System. Your record will start from the CHU, where the CHU is serving your household. Then from there, you'll go to your primary facility, which is actually your spoke. Your spoke. That is the dispensary close to you where you will be seen. That's where your record will be. Okay. Then when the record, when I say downward referral is, for example, if you are diabetic, you're hypertensive, and you want to be seen, you can't go to a bigger facility. You'll be seen at that level where you are. That is dispensary. It's only the team that comes down now. The MDT, the multidisciplinary team, come down. They see you at that level. They keep your record there. They can even take samples from you there. You see. And when I talk about PCN, we try, this network is within a sub-county. Unlike what we have now, patients do a lot of self-referral. Someone can leave this facility, go this facility, go this facility, and hence you cannot even track anything. A patient comes with a book, tomorrow he goes with another book somewhere else. But with PCN, we have that structure so that we know that, okay, from this community health unit, patients should know that this is where they are supposed to go. This dispensary or this health center. This is where you should go. The services that are not here will come. And if it's referral upward, if more complicated cases, you can be referred upward like that. And hence, you can easily be tracked down. So when it comes in record form and also an M&E, you can easily track these patients and you can easily have the records of the patients rather than with the self-referral and all that. I don't know if I have answered the question.
Yes, I think.
Yeah, thank you.
Okay, thank you, Dr. Manyara, for the question. Thank you, Dr. Mohammed. I know there are a lot of questions. Yeah, that was there's technology that is emerging and it's so closely interlinked with primary care networks and all that. But we appreciate that you've been able to respond. If there are any more questions, we'll direct them to you, and hopefully you can respond even outside this conference. So with that, then we want to appreciate. Thank you. Yeah, thank you. I'm sure the Secretariat will reach to you and appreciate you more. Okay, so with that, then we've come to the end of the plenary sessions and the questions and answers, and we'll take a break. This team has been seated here since morning. I think you will need a break to at least take some water, sip some water, or have some coffee. We'll take a 30 minutes break. So for the sake of our online audience too, we can take a break. we come back at exactly 12:30 for the next presentations. We apologize that we are running late. Technology let us down a little bit at the beginning, but I'm sure we'll catch up. So we'll take a short break and let's see every one of you at exactly 12:30. Thank you.
Yes, we are going to say where we took it yesterday.
So twende wamesema twende School of Nursing, tukunywe chai ndio. No. Oh, you had me. Sorry, you had me talking. Yes, I know. About it. Okay. If you walk down to the hall, there is a HSM hall. Daktari normally teaches there. Yes, so down in the hall of HSM, let's go have our tea. Very, very fast. I don't think it should be the second time.
Just before the exit, where we are
Yeah,
getting
well,
the one.
for the one exit, turn to your right. Then we come back. If you can take less than 20 minutes, Are we ready? Come on. Okay. Thank you. Welcome back to this session. Yeah, we've had a break. Now we are about another 5 minutes late, but we'll try to catch up. So we'll have 4 presentations. From different researchers. So we will wait. We'll have the 4 presentations run to the end. Then after that, we'll have time for discussions. So I request each of you to write down your questions. And at the end, we will direct the questions to the different presenters so that we save on time. So without further ado, we're going to have the first presentation by Marion Chelimo et al. On institutional strategic planning, experiences of the Strategic Plan Secretariat at the Kenya Medical Training College. I think we can begin. Thank you.
Good morning. My name is Marion Chelimo. I'm here to present research paper. My name is Marion Chelimo. I'm here to present research paper on Scientometric's analysis of scholarly publications of Kenya Medical Training College from 1927 to 2022.
Apology, let us sort our presentations.
Good morning to you all. My name is Marion Chelimo. I'm here to present a paper on Good morning to you all. My name is Marion Chelimo. I'm here to present a paper on institutional strategic planning experiences of Strategic Plan Secretariat at Kenya Medical Training College. I am the principal investigator for this paper, and my co-investigators are Purity Gadhama, Lynette Makazi, Francis Gashanja, and Nyawira Mwangi. Thank you. On the background, the process of strategic planning is crucial in providing direction for institutions. It allows members and stakeholders to envision the vision, mission, and core mandate. The Secretariat for the Strategic Planning play a crucial role in supporting the development, implementation, and monitoring of the strategic plan. KMTC has a 5-year strategic plan cycle, and with the approach towards the end of the KMTC 2018-2023 strategic plan cycle, there was a need for planning for the next 5 years, which is 2023 to 2028. This necessitated the constitution of a team, hereby called the Secretariat, dedicated to this process. For the problem statement, institutions engage in strategic planning, but there are few studies which have been published on the experiences of those involved in this process. This necessitates a study on the nature and the experiences of the Strategic Planning Secretariat at KMTC. The objective for this study was to determine the experiences of the Strategic Plan Secretariat at Kenya Medical Training College and their role in the development of the KMTC 2023-2028 Strategic Plan. For the study design, we employed a case study which was used to report the experiences of the Secretariat of the Strategic Planning Committee at Kenya Medical Training College. And in this paper, we report on the appointment and membership of this Strategic Plan Secretariat. We also report on skills that are required among Strategic Plan Secretariat, more so to ensure stakeholder engagement, a key process in strategic planning. We also report on the communication and the channels that were used to communicate and engage the stakeholders. We report on data collection and analysis, on the leadership, as well as the experience that the Secretariat got during the process of writing the strategic plan document. The subjects for this study, we focused on the KMTC Strategic Plan 2023-2028 Secretariat, while the setting was Kenya Medical Training College. For the results, the initial appointment was made of 6 members of the Secretariat for the strategic plan by the CEO of KMTC. And the composition of this Secretariat initially was 5 out of 6 being female. The appointment of the Secretariat was done with clear terms of references, clear leadership structure, and defined timelines. After a while, 3 more members, all male, were co-opted to provide rich skill sets for the process. As for the composition of the Strategic Plan Secretariat, we had staff drawn from different campuses, that is Nairobi campus, Murang'a campus, and Port Reitz campus. Of this staff, we had a mixture of lecturers, a librarian, an ICT officer, a graphic designer, a finance officer, and a risk officer. We operated using a clear work plan to implement the strategic plan. And the requirement for this secretariat was that they could dedicate at least 15 hours per week to strategic planning work. This time was spent in an iterative process that involved engagement of stakeholders, communication with the said stakeholders through dedicated institutional email, through Zoom link, through WhatsApp group, And it also involved analysis of incoming data from the various planning tools and that had been distributed to the identified stakeholders. It also involved analysis of documents, both from the international to local and to even regional levels. Then it also involved report writing. This led to the development of several drafts of the strategic plan 2023-2028. Members demonstrated their ability to multitask and work well under pressure. There was strong leadership that was demonstrated by the chair and the vice chair, which led to the delivery of the strategic plan within the stipulated timelines. There was also internal leadership within the strategic plan secretariat, which also contributed to the successful completion of the process and delivery of the strategic plan document. The secretariat expressed appreciation for the opportunity to participate in the process of KMTC strategic planning, and participation provided them with an opportunity to learn about the strategic plan process. In conclusion, the key contributors to the success of the KMTC 2023-2028 strategic process, as reported by the Secretariat, included the use of a Secretariat comprising of a multidisciplinary team, and the Secretariat bringing on board unique skill sets that made the process successful, as well as strong leadership that was demonstrated by the chair, KMTC Deputy Director Academics, and the Vice Chair, Deputy Director Finance and Administration. For recommendations, there is need for institutions to document the process of strategic planning, and this includes the experiences of those involved in the process. There's also need to capacity build members of staff on the process of strategic planning to ensure that it runs smoothly. There is need to ensure the involvement of all stakeholders in the process of institutional goal setting. We would like to acknowledge the following: the research team for this paper, for their active involvement in the paper and their contributions to the findings. We also would like to acknowledge the participants, that is the Secretariat, who took part in the strategic planning process and provided valuable insights and perspectives on KMTC strategic planning process. We wish to acknowledge their willingness to share the experiences and opinions which made our paper rich. And lastly, and importantly, we wish to acknowledge KMTC management for giving us the opportunity to participate in the process of strategic planning for the year 2023-2028. Thank you very much.
Okay. Thank you so much, Marion Chelimo, for sharing your experiences, being a member of the Secretariat that was planning for strategic planning. Thank you for sharing how the Secretariat was formed and the process that you went through, the strong leadership that you had, and how the strategic plan was delivered. And next to present is Purity Gathama, whose paper is titled Situational Analysis for Strategic Planning, Use of Strategic Planning Tools at the Kenya Medical Training College. Karibu, Purity, to make a presentation. Thank you.
Good morning. Good morning. My name is Nyambura Gadama, and welcome to this co-authored article. It is collaborative, and the title of the article is Situational Analysis for Strategic Planning, Use of Strategic Planning Tools at the Kenya Medical Training College. The paper is co-authored by myself, Marion Chelimo, Francis Gashanja, Nelly Chopkonga, Lynette Makazi, Lucy Waweru, Kelly Oluoch, and Nyawira Mwangi. The background information. Situational analysis is a crucial step in the development of a strategic plan. It involves understanding the internal and external environment in which the strategy will be implemented. Both print and electronic literature host a number of situational analysis tools that guide the situational analysis during the development of a strategic plan. However, literature on how to use and apply the tools in the real-life context of developing an institutional strategic plan is lacking. As a team involved in development of Kenya Medical Training College Strategic Plan 2023 to 2028, we tried to retrieve the literature on how to use the situational analysis tool, and we could not locate. The only thing we could find was the tools and what they meant and the definition, and not how we can contextualize them to collect the data we needed for situational analysis. And this is what informed the problem of this article that I'm presenting, and we decided to document our process on how we identified and used the different tools for situational analysis during the development of the strategic plan. The objective of this article was thus to document and communicate how situational analysis tools were used during the development of Kenya Medical Training College Strategic Plan 2023 to 2028. Methodology. We used a case study description to show how various strategic plan tools were selected, contextualized, and used to collect data for KMTC situational analysis. Results and discussion. How did we select the tool? The KMTC Strategic Plan Secretariat, together with an internal team of experts with skills in strategic planning, selected a total of 10 tools, which are, we used the SOA, the SWOT, the root cause analysis, the PESTEL, the stakeholder analysis, competitor analysis, survey of supplier, survey of alumni, and survey of partners. Also, balance scorecard was used to align our strategies. How did we prepare the 10 tools we selected to collect data? For each tool, we prepared an MS Excel template with specific instruction for engaging different stakeholders. When I mention the word stakeholder, it is both internal and external, student and staffs and any other person that are of our interest. And then the templates were shared with stakeholders through email, Google Sheets, Google Doc, and Google Forms. Completed templates shared with the stakeholder were then received from all stakeholders via a dedicated email for strategic planning. They were classified, copied, and pasted into a composite Excel datasheet. The template was then presented to stakeholders in Zoom meeting and physical meeting for validation. After the validation of the composite data, they were analyzed and summarized, and key messages from each tool was identified, and a report for each tool was prepared for situational analysis for strategic planning. Conclusion and recommendation. The use of multiple tools in the situational analysis is feasible and support an understanding of the operational environment where the strategies will be implemented. How the tools are tailored for data collection for situation analysis need to be documented and communicated. The tools should be operationalized in the context of the organization. Thank you very much, and that is my presentation.
Thank you, Gathama, for that presentation, for sharing your experience during the development of the KMTC strategic plan, the various tools that you used, and how you analyze the tools to support that development of the strategic plan. The next presentation is by Marion Chelimo, entitled Scientometric Analysis of Kenya Medical Training College, 1927 to 2022. Karibu, Marion.
Good morning.
My name is Marion Chelimo. I'm here to present research paper on Scientometric's analysis of scholarly publications of Kenya Medical Training College from 1927 to 2022. I'm here on behalf of the principal investigator, Kelvin Oruko. The other co-investigators for this study are Purity Gathama, Wagaki Gisheru, Francis Gashanja, Lynette Makazi, Sami Barasa, Caspar Atege Onyego, Anthony Radol, Marcela Ogendo, and Nyawira Mwangi. For the background of the study, the determination of the research performance of an academic institution is crucial. It is also prudent to establish the scholarly behavior of members affiliated with such an institution. Scientometric studies are the main approach used to establish scholarly behavior of institutions at national, regional, and international levels. Scientometric studies are concerned with the publication output or count of an institution and are thus quantitative in nature. Globally, Africa's research output fell from 1% in 1996 to 0.7% in 2006. However, between 1996 and 2012, the share of articles globally with African authors doubled from 1.2% to 2.3%. Research output in sub-Saharan Africa is characterized by low allocation of national budgets to research and development, and this in turn constrains the resources available for scientific research, including equipment for research, infrastructure, and human resources. In KMTC, research is one of the 8 strategic issues in the KMTC 2018-2023 strategic plan. It thus follows that KMTC affiliated members have a mandate to engage in scholarly activities. For the problem statement, although research is one of the core mandates of KMTC, since KMTC started in 1927, there is no record of any study of its research productivity nor the scholarly behavior of its affiliated members, and this necessitates the current study. The purpose of this study was to retrieve and provide evidence on the publication output of authors affiliated with Kenya Medical Training College. And the objectives for this study were to determine the publication trend of research by authors affiliated with KMTC since 1927. Number 2, to determine KMTC author characteristics. And number 3, to determine the collaboration patterns of research by authors affiliated with KMTC. The main outcome measures for this study were publication trend, which includes number of yearly publications from KMTC and the publication growth trend over time. Number 2, KMTC author characteristics, where the focus was on gender and position of the author. And then main outcome number 3 was collaboration index, that is number of co-authors. For the research methodology, a systematic desktop review design was applied, and the setting is that we used Hazing's Publish or Perish software to retrieve peer-reviewed publications from 5 databases, namely Google Scholar, Crossref, Semantic Scholar, PubMed, and Scopus. We used keywords, whereby we did a keyword search of databases using the words Kenya Medical Training College or KMTC, as well as Medical Training College or MTC. And the search period was indicated from 1927 to the year 2022. For the criteria of inclusion, we included articles with at least one author affiliated to KMTC. For the study findings, we searched for publications since 1927, and a total of 124 publications were retrieved. And these were included because they met the inclusion criteria of having one author, at least one author affiliating with KMTC. You can be able to see from the table number 1 that the earliest study we got was from 1994. That was one publication. Figure 1 also depicts the number of articles with authors affiliated to KMTC. So here we are looking at the trend. So we are looking at the number of publications per year versus the year of publication. Figure 2 also shows the number of authors that have been involved in publications affiliated to KMTC. Our findings from the 124 publications revealed a total of 167 authors who had affiliated themselves with KMTC. Figure 3 is a comparison of the number of publications per year versus the number of authors per publication per year. And from the figure, you can be able to see that there are increases in collaborations as indicated with the yellow line graph, which shows the published number of published articles versus the purple line graph, which shows the authors per published work. And this could be an indicator of increasing collaborations right from the year 2023. We also looked at author characteristics, and here we focused on gender. So table 2 shows distribution of gender in KMTC scientific publications. And we are seeing that out of 67 authors that were identified, 74, that represents 45% were female, then 50, this represents 50% being male. And then we have 10 whose gender was not disclosed from our study. In table 3, we are still looking at author characteristics, distribution of author position in KMTC scientific publications. As you can see, 57 of the authors from the publications retrieved were first authors, compared to 11 who were the last authors and 99 who were the middle authors in the various publications. And the bar graph in figure 4 shows the frequency, that is number of persons who published as per the reported author position. So out of 167 authors, we can be able to see that 57 only were in the first authorship position, while majority of the other authors occupy the middle positions. And as per figure 4, these are positions 2 to 8. Figure 5 also shows author position compared to frequency. We are able to see through the categorical frequency of author positions that we had 57 authors being in the first authorship position, 11 being in the last authorship position, and 99 in the middle authorship position. So interestingly, majority of the KMTC authors were in the middle authorship positions, followed by those in the first authorship, and then lastly, those in the last authorship positions. We also looked at gender, a comparison of gender versus the authorship position, and figure 6 shows that among those who occupied the first authorship position, 24 were female compared to 28 who were male. And out of those in the middle position, 45 were female and 50 male. Those in the last position female and male occupied the last position equally at 5 versus 5. In conclusion, publications by KMTC have been increasing with up and down since 1994. The increases in collaborations among authors is realized from the year 2013 onwards, and majority of KMTC authors occupy the not so prestigious authorship positions, that is the middle positions. Although gender disparities persist with male authors dominating, this gap is narrowing. There is need to use data from the KMTC repository to counter-check publications of authors who might have been missed because they did not affiliate themselves. Future research is needed to determine the types of collaboration, that is internal KMTC collaboration or collaboration with other institutions. Furthermore, future research is also needed to determine and document impact factor. There is also need for nurturing research culture among staff. This will improve KMTC research output. It is important to encourage members of KMTC to also affiliate themselves with the institution when doing research. We have limitations. Limitation number 1, KMTC publications that were under the embargo period were missed out during this data extraction exercise. Again, another limitation, the use of publish or perish only allowed us to use 5 databases, and these databases had different citation impacts, making it difficult to get one citation impact. Then over-reliance on open access from these databases may have been a limitation in the process. Then data from KMTC repository was not also available at the time of the study to use for counter-checking of publications of authors who never affiliated themselves. Lastly, when it came to gender, determination of gender, this we had to do qualitatively because in most of the publications, there was no provision for the author to indicate their gender. I want to finish by expressing acknowledgement. We, the research team, wish to extend our heartfelt gratitude to the authors who affiliated with KMTC and whose scholarly work and publication formed the basis for this scientometric analysis. We also wish to appreciate librarians at KMTC for their assistance in retrieving relevant publications and offering guidance on the scientometric analysis. We also wish to thank our research team for their dedication, expertise, and collaborative efforts throughout the study. Thank you.
Thank you, Marion Chelimo, for that presentation. Yes, research is a mandate of KMTC, and now we appreciate the scholarly behavior of our staff members. But we know that the trend has been going up, both in terms of the number of publications, the authorship, and even the gender. The trend is upward. And with that, we come to the next presentation. Again, as we continue, please jot down any questions that you may have to ask at the end of this last presentation that is coming up by Okumu, WC, and Angira C, entitled Determinants of Utilization of Free Maternity Services Among Women of Reproductive Age Attending Health Facilities in Homa Bay County, Kenya. Okumu, please.
Hello and welcome to my presentation. My name is Winston Churchill Okumu, a lecturer from KMTC Sigowet campus, and my co-author in this paper is Dr. Charles Angira, a PhD lecturer at JUST. My research topic is determinants of utilization of free maternity services among women of reproductive age 15 to 49 years attending health facilities in Homa Bay County. So the outline of this presentation will be as follows. We'll have introduction and background of the study. We'll have problem statement. We'll have study objectives, conceptual framework, methodology, study findings, discussion, conclusions, and recommendations. So what is this free maternity services? Free maternity services is offering of medical and obstetric care to pregnant women without any financial cost. The program was introduced in Kenya in the year 2013 with an aim of ensuring that 100% utilization, but this has not been the case. So globally, we have over 500,000 women dying of pregnancy-related complications, and 1,600 die every day of the same. So women in sub-Saharan Africa are at a higher risk of this mortality, and in Ethiopia we have a mortality rate of up to 676 deaths per 100,000 live births. So at the time of this study, the unskilled delivery in Kenya was at 39%, and 15 counties constituted 98.7% of all the total maternal deaths in Kenya. Apparently, Homa Bay County is among the 15 high-burden counties by maternal mortalities in Kenya, with a maternal mortality rate at that time being 583 per 100,000 live births. The skilled delivery was at 54%, and that means that 46% of the deliveries were not conducted within the health facilities, and therefore they did not utilize free maternity services, leading to maternal mortalities that have been presented. So this study went out to establish the determinants of utilization of free maternity services among women of reproductive age attending health facilities in Homa Bay County, and this was done through the three specific objectives. One, to identify maternal experience determinants of utilization of free maternity services, to identify the healthcare service providers experience determinants of utilization, and also to determine the health facility capacity determinants of utilization of free maternity services. So for justification, underutilization of free maternity services leads to increased maternal and neonatal mortality rates in Homa Bay County, and therefore proper utilization of free maternity services can significantly reduce the mortality rates, and thus minimize the dangers that mothers and the unborn babies are exposed to. This study established key findings that informed recommendations which would guide appropriate interventions, and when these interventions are implemented, utilization of free maternity services would hence improve and will have reduced maternal mortality rates significantly. The study had this conceptual framework with the three objectives and some of the interventions that happen within the hospital setups, such as family planning, commodities and devices, some of the policies like health systems policies, universal health coverage policy, social mobilization and youth-friendly services would result to the utilization of free maternity services, and the utilization will depend on the three objectives as indicated. The study methodology, the study area was Homa Bay County. Study design, cross-sectional descriptive study. Study population, women aged between 15 to 49 years residing in Homa Bay County. Then the target population were postpartum women attending maternity services at selected health facilities in Homa Bay County. Sample size determination was established using the Fisher's et al. Formula, and after computation, 382 mothers was obtained. There was a 10% adjustment, bringing 420 respondents. Sampling procedure. 4 health centers were randomly selected among all the health centers in the county, and all the 8 sub-county hospitals were purposively sampled. A total of 420 mothers attending the 12 selected health facilities were involved in the study. The questionnaire was proportionately allocated according to the volume of each of the 12 health facilities in Homa Bay County. A structured and semi-structured questionnaire was used to collect quantitative data. We also used focus group discussion guides and also key informant interview guides. Data collection process. Data was collected at the selected health facilities where face-to-face interviews and filling in the questionnaires was done. We also conducted the 4 focus group discussion guides, with each having 7 to 13 mothers, and the facility in charges were also involved in the key informant interviews. For the ethical consideration, this was obtained from JUICE postgraduate studies at NACOSTI. We also sought the permission from the Director of Health Services, Homa Bay County, health facility in charges, and all the participants who were involved in the study. Data security was ensured by use of logs, passwords in various electronic devices. So for the findings of this study, the response rate was at 94%, and we also applied descriptive statistics. We also did factor analysis and inferential statistics. Results and discussions. A total of 396 respondents, that is translating to 94% response rates, was established, and amongst these, 54% were of the mothers interviewed were aged between 20 and 29 years, the mean age being 26.4 years. The results showed that age was insignificant in utilization of free maternity services. Further, we did a factor analysis and a logistic regression revealed that respondents who agreed with the need for a well-equipped health facility with good sanitation system were 63%. That is an odds ratio of 0.37 at p-value of 0.03, more likely to reuse the free maternity services. Distance was insignificant in utilization as long as the health facility was well equipped and adequately staffed at 57%. So in conclusion, the study revealed that despite the fact that distance did not show a direct association at individual level, overall, well-equipped health facility with good sanitation system, competent and adequate and respectful and diligent healthcare staff, registration for Linda Mama process, healthcare worker strike, good supplies emerged as combined factors to determine utilization of free maternity services. This study revealed that utilization is as a result of a complex amalgamation of service-related factors, each contributing to the final decision of utilization. So the recommendation of this study is that the county government of Homa Bay should work towards improvement of infrastructure and healthcare service provision related factors through resource allocation to ensure all health facilities have better sanitation facilities and privacy, which are key determinants in utilization. Thank you, and thank you for listening to me, and I welcome questions from the audience. Thank you.
Thank you, Okumu, for that presentation on free maternity services, which, as we noted, has an impact on maternal mortality. And that was in Homa Bay County. And that brings us to the end of our presentations under session 4. That is, we've had 4 presentations, 2 by Marion, 1 by Gathama, and 1 by Okumu. At this juncture, we welcome questions directed to any of the presenters, both from the members present in this room and also from the online audience. Yeah. Questions from, okay, we have Chalo.
Anyway, let me just talk. Maybe this. I'll just put them as comments. One, I did not get the exact key message on strategic planning. The exact reason for the process, it was more of ascertaining how the procedure was done. However, it is very meaningful on the other side because it shows a position where KMTC is as of now, but the things that should be setting on the challenges should be monitored, because it's not the first time that we are doing a strategic planning. We have had strategic planning before. So probably if there should have been a comparative aspect, it would have added more strength to the review, but it was very good work. That's just a comment. On the tools for situational analysis, when you talk of like 10 tools that were used, and this is data that was being retrieved based on your thematic areas, numbers for quantitative values were not shown, and the tools cannot be similar or the same. When you report, it was found that these tools can be used for this and that. We cannot use all the tools at the same time. Maybe economic aspects or resources limitations. Probably it would have been much better if there was a priority to which tools would be much better if you are talking about pestle analysis or something like that. However, the study is very, very informative for a start, but maybe next you could benchmark now on sub-analysis of those tools, which one is more effective to save resources. On Scientometric analysis, still a comment, not asking a question. I did not see the reason why you put up the data from 1927 all the way to 2022. Scoping review should have been done before to ascertain when should you start ascertaining these publications. Because even from your analysis, and I expected that when you are projecting, I did not expect to see anything from 1927, 1930, I did not expect. So that was too much redundant. And when you are reporting that data, you are now telling us between 1922, 1927 to 1922. That is 95 years. You are skewing the data where you did not even collect some variables, because the first one was in 2014, no, 1994. So there's a lot of redundancy that will reduce the quality of the study. So if it was narrowed down, probably would have gotten a different aspect. Again, when you are using this publication scope, I think it would be also been prudent if you take care of predatory journals. Even myself, before I started publishing, when I was learning to publish, I put my articles in predatory journals. And people might have done that. And a predatory journal will be a fake journal that is not formative. And some of us, even at this stage, we have done that without knowing, because journal and publishers are very witty. So if you could go further to understand that aspect so that we can get the finest in terms of talking of 127 sites or something, you could find that 60% of that are actually predatory journals. That's something you do not take care of. It's not still a question, however, it's a view, because that study is very, very important, and it is something very good, because it's now a platform for another study that the team members, which did very good work, they can do. The last thing is on the license, Creative Commons license. When you're publishing your work, there is an open access, there is closed access, and there is what we call hybrid journals, which can have both open and closed license. It would have been much better to map out which one, in terms of the work that was published by KMTC members, so we know why do we find ourselves so much into open access as compared to non-open access, or why would we recommend we go to hybrid? I think those are my comments, not a question. And for the last presenter, an odds ratio does not always mean it is associated. Even if you get a proportion of 63% and then the odds ratio is 0.37, that is projective. So maybe you can say it was associated, however, it was projective. So we be careful when you report, maybe you don't say it was associated. 63% is a proportion. The odds ratio communicates, and the 0.37 is projected by 63%. So those are just comments, not questions. Thank you. They were very good presentations.
Thank you, Chalo. Another question? Yes, there's one question there.
Okay, thank you. Thank you all the presenters for your wonderful presentation. My question goes to Scientometric analysis. Now, there was this, the departments and the qualification of the first authorship. Now, you have given us the first, the second, all the way to the eighth. In our KMTC, which is better, did you care to know whether the KMTC staff were the first authors? And did you care to help them understand better, or is there anything that was done to them for the sake of motivation and encouragement? Now that there is need for nurturing research in KMTC. And for the last presenter, you have said that you used semi-structured, structured, face-to-face interview and focused group discussion. But you said your research design was quantitative, but you generated qualitative data. There was no analysis for the same because semi-structured is qualitative in nature. Now, what are you telling us? What is wrong? What went wrong? Thank you.
Thank you, Romina, for the two questions. Any other? From our online, you can raise up your hand or you can type your questions. But we'll give the opportunity to the presenters to respond to Promena's questions. Marion on Scientometric. There was a question for Marion and a question for Okumu, right? Okay.
Good afternoon, and thank you. I would like to thank Dr. Tari for raising the issue of predatory journals. Yes, we are aware. We were aware of the predatory journal when we are doing this study, and the database we have used are indexed in DOAJ, and therefore, the DOAJ usually take care of the issue of predatory journal. The issue of the first author, second author, we were reporting on the position of KMTC affiliated members. At what position were they? And as Barion has presented, most of our authors were in the middle position. But we had some in the first order and others last orders. And as some papers have reported, we have prestigious authorship position in case of Sub-Saharan Africa. So first authorship and the last authorship are viewed as the most prestigious authorship position. You are asking what have we done to help our affiliated members? The research team, which is here, is doing a credible job. They do a lot of webinars, they sensitize people, and they are encouraging our members to do a lot of research and get to be in those prestigious authorship position. Thank you.
Yes, Okumu.
I just add something to the question which was asked.
Yes, I know you are the first author for that particular paper, so please go ahead.
Thank you. In addition to what one of the colleagues have said, this was purely secondary data. So there's no at one point we met the authors through the online search. So there's no interaction so that we could motivate or do something to the authors. But I think it is one of the recommendations now made as a challenge to the organization to find a way in which the researchers can now be motivated. Like when you are going to do a publication, you may find it necessary to affiliate yourself with your institution, which in this case is KMTC. Thank you.
Thank you for that. Another question? Oh, Okumu, sorry.
Thank you so much for the comments from Dr. Chalo. I now can better report on the odds ratio and the percentages. On the questions from Madam Promina, if you look at even the abstract, we have a descriptive cross-sectional study, which is having quantitative and qualitative arms. From the presentation, maybe because of limitation in terms of the time, we were not able to put narrations among the slides. But if you get the real document, there is narrations, and the qualitative data is well brought out in the report. Thank you.
Thank you, Okumu. Another round of questions online. Yes, raise your hand, please. Raise your hand for the online audience. If you have a question, you can also type. No. Okay, comment from Musovia.
Thank you for this chance. I have a comment on this Scientometric analysis. And mine would be rather to, if you had gotten a chance to interact with the others in terms of their positions, probably you might have found that the financial muscle, when it comes to publication, maybe had an impact in where someone finds themselves in terms of that list. And in that light, could maybe the department of research in KMTC consider extending assistance to KMTC lecturers when it comes to publishing even their private work? Because I understand currently there is provision for funding when it comes to publishing that research work funded by the college. Can the same department consider also assisting lecturers who want to publish other scientific work in those journals, so that we can also even encourage the publishing, even encourage also, or try to see if they can influence the position at which we find ourselves? Because as you have said, there is prestige in the position, and even equally important, we also push the institution forward when we actually publish this work in those credible journals. Again, these journals are also expensive. It depends on the amount of money you have. I mean, you might find yourself with a lot of, with some quality work, but probably because of the amount these journals are asking for publishing, maybe this one can limit a lecturer into using a low impact kind of journals out there. Thank you.
Thank you. I think that was just a comment. So there's no response from our online audience. There is a comment from Rosemary Wanjiku. I applaud the Scientometric group. Hopefully this supports the need to empower staffs on research. I think where we've started, we've seen the trend is going up, and we are hoping that this will continue. I think that is what Musovia is also alluding to. And there's a question from Ochoro Law on free maternity. Elaborate, what are the solutions? One question is not really, I do not really understand, but Okumu, probably you can just make a very brief comment on what were the solutions to maternal deaths, although I know that was not the gist of your research.
Thank you so much. Maybe from the online audience, my comment on the same is that, the justification of this study, that we want people to utilize free maternity services. The government came up with this so that we would have had 100% utilization. And therefore, if we still have unskilled delivery, then people are not utilizing the service. Anytime you go to any public health facility in this country, then the service is there, and you'll get all the package that you want. And therefore, the only thing is that to ensure that we strengthen the public health facility, and also encourage through awareness, through promotion, health promotion, within the community so that they are able to achieve. Through that, then we will be able to reduce the maternal mortalities. Thank you.
Thank you, Okumu. I think with that, we've come to the end of this session. We appreciate our 4 presenters for sharing your findings and expanding the knowledge in the various areas. For those who still have questions that are not able to ask, you can still direct them to the others. And yeah, with that, we've come to the end of this session, and we have the 5th and the last session for the day that we're preparing now to enter. Thanks everyone for being present, and tuonane in session 5.
Yes, so good afternoon, everybody, and welcome to this session 5. So on session 5, I'll be your chair. I'm Kennedy Kenyo from e-learning department, KMTC. This session is about emerging technologies and innovation in healthcare. To start us off, we will have a presentation from Mr. Josh Kiptanui. So Josh Kiptanui is a certified simulation educator, a provider. Is also a healthcare simulation technician specialist from Paramedic University. He has also a BSc in computer science from Masai Mara University. Also owns a master's in healthcare informatics from Moi University. He works at Aga Khan University Center for Innovation in Medical Education, currently employed as a position as a specialist. He has also previously worked at AIC Kijabe Center for Medical Simulation, and also as an assistant international Tanzania technical specialists. Notable achievement is that he has supported the implementation of healthcare simulation program in Uganda, Tanzania, Ethiopia, Liberia, Somaliland, and Zambia. He has also supported various research, work, and publication, and presented in major scientific conference. So, Joas, karibu, and I'll make your presentation. Thank you.
Thank you so much for the introduction. And thank you also for this opportunity to be part of this scientific conference and even to make this presentation. So I'll quickly dive into the topic to look into emerging technologies and innovations in healthcare, the opportunities and threats. So basically, I understand that the topic here is opportunities and threats. So I decided not to start with the opportunities, but to start with threats first, because if I start with the opportunities, then go to threats, you will all remember threats and not opportunities. So basically, this is what I'm going to talk about. So I have my objectives lined out. First of all, I want us to see where does this tech and innovation intersect and healthcare intersect. So you understand medicine, healthcare, you are taught so traditional in the way you train, in the way you do things, you know, anatomy and everything. Technology on the other side, we are so focused on new things, coding, programming and everything. So where do these two places critically like meet, and which kind of decision do we make? And then two, I look at the threats that are posed by technology, which are numerous in many ways. And then three, I look at the opportunities availed by technology in healthcare. What are these opportunities that we can tap into? There are so many, but let's look at the practical ones. I'll pick on the practical ones which have personally been involved. And then four, I'll try to answer or not answer the cost question, because that comes up. Some of these technologies come at a very large cost, and then I'll give a conclusion. So first, let's look at where do these two intersect. So basically, we understand that there's so much coming into healthcare as a result of changes in technology. There are many things happening. As you can look there are so many clinical decision support systems. The equipment we use are all technological. You are using manual blood pressure cuff. Now automatic ones are here, you know, and also many things, glucometers and everything. So the question that I always have is, who is this informed person in between who can decide my county, Nandi, where I come from, needs to pay nurses more and does not need ambulances? Who comes in with this information, with these processes, who can understand how it works? Who will come in and say, we don't think county X need an MRI, county Y needs 2 CM for this thing. So I always call it a technological gap. You find that it's a gap that I don't know who created it, but healthcare system and technology systems, you don't have specific specialists. I realized this when I was doing my healthcare informatics. No dedicated people who can understand the needs of healthcare and then look at the coming technologies, be able to understand the trend, the advantages, disadvantages, and everything before deciding we are mapping this technology to this healthcare system in this way. And then you find most of the time we borrow from other worlds, and all of you will agree with me, healthcare changes, you know, geographical things and whatever, everything is so diverse from one setting to another. So then there's a gray area here on the decision you are to make if you are to map a certain technology in a given healthcare field, and then how do you measure the output and all that? So it's still a very gray area. And in my presentation today, I will try to win you over to the fact that we all need to stand up, because if you're waiting for a savior to come in between there is no one. I actually say key players in the healthcare industry, an institution like KMTC has the best foot forward to step into that space, because for sure right now, it's very, very unregulated. Healthcare companies, yes, they've employed doctors, they are coding these programs. You've heard of people buying glucometers that worked in another area and they came here and they gave totally different findings because probably of a way of a lifestyle of a people somewhere. They're using these other products, they are doing these other things, use an equipment, it worked elsewhere, it did not work here. You all understand the results from vaccine and everything. So the question I'm trying to answer even in this slide is the space between the technologies you are bringing on board and the kind of settings you are mapping them into. We need people to step into that space and offer the appropriate guidance to do all this. So quickly, I have a few questions which I've just mentioned. I've mentioned a few of those. Who regulates that technology, you know? And then in the healthcare system, is it ready to embrace? We are bringing EHR and everything. Are we ready? we don't have paracetamol and we are pushing for an EHR in a sub-county hospital. What do we go first? Are we ready for these things? You are pushing for EHR and you don't have electricity. The computer you have, you don't know if to run that EHR and everything and all that. So the point is also the vendors of this technology, do they understand the different needs? Do they understand the nurse working in West Pokot Sub-County Hospital does not necessarily have the capacity or the infrastructure to handle that EHR, which we are forcing down their throat? And then two, do the healthcare systems also, the systems in place, can they support these technologies? So two, let me dive into my second point of the threats posed by these technologies. I said I will start with that first. And the first one is very common right now. Technology, especially you, I've seen KMTC, you are training for better healthcare, right? Yes, now you're training. First of all, I realize the word training, it's not just better healthcare, but it's also that better training, because without that better training, you'll not get that better healthcare. And now you give a student an assignment and I put it on ChatGPT and give it back to you. How will you tell I'm smart or not? You see he's smiling, he knows what I'm talking about. Yeah. How do you tell where that content is coming from here or not? And it's not just that. I was told just in my tech background, and I'm a student also, beating students sometimes is very hard. As instructors, I've said that space that is there, step into them before they do. Because once they do, catching without them is very hard. I mean, the ChatGPT, I was told there's a new one coming, Metaverse, just to divert you a little bit. You've heard of Metaverse, the concept of Metaverse? Yeah, so this is a virtual world where I'll go impersonate as Josh, create an avatar and allow it to go into Metaverse and tell it, you are studying Bachelor of Diploma of Medical Surgery in KMTC. Go find out the topics and do all the assignments that might come. And Josh will walk, he will look for notes in the United States, wherever, in all the whatever, then do that assignment. In the evening, we meet with him in the Metaverse, he gives me all those things. So by the time you're giving your assignment, I already have your answers. It looks very virtual, but these things are here and they're here to stay. And many other things. Who controls all that? So threats, I've also talked about, as we improve this, as we bring these technologies, there's an aspect of system security. You know, there's a college, I know in this, there's a college somewhere where students told me, there's a day the teacher left the laptop on the table and they went and copied a folder which he had kept all materials for the 3 semesters. So the students had the materials and they read the cards, they read everything. So they were doing well all throughout. And this guy told me once they graduated. So how would you tell when that happens? Very difficult. The other one that was very bad around, not here, somewhere else, where students, some smart students of IT managed to hack to the examination system and he was charging others 20,000 to change their grades from first year to fourth year. And the university didn't realize until graduation, when some lecturer was like, this guy never attended my class. How did he get a first class? So it started then, they went backwards and they realized actually the examination system had been infiltrated and things were changing. So these things are here with us to stay. EHR, electronic health records are here. Data, you don't know who is keeping that data, who is accessing it in the end. And there's even a new arm to it, robotics and things, where people are trying to use artificial intelligence to give, to make some systems smart to handle some things. So one thing I always say, healthcare is unique. My interaction with healthcare for the last about 10 years is that healthcare is unique in a way that some of these systems will not really find their way in between. Because the way a patient with malaria in Southeast Asia may behave may be very different from a patient in Nyanza. And it requires somebody to rely on these technological platforms to give all those solutions. So I've already talked about that. There's nobody controlling it. There's no specific way to authenticate information. The first one is very bad. And I did computer science and one of our lecturers actually brought it up that it was so bad, nobody can regulate the internet. We don't know how we came about with it, but we just realized we can't regulate it. And the other bad thing about technology and internet, just to highlight, to wrap up these bad things about it, is that you realize in other fields, engineering, whatever, they get time if they're building a house to create a prototype. Create a prototype, put it in the wind, blow wind on it, look at the structural defects and all that. Now with technology, we do programming and you can program these things, but most of the time we don't have a place to try them. So you drop the technology, you have people use it and then figure out what are the weaknesses. And if you take too long to fix them, there's another one coming, Simple example, M-Pesa came. They didn't know people will start impersonating and swapping other people's number. So we keep fixing them as we go. So first of all, they were calling you. The first people send money. Then everybody realized their accounts with money. Then the others came with the messages. Then the others came to swap. And trust me, I'm not threatening you, but there are more things happening in your phones that you don't know. with all those apps you've downloaded, I mean, I just need your laptop for 5 minutes to put in a small script and I'll be reading all your emails and anything you do on that laptop. Just one script. Those phones, they are tracking apps. I can just go in, download in the backend and install. People are doing that. People are doing it for money nowadays for other reasons which I don't want to mention. But I can get your phone, put a bag inside there, and it will be sending me a copy of all the messages you do in the transactions. So things have changed. There's a bad side of that technology. So simply to put it, the inadequate, there's also the complex nature of technology. What I'm just trying to raise is the things I've put there. So simply, I don't know if, okay, fine. Yeah, so the other threats which I've already put, the fact that like now in healthcare, these are threats specific to healthcare that you have to abandon the traditional methods. Technology has come and you have to change things. So you have to change the way you do things, but also there's the concern of losing the very specific things. Like I've talked about the specific skills, you know, people like, for example, you just talked about research here. People need to know how data is collected, how everything is collected, what are the p-values, what do they mean when they get skewed and all that. But you find people change that. And I mean, technology can come in and you've seen ChatGPT, I just throw in the heading and it gives me an abstract with everything that I want to look at, you know, with these systematic reviews and everything. So anyway, the other major challenge is what I've just mentioned, lack of accountability and verification, very hard, you've seen that. And then the accomplished professionals realize all of you at the top, you may not have had the luxury of what we have right now when you are doing your undergrads and postgrads and all that. So you did it the hard way in quote, and you knew the value of what you're doing. Me right now in my third year, there are guys, you're lucky you people in Nairobi. You tell me to write a paper, there are people across the road. I just send them the topic. They'll write everything, they'll cook the data for me, and you put that data through the authentication software, even plagiarism checker. They even paid for a higher one, which will rule out yours, you'll get 90%, theirs is giving them 80, you know, and all that. So things are happening. So how do you authenticate that? We will look at the simple solution that I have. So there are other threats. And now with all those threats and with all whatever I've mentioned, let's narrow down to the opportunities we have. In as much as there are those threats that may make us or have already made us be afraid of this technology and be worried of. There are even people, I've been in settings where you get somebody and he's like, weka hiyo kitu mbali, print papers for me and bring them to me. I'm giving my exam on papers, you know. No, you tell them this thing is secure. It has a password. We have a, you know, they're like, no, just print the papers and bring them to me. So those things have happened. But now let's look, what are the opportunities that we have? And I know there are numerous opportunities. Here, I will narrow down to opportunities that have personally collaborated or participated in and have seen the impact. And I would say straight away that I always go for opportunities in the sense of what works. And now this brings back the introduction I had. That empty space, I think as an institution especially, you are at a very good position to influence even the national policy on some of these things. So let's step into that space of what works. Because trust me, somebody will come here, sit down, or I find it sometimes very interesting when, you know, I'm the, which position do I don't want to pick somebody's position here. Let's say I'm the head of department X, you know, examination. And I'm the chairing the committee that is looking into adopting new technologies for KMTC. Trust me, unless I have the second wing of tech, I may not be in a very good position to advise for that. So you find KMTC ends up buying a system which will not even take off because of simple things. So personally, I have an approach of what works and what gives result. So I justify the technology approaches, I evaluate given the results. So if there's no way I can try to see the results, let's talk about it again. One simple thing is just looking at the threats and everything. I was invited into one of the neighboring countries, had a committee in a university to look into acquiring a technology solution for the university. And they asked for my services in that to try and reason with them. The principal was the chair of that committee. I'm not saying the principal would not be the chair, but he was the chair. And when I attended the first meeting, he was like, we are going to buy a system and we have identified a system that has an examination system, a library system, a finance system, a student system, and a learning system together. And you're going to buy it for, I think it was about 15 million Kenya shillings. I asked him, are you sure about that? He was like, yes, we even met the vendor. I just told him I'm out of the committee. Just like that, because I didn't want to sit there and be part of that process, because I knew From my technical understanding, it's not possible to have that kind of a system. Even MIT do not have that kind of a system. It is easier to have aggregate systems doing dedicated work than having one system. So you have this system that has a finance system and a student interactive system. What if a student will get a code somewhere to bypass a security feature and get into a finance and examination system? Then the whole institution comes down. Yeah. So there are very, very deliberate moves as we look into this. Let's dive into opportunities. Many opportunities have come with electronic health records, which I always advocate for, but in modules that work and in modules that deliver. Because you find health information, even what you teach, is so much reliant on the feedback we get from health people, from healthcare providers. So, and the same feedback would even inform what you're teaching, because the people you teach are the people who are going to deal with those patients. So once electronic health records came, I found a challenge with it, just a little one. This is a solution, it's not a challenge, it's a solution. But I've found a challenge where institutions have not invested in staff development, resource development. And now these EHRs are in our hospitals, and the people you trained are copy-pasting notes. Why should you sit there doing this on the keyboard for 20 minutes when these are patients who had a malaria, patient Z the other week had malaria? Just copy-paste and change the names and save. People are doing that. You copy-paste the information, the information, the history you took from patient X, because this patient is here, he has a headache, he has this, he has weak joints, in malaria, na niko Nyanza. Just copy-paste that, paste here and save. That must be malaria, you know, to my lab, typhoid and all that. So then when you go to audit those systems, you get out results which probably may not align with what you're looking for. Imagine you are a researcher looking into that database. You will see things. So the idea again is from this institution to emphasize the need for keying in the right kind of information, because it is informing the entire system backwards. There are other systems for training and things. So I'm looking at those 5. I will talk a little bit about the e-learning platforms. I've already mentioned something about EHR. So I'll mention something about e-learning platforms, quality improvement platforms. That will cover the EHR and whatever we are using. And then there are task trainers. They are simple task trainers, which I think here you use them a lot in your labs and skills lab. And then I'll talk about computerized simulators, which have dealt with the application and everything. And then I'll talk about controlled or integrated environments, which will be the highest level of how I think technology can meaningfully be employed in learning environments. So e-learning platforms, I found one with you. I don't know how you're utilizing it, but I think this is one of a very big wasted resource we have. In the sense that not its implementation, the usage. All these young guys in our class right now, they're all digital, on their phones everywhere, digital, digital, digital. We have no choice. That space I talked in the middle, step in, and the first step you'll find is an e-learning platform. But again, don't paste a question there. Don't paste a PowerPoint there. That is how we are underutilizing it. Because you paste a question, they copy, they paste on ChatGPT, they get the answer, they post it back to you. One of the suggestions I would make to using e-learning platforms is to put interactive forums. So you post a question, there's a patient X who came to the hospital, 38 weeks pregnant, feeling this and this and this. Based on what we learned yesterday from head to toe assessment of a pregnant mother, please point out the 2 things you look at. And in those 2 things, you now put a forum. Every person in this group has to comment on everybody's response, either criticize it or comment positively on it. And only before you comment, you have to post your question. So people don't have to copy paste each other's questions. So now post your question, comment, and then comment at least 2. Then I will mark those comments and give you 5% for the cut. How will he ChatGPT somebody's comment on thing? He won't. So he will have to think, even if somebody will post, for example, I'll look for swollen legs. This guy needs to recall on his notes or now go to ChatGPT and say, ChatGPT, what does a swollen legs in a pregnant mother imply? Now he reads, it could be a sign of preeclampsia, eclampsia, whatever. Then this guy, you are forcing this guy to read the notes on ChatGPT, not just copy paste them on your forum. Then come back and say, I think Mother Mary might be predisposed to preeclampsia, and the best management would be, flat, whatever, uterine replacement and all those things. I read through the window. So all those things, yes. So you are forcing him to look for information, process it, and post it. He will remember something about that information. But if you throw in PowerPoints and quizzes, this guy has a smart way of doing it. My PowerPoint disappeared. Somebody can help here. Oh, here we go. I don't know if I'm still on the same page. Let me see. Okay, fine. So you've seen, yeah, I'm on the same page. Yeah, so that is about a digital learning platform. My next part would be interactive. So this is still on my first objective. So other interactive platforms, when these guys go for rotation, we can employ technology. I'm still on the part of EHR and whatever kind of technology. So when these guys go for their rotations and clinical whatever, and they're working outside, and you give them manual logbooks, one thing I tell instructors, don't trust those manual logbooks, because they go to do whatever they do. When they know you are coming next week, today, Friday night, he's laughing in us, you sit in your room and feel that thing and feel it to the end. Then when you come, I give to you, you tick there, past rotations, and I'm graduating. I'll learn these things ahead. What if you have an electronic platform? This is just an example. There are many electronic platforms. There are many applications. ODK, whatever I'm using is RedCap, and many online applications which have a secure end. Some even you can install them by yourself. I know there's a module to this e-learning platform KMTC has that can do that. You can install an additional module because these I'm sure you host it here. So what this does is you put them in a rotation, give them an application on their phone, and ask them to enter the clinical cases they do there. And then there are 3 in a room. If they're evaluating a patient, 3 of them, you ask them, one of them to be the primary person, like for that case, then the other one pick. So there's no guy who's sitting in the corner on the phone on chat while everybody is doing the job on the patient. So a smart way of rotating them, and probably tie that application, the date of the case, to be a primary ID, like a stamp, timestamp. So they can't put tomorrow's patient today or yesterday's patient. So they have to do that every day. Then you've tied them to look at the patient and evaluate them. And with that, you can easily log in at any given time and see their progress. You don't imagine collecting 40 logbooks to try and assess how your students are doing. It will take you 2 months. By the time you're finishing, they've left the rotations and they're somewhere else. These applications, you log in, they're instant. They'll tell you this person has this caseload, what they are doing and all that. And where I worked on this project once is that we used to send this to the learners. So we send it to them and tell them, this is your progress, discuss with your supervisor. And some learners would be like, I think I've rotated in obstetrics so much, it shows 80%, I need to go to pediatrics. We better be 10 people in pediatrics and learn than 2, depending on a rota schedule, and we are not learning. The other thing I found difficult when you give them logbooks, nobody will register a complication or an emergency, so that if failed, they will go discipline me. How did you do with the patient and all that? Once we started registering this, we actually asked those learners to record those, because their instructors would look and say, oh, what happened here? You did 6 attempts of spinal anesthesia. What was the problem? Or you had these complications. Let's look at it. Sometimes the instructors would create case discussions in the lectures just to look at that case. So they're telling this guy, it's not to punish you, did not do it well, but we are looking at how could you improve better, or what did you miss? Is it that something was contaminated? Is it that something went wrong? You've had cases where things were swapped, and we've had all these medical cases and emergencies and things that happen in very bad ways. These situations where somebody gives a drug, the colleague comes and the guy goes for tea or goes to the toilet. The colleague looks around, is like, this patient has not been given this dose. He pushes the second one, and then the patient are in surgery and they never wake up. You've had all those. They are common. The simple ones, I always say, if you documented them, the wrong surgery on wrong patients, Kimani is pushing patient X to theater number 6, then he leaves him at the door, Kipto comes, and huyu jamaa ameacha mgonjwa hapa kwa nini, then takes him to theater 8 and the patient is unconscious. And the surgeon in 8, oh, the patient has arrived, let's continue, And then when you open the stomach, you realize that tumor is not there, or the head or whatever. So some of these is very crucial to give real feedback. I'll move to the section quickly here because this is what you use. Task trainers and all these things. Technologies are available to teach people hands-on. And I always say, these would allow for so some of these technologies in this equipment, mannequins and simulators, they are close to real. So like the intubation mannequins I have here, you can adjust the difficulty level and they would feel as they would be. Some of them have sensors. If you push so much, they tell you. If you put the tube so much, you can tell. If you're bag mass ventilating, you can tell. You can see the CPR ones nowadays. It's not the old ones where you are just you do the chest, 1, 2, 30, give 2 breaths of air. I mean, how do you, if a patient collapses in ICU, you won't do 1, 2, 3, 30, you know? So there are these one with smart systems, which you download an app. You are doing chest compression, is showing you the rate, the volume, the whatever, everything, you know that. So smart and all that. Now we have the high fidelity ones, which are even more interactive. And what I always go for is to make sure these environments simulates reality. So this is where now advanced healthcare simulations comes in. Don't be those like you're standing in a room. Okay, the patient has collapsed. What would you do? I'll do 1, I'll do 2. When they go to the clinical environment, they don't do that. The idea is to put them in an immersive room. If you can get a high fidelity simulator, which can talk to them, can breathe, can respond to them and do things. When you are bagging, the sensors can tell whether they are ventilating or not, and all these things. Some of these even recognize the medication you give it. It's not really medication, but the syringes have chips to recognize what you give them. So you are checking them even on dosage, and you make these sessions interactive. I've been in one where I was a fake nurse, you know, a fake nurse who is junior, and the senior is there, you know, where is the ambi bag? I don't know. Where is the drug? I give him the wrong one to see if he'll counter check before pushing. And in some instances, some push the wrong drug. And when we realized at the end of the case, I said, once they graduated, this was a mannequin, but if they graduate, it will take them the 30 years or 50 they'll practice, they'll be looking at all syringes because they learned in a controlled environment. You don't wait for them to learn on a real patient. So quickly, interactive environments with monitors, you can change those vital signs. This is one of the things we have at Aga Khan University. You can change the vital sign, teach them how to use the equipment, a very interactive and immersive environment. So these mannequins react, respond, they can see, they can blink, they can cry, tongue edema, so many things. So many features. Technology has enabled a number of features in them that they can do. You can simulate so many conditions of them. And we go even ahead. We can use task trainers. And when I'm a fake patient who has a diabetic foot, I get moulage and put on my foot and make it look as real as possible. So when I walk in there, you don't again walk and tell Alana, show us what you'll do. No, he's telling them there's a patient who has come in, please go and attend to him. And some of the factors I'll have as a patient is I'll be very rude, I'll be very unresponsive, I'll do things to him as it would be in a real clinical environment. I've had one immersive scenario where I was involved. And one of the objectives for them to do was to debrief the patients. So the mother comes in, they are pregnant and she's convulsing and everything. And the learners and the mother is with a rowdy husband, you know, I don't need expensive equipment, just making it look like that. And this mother is convulsing and doing that. And this guy has to brief a rowdy husband. And the husband is like, will everything be okay? Will everything be okay? And the guy is like, sit outside, everything will be okay. Don't worry, everything will be okay. Unfortunately, in that scenario, the mother goes into cardiac arrest and they don't make it. Then they told the same guy who told the husband, everything will be okay. Now go and talk to him. He actually sweat and just stood at the door. He didn't go out. And it was a simulation scenario. So the point was, I mean, the classroom might not really teach debriefing. You might teach debriefing, but it's in a classroom setting. Immerse them into a deep session that will look like that, and then show them what could you do. Then they will take it seriously. So another simulator over there for obstetrics, just showing you the photos as I almost wind up. So obstetrics, we have a high fidelity simulator. This simulator gives birth, and you can change the baby into different positions. Those who had a chance to come to Aga Khan, you could see this. I mean, there's a cost factor to it, but whatever this thing does, I want you guys to judge at the end. Is it worth? You'll answer that question. But the point is that simulator can do so many things. It can give birth, you can put the baby in different maneuvers, give the baby shoulder dystocia and all these. You can do CS on her. I'm like, you will teach your learners here how to manage a shoulder dystocia. I don't know how many they will be able to do in their first year of graduation. Maybe that's a point of research. And then the second year of whatever they've been posted to Bondo, they see that. That is where students are like, this one, muiti ambulance, we tunampeleka JOTRH, and it's 100 kilometers away. Yeah. So what do you do when such situations come? So real immersive simulations, tapping into technology, but making it real to our environment. There's even more advanced ones, which I think institutions at your level should tap into. I find it a little bit, I'm not in too much into tech, but I find it a little bit unfair to these students. When you're teaching them about, you know, there's a sciatic nerve on the other side of the leg on a paper, on a book. So you see this leg on the other side, there's a nerve passing in the middle of the muscles. I mean, and you want me to write that in the exams and you give it to me, you know? You know, the heart, the ventricle is on the other side, and just on the other side of it, and you are showing me a black and white picture. To think on the other side of it, there's the other artery which goes up, you know? And then you want me to practice. So anyway, technology such as this, an atom age table, so real. You know, you can turn that, you can go through different modules from the skin to the toe to everything, to the muscular system, to the vascular system, all that to the nervous system, just digitally in a 3D format. These guys will understand it better that way. There's even more practical ones which have come up. You can do, that's a cataract simulator, and the other one is an OGD simulator, which you bring up slides and things and you do a near real, using real equipment, surgery on that thing, with different levels of difficulties as you learn to do the different things. Now there's the famous one, which is the VR, which is the cheaper one and very good as a visual aid. You know, the time for drawing charts on the wall and manila papers trying to show the other side of the heart, just behind this picture, there's another muscle called, no, just get VR, have the guys put the glasses on, you can subscribe to the cloud, you know, storage and whatever. As you turn this thing on, learners can see it and appreciate even much, much better. And some of these technologies like VR is not that expensive. Yeah, it's not that expensive. You can look into it. Now I'll go to the last part of immersive spaces. So immersive environments where you have rooms which can be created to dedicate this to replicate the real spaces. So I would call these OSCE, Open Clinical Structured Examination Rooms, but I'll just call them assessment suites. So you have this, you don't do it in front of a class of a student lying on a table. That's good, but you want to create a more immersive session using even available technology. So head-to-toe examination, create a clinical environment, put a patient there, throw in a few students, have a small video recording that or streaming it to the other room, have the other guys look there because they're like, why is he forgetting the toes? You know, they can easily see that until they are there and they realize the patient is uncomfortable. He's saying, you are very young, I need a senior doctor, and all those things pulled into place. So until they realize there's that pressure to that environment, they may not be able to appreciate. But such immersive rooms, just creating simple rooms with, let's say, a bed and a couch and a whatever, and an audiovisual system would bring out things which we will not get in this other demonstration. There's that cost question, which I said. There's the cost question, I'll not answer it. The cost versus efficiency question. There are many factors you look at when you're looking into that. I know we all want impact, but everybody focuses at the input. And I want you to remember about the cost and efficiency question using this picture. So you are a husband in your home and you want to buy a new knife. Do you sit with your wife and children for a meeting first to discuss what will this knife do? What is the security of this knife? How are we going to take care of the children with this knife? Which children might cut, or should you just use stones? I think sometimes you just walk with your knife to the house and then see what the knife can do. And then if the kid cuts themselves, you figure out how to fix it. Remember, I told you technology, we don't have somebody who has gone ahead of it. We are creating it, using it, looking at the product. So remember that knife. And I think from today, those board meetings you have about online learning, the platform, people don't upload lectures, I think they should stop. And all these other things, and taking tea in some hotel, discussing how we implement the electronic learning and whatever. I think those meetings are wasting time. In conclusion, this is what I have to say. Technology is here to stay. There's nothing you can do about it. The more you delay, the more it changes, the more new things come up. The other time you're telling students, you cannot bring to me an abstract in 2 days because you remember in my days, I did it for 3 months, going to the library, getting references. And here you've not referenced correctly, go back, not 2 days. Now they have ChatGPT, they'll do a whole research paper in 14 hours or 12 hours. And some of those are authentic. But then how do you make sure that the content and the objectives you want them to get is being retained by this learner? So it's here to stay. So one of the things I point out is faculty development. Don't be left behind. You need to step into that space as an institution. And then 3, I've always said tech, put in garbage, get garbage out. Let them give you research papers from ChatGPT. They will graduate with the research papers from ChatGPT and they'll go home empty. And your relatives and your villagers in the village, they'll go see him as a doctor. And you can guess what will happen. So we should make sure, as I was telling you through the interactive forums, whatever goes into them is as good as what you expect to come out of them, because in one or the other, we will meet that. And then 3, I've already talked about number 4. I will not walk out from wherever I am and go to the government and say, hey, we need to change this policy about EHRs or whatever. Even an institution like KMTC, I was saying actually, when COVID was there, KMTC was the best to inform the government. Unfortunately, maybe we did not do. But if all your learners graduated in all counties had an electronic way to submit whatever is happening to every patient who gets vaccines in like 3 days, you would walk to the government and say, hey, we think this vaccine is affecting this age group in 1, 2, 3, 4 ways, do not bring it. And then the money you are supposed to bring it, please increase our salaries. Anyway, yeah. So anyway, such kind of policy. So as an institution, you are at the very peak of it, and you can change a lot of policy about that using information and all that. So the cost question, I say that the cost question is answered by results. And then one of the things I said also, the cost question can be answered by the fact that resources can be pooled. The anatomy table you saw there costs 20 million. So if you, yeah, it costs 20 million. It's not cheap. They've packaged a town and a town. And if you buy that one, I think you'll be surprised. Sometimes people say medicine is hard. I don't know. But I think if you avail all these assistive things and some of these, audiovisual information, it might, I don't know. Somebody will do a research about that. But I tend to think video, audio, pictures tend to influence our mind more than literature, because then I have to read, conceptualize it, memorize it, put into an image, and then you torture me with your exam. I have to write it to remember, then I graduate now knowing. But if you ask me what movie I watched first in my life, I'll tell you when I was 6 years. How I saw the guy, jumping over the train and all that, so I remember that. So sometimes I tend to think these kind of things would do. So if you pull down resources, I saw a very good simulation center here. That is one of the way pulling down resources, then your learners can go through it. Thank you very much.
Yeah, thank you, Joas. I'm very happy that anytime that we meet, you usually learn something new from you, and also the zeal in which what you exhibit in regard to technology. Yes, we have gone through that session, and we have learned the intersection between technology and medicine, practice. We have gone through threats and opportunities. We have also gone through costs for efficacy, and we have seen that the cost is answered by results. He has also taken us through quite a number of technologies that we can be able to adopt in our colleges like KMTC, and he has also even gone ahead to give us the pedagogy of how to utilize these technologies. Thank you for that. So just want to begin the question and answer session by probably asking Joas that because every time that I meet you, I get to learn something new. So how do you stay informed about the emerging trends and technologies in healthcare profession, education, so that we can learn from you as a college, such that we can be able to keep ourselves abreast with the various trends that are out there? And then are there any research projects or innovation hubs that maybe you can suggest to us that are focused on developing and testing new healthcare technologies, which KMTC can leverage on? So those are my two questions as I open up to other questions. So but you can start by answering that. Thank you.
Thank you so much. So quickly on the two questions, how do I keep up with emerging trends in technology in healthcare? I think research is helping a lot, but the challenge is I mainly access research outside our setting. So look at papers and everything outside our setting, then try to infer that. As you can be sure, tech in healthcare, as I've said, that gap I mentioned is still very big in our setting. So it's trying to look at other environments. What do they do? Simulation, healthcare simulation, immersive healthcare simulation. It's now that the new centers are coming in. The other part of the world, things have gone so much ahead with that. So it's keeping up with research and trends, and then also, just looking around, and also looking at failures, because I've evaluated so many failures, failed technologies, failed projects, and I always say, one day I get a platform to speak with the big donors, whatever, I don't want to mention foundations, but they throw in very big money at a project with no capacity, with no building people's capacity, without even doing a pre-thing to understand the needs. Or sometimes you do a needs assessment and do the questionnaire you send to people. While they're taking tea and mandazi, they're like, here, yes, no, and then they send back. And then when you implement that project, it's dead on start. I've gone to institutions with big equipment, with MRI machines, with whatever. I will quote this one We went somewhere for training, and then while we were in that training, there was a cardiac arrest in ICU. So the nurses came running and saying, come and help us. You guys are here. Come help us. There's a problem in ICU. Went to ICU, connected the patient to the monitor. Oh, this is VFib. We need to shock this, or what was it? Where is your defibrillator? He ran to the store and came with a defib in a box, tied up, new defibrillator, still sealed with an official seal. It was delivered like 2 years ago. So by the time we are cutting those things, oh, we plug this thing to power, unfortunately, we lost that patient. Yeah. But the problem was whoever delivered this had a very good idea. But did they take time to look at how do we develop, how do we keep, who will operate these things, and not just defib and many more. So I'm learning from failures. I'm enthusiastic about learning from failures, but also I'm enthusiastic about keeping up with what is working. You know, I don't wait for funding, for whatever. What works? How can we implement it? Who is ready to work with it on that? So I think I said in this presentation, there's no savior coming. The saviors are you. So if you're waiting for one from somewhere, they are not coming, I assure you. This technology, we have to dive in from the top. If you guys from the top dive in, then from there, it will be very easy to resonate it downwards. Thank you.
Thank you, Joas.
The tech hubs have answered it. It's still coming up. And I think if we keep a network, we can keep tapping into those that are helpful in our setting. Thank you.
Thank you for that response. I want to, at this juncture, I want to welcome anybody else who has any question to Joas. Yes, can have. You can use this, please. Thank you very much, Mr. Joash. That was a quite insightful presentation. Mine, not really a question, but an echo and sentiment on the same. Like, for instance, you mentioned about our e-learning platform. Indeed, yes, implementation, it was very much efficient, but now matters to do is utilization, the usage, slightly around 45%. And it's a big task that to ensure that the utilization is high by ensuring that two things. Number one, acceptance of the system to the students and staff members, and also on the side of the tech to ensure that we have a robust channel to ensure that the e-learning platform is on the way to be usage. Another point is you talked about artificial intelligence, AI. We do understand that we're moving, and already we are in the world of smart world, whereby we have in smart cities, we have in smart industries, we have in smart health, right? And this, because this is already the world that we are running in, are we ready for emerging technologies? Are we ready for artificial intelligence? Are we ready for robotics? Where is the gap? My input will be, as much as we will come in all these particular technologies, especially for like artificial intelligence, chat GPTs, regulation and formulation is a crucial thing. For instance, like the last 2 months, we've had several conferences about data protections. And also like a week ago, there was a conference in Kenya that was about ID for Africa, right? We welcome in new technologies, but we are not looking on the other side. So for me, especially on the healthcare sector, the artificial and our framework policies in place. Thank you.
Very, very important. I would agree with you. And I'm actually throwing the question back to you. Who is to form those policies? Is it Joash sitting somewhere? It's you guys. Yeah, it's actually you, because you sit in you are training healthcare workers for the entire nation. So if there's a policy to come, it will come from you guys. And I would agree, policies, very important. That's why I'm like, step into that space before they do so much. You saw what happened with the Huduma number, spent a lot of millions of shillings registering people. And one guy from somewhere walked to court and said, we don't have laws. Who's keeping this data? Where? Which server? How secure is it? And this process had to be stopped after spending millions, and that is when we now have to go to parliament to create a data protection office, who was elected, and really, I don't know if they know what to do, but probably they had their policies, but the data protection should have come before we started doing, then it could be a more framework. What if the data protection person realizes there are flaws in Huduma numbers? So what do you do? Anyway, I'm not going into that, but very true. Regulation, policies, I believe they have to come from the top. Yeah.
Thank you, Joas. Somebody else? Yes.
Thank you very much, Joash, for this wonderful presentation. I have some concerns. One, all the simulators you have shown us, the task, whatever the high fidelity, have not seen any showing us on diagnostics. What is happening? Number two, you bring me that machine. I'm not trained on the operation. What do you expect me to tell the students? You will give me the mannequin to deliver in real patients. So what do you have to say on the simulator instructors? Should they be trained? And where are we starting? What is the starting point? Thank you.
Can somebody answer that from the second one? I left the second one for somebody to answer here. Yeah, but the first one on diagnostics. So on EHRs, so different systems are embedded in different places. On electronic healthcare record, they come with so many modules. There's one called Clinical Decision Support System. So it has all these algorithms, which when you get a patient with vitals and whatever, you try key them in, and then it narrows them and tries to tell you what could be the possible diagnosis. So those are there. So those modules comes in different places. The last one I'll tell you would be on simulators. So if you come to established simulation centers like where I work, the institution also employs dedicated technicians. So you as a clinician, you don't have to struggle. And there are clinicians now who don't practice, they are learning the technological bit of it. So if you come to a place, there's me, who is a main technician, there's a clinician, somebody with a clinical background, but understands the simulation equipment, who helps faculty who come there to teach using these simulators. 3, we have small courses internally. We have one which is called Certified Clinical Simulation Clinical Educators Program. So these ones we spend like 4 days teaching you how to best teach using these simulators. But the approach is very simple. I always say, look at the problems we have, then see how can we use these technologies to address those. So you start there. Yeah. It's a very heated session, so I don't.
Thank you, Joas. Yes. Okay.
Okay, thank you, Josh, for the presentation. It was also quite electrifying and quite stimulating as well. So mine is not even a question, but rather a comment. You know, sometimes when these new things come into institutions and you have got people who have got the knowledge and know-how in terms of how these things operate, I want to assume that you have got a duty of advising institutions. Like, for example, you are discussing about artificial intelligence and how it can really infiltrate into students and affect the retention of knowledge and the quality of training. But when you look at an institution, it is not going to pick on that person who is directly dealing with the students in terms of these instructions to inform this person on how these new technologies could really affect the learner. Rather, as you've put it, you would find some people who are not even directly involved with the student, spending more time, probably resources, getting into some of these opportunities of learning the effect of some of these technologies coming on board. And not even the technology. We have got so many other things that which come on board in terms of training of the students, some new programs. But now, when it comes to the selection of the front learners in terms of what needs to be done, then a decision, probably an error is committed. And then maybe we start going in circles without seeing the fruits at the right places in terms of the system and the various parts of the system. So I think this is a challenge which we really hope so people like you are coming from out, or even ourselves, we should take up some of these forums to be able to point them out for some corrective measures. Thank you.
Question here.
Yeah, okay.
Thank you so much. And I think from this presentation, then I've just realized that there's a question that has been disturbing most of lecturers and especially clinicians, that for quite some time we are not, clinicians are not practicing, yet they are teaching. So you may be teaching things which are not there. You find
the student has gone for a clinical placement, and what you taught them in class is totally different with what is currently happening on the ground. So I think through engaging tech, then we can be able to find means and ways of doing it. Some people were even suggesting that why should KMTC even start having hospitals? That if it is a KMTC campus, then we should also have a KMTC hospital just there, so that we are able, the lecturers can be able to practice. But I think with the technology, then we should be able to now think of, as a clinician, then you should be able to now think of technology so that if you engage so much in it, then you are able to now know the exact procedure and how it is done, and constantly you get updated, and that will be a good thing. Thank you so much.
Thank you for your comment. Any other? Okay. Dr. Manyara?
Yeah, thank you so much. I don't know whether I can be heard.
Yes.
I can be heard. All right. My question is, things are changing very fast in the digital world. We wake up today and it is ChatGPT. Tomorrow it's Ata AI. To the next day it is virtual reality, augmented reality. So if KMTC was to invest in some of this training technology, what would you advise for KMTC? And or should we just make a hub as training institutions so that we get the best, and so that all the trainees can use such a hub that is high class, instead of each of us setting small bits and pieces that are not the best? What would you advise? Thank you.
Yes, Joss? Because it involves money. But simply put, I would say there's this. So I was like, I don't know if you have, like, I know there are many associations and everything, and these accreditation things. Sometimes I used to tell people, I wish these accreditations were happening in that I'm a nurse and that I'm supposed to renew my license. There's this hub somewhere, let's say if it's KMTC regionally, where I have to walk into a simulation center with simulated patient, and we are learning new things. Like there's like a one-day intensive thing. I have to go through several procedures while somebody is scoring me. Then I receive my certification. Not just the CPD, which somebody will do a lecture online and I'm sleeping, you know, I just mute, enter in, turn off the camera and sleep. Then out of the meeting, they just log me out and I get 5 CPT points. So I'm like, if it was that interactive, then making the big ones a hub is more easier, because then your learners can utilize it, your practitioners can utilize it for continuous, you know, improvement. And trust me, if you make a hub and invest it in the first time, those recertification courses, I'm not a finance expert, but I'm very sure if you guys have 100,000 graduates and you say to recertify your certificate after every 1 year, 2 years, you just pay 5,000 to redo this and recertify. Trust me, after the first round, you'll build 2 other labs like that. Of course, with a good manager, you know, who will take care of that money. You'll build 2 others. So the initial investment might be high, but such a thing would do. So a hub for these very expensive equipment, I would propose for that. Now, for institutions, have these basic ones, but real ones. Not a BLS mannequin, which is just like a piece of mud sitting there and they can throw him. No, there's one which they will do. It gives them responses of the depth, the rate, how fast they were, and they'll be able to get those skills. Trust me, let me tell you, we get bad outcomes sometimes because of how we train people, because BLS 1, 2, 3, 4, 5, go. So when I'll go to a hospital and in casualty, somebody has collapsed and I'm on WhatsApp sitting in the corner, it's like, hey, emergency, show up. Me bado niko phone. You guys, I'll come. I'm just chatting. I don't really know that that patient who was arrested has 3 minutes, because when I was doing my BLS, I did 4 rounds in 15 minutes. So the urgency thing never clicked in my head. But if I was in a real simulated environment and I'm realizing, hey, this thing is heavy when you're doing CPR, it's very heavy. When somebody will say help, I'll show up, because I'll know if he's alone, he might do the right things for 8 minutes and will not save that patient, or 9 minutes. But if you are 3 of us, split up those roles, we'll achieve the same objectives in 2 minutes or 3 minutes, and we'll save that life. So sometimes when help is called, that clicks and you run. So you see, those small, they should be there. But I propose, let them not be too basic. You know, the ones that are being used in 1980. Let's go into ones that are more modern and all that. VR can be gotten in almost all your campuses. and you find that VR, what you'll send in your campuses are the glasses. The cloud has the software. So everybody has to log in from different, sharing the same resource in different areas and many other things. So I think it's a case-by-case basis, but I would say you guys would agree with me, hands-on, and then making the environment real would contribute more. Thank you. Yeah, I think this discussion has to continue somewhere because it can go on and on. But one thing I'll tell you for sure, he raised a very important thing. If you buy that knife and throw it on the floor, the kid will cut themselves with it. You'll go again to another meeting to decide whether that knife was good for your kitchen or not, or you should get a panga and all that. So if you buy those mannequins, you don't equip the right people, you don't do it right, it just goes down. So I feel, yes, we need to take a bold step and step into these technologies. But as he also said, raise the right teams who look at policy, who look at implementation. I think your e-learning has stopped because it was all about upload a lecture. These guys go in, read one lecture, tells everybody what was there, and nobody else will go in there. You never made it interactive in a way that people would keep going in and finding. You know, sometimes they go in, post an assignment, you don't do anything. You just wait the end of the term and say, this guy looked nice, 14. The other guy doesn't very nice, you ni watisa, you know? You didn't even comment, but trust me, when they see you commenting on their responses, they are happy. Somebody's watching what I'm doing. So it becomes more engaging and more lively. So the platform would be even, I think I want to applaud the people who work in your IT. I looked at your platform, it's wonderful. That's why I asked, I don't know how much you're using it. Whoever is in IT knows what they are doing. Whoever is to use what they are making also knows what they are doing. Thank you. Let me end there. I'm enthusiastic about technology. I don't want to talk so much about it. I'll eat into other presentations time.
Yeah.
So allow me to end it there. And thank you so much, KMTC. Thank you for giving me this time. And I wish you all the best as you prepare and create healthcare workers here. And just remember, as you create them, trust me, that's why I'm like, tap into technology. I want to raise a thing that all of you know. The people you are creating are escaping our country. I don't know if anybody is concerned. You guys are not. Personally, I am. Whoever is listening to me, if it's a government, fine, but many nurses are leaving the country for other places. You know that. They are leaving from every corner. You deny them a visa in Kenya, they go to a neighboring country, they get one. Just go. So now, I don't know if you are replacing us with people who wrote a research paper on ChatGPT and send them to replace those positions, or you are replacing us with the more competent people you trained those days. You guys know those days. Those days who are now leaving. So have that in mind as you think about this, but I strongly feel as an institution at the top national level, step into the tech platform here, tell these guys the right thing to do, and let's move forward. Thank you so much.
Thank you so much, Joash. I'm very happy that you have even helped us encourage members to join this world of technology. You usually, anytime you talk, you make things look very easy, just like you have just done now. And I know so many people have been challenged, and we wish to continue with the conversation on our online platform. If you have a comment, you can place your comment there. Thank you, Joash, for this session. I want us to move to the next session, which is a presentation. So we are going to have our next presentation on experiences in conducting a first online licensure examination, a case study of the Clinical Officers Council by Duru M, Kuria A, Aswa A, V, and Manuva A.
Hello everyone, my name is Violet Aswa. I am a lecturer of pediatrics at the Kenya Medical Training College and also a member of the Clinical Officers Council Examination Board. Today, I'm happy to share with you our experience on conducting the first pre-internship, also known as licensure online examinations that were conducted in 2022 at the Clinical Officers Council. So welcome. My co-authors were Bainaduru, Eunice Kuri, and Angeline Munavu from the Kenya Medical Training College, the Clinical Officers Council, and Thika Level 5 Hospital, respectively. Our outline will take this format. Just a small background into the Clinical Officers Council is that it is established by an Act of Parliament, number 20 of 2017. By it is mandated to regulate training, registration, and licensing of all clinical officers. It is in line with this mandate that it has been administering pre-internship or licensure examinations since 2009 as a measure of quality assurance to all graduates of clinical medicine from various training institutions. However, with the advent of COVID-19, there was a general disruption of operations in all sectors of life, including training and learning. And therefore, this posed a risk and a disadvantage to all would-be interns because then they would not have sat their pre-internship examinations. And therefore, there was a proposed shift from the traditional pen and paper examinations to virtually administered exam without losing their quality and integrity. Our broad objective was to evaluate the proficiency with which the 2022 first online licensure exams were conducted. We were to look specifically at the adequacy of preparedness for its success, ICT strengths and drawbacks, as well as the challenges that may have been faced by the proctors and test takers. This was a descriptive study. It was conducted in the Republic of Kenya across all countries. It involved 6 technical support staff who were mainly ICT trained, 78 proctors, and 1,984 test takers drawn from 3 cohorts. We used email questionnaires, phone interviews, and also reviewed reports from our minutes, ICT support team, and the EMS. Data was analyzed using Excel application and presented using tables and figures. Our main measurable outcomes were, number 1, to look at the preparedness and its adequacy. So we had a schedule of events and with timelines that were to be done. Number 2, we had communications that were to be done to the test takers and also to the proctors. And then we were also to look at the proportion of test takers and the proctors that would be trained, test item management in terms of their preparation of the question papers, their safety, and also their scheduling. And all these things were recorded in our minutes, in the ICT reports, and also the EMS data records. In looking at the ICT strengths and drawbacks, we were more concerned about the data safety of the test items, and we also wanted to see the proportion of test takers that would be able to log into the exam and complete without any challenges, and also the aberrant behaviors as would be picked by the AI and the human proctors. And finally, we were to look at how much analysis of performance we would be able to do. Last but not least, the challenges, we were to look at them in terms of what would be reported by the test takers as well as the proctors. Let's look at the results. I'll give you a small breakdown of the test takers. We had Bachelors of Clinical Medicine, Bachelor in Science, Comprehensive Ophthalmology and Cataract Surgery, and then the diploma takers. So the bachelor's degree in clinical medicine as well as the comprehensive did the exams on day 1, and then the majority diploma took the exams on day 2. Now, looking at the adequacy of preparedness, all the scheduled activities, communications to test takers regarding their registration and approvals, payment, authentications, and the trainings of both test takers and proctors, super proctors were all done according to schedule. The question papers were prepared and the management was done according to schedule. So that was 100%. Now, looking at the proportion of test takers that were able to be trained, as well as the proctors and support team, this is what we found, that all proctors and support team members attended the trainings as well as the mock trials. Generally, of the test takers, we had 93% of them participating in the training. And this is a breakdown of the various cohorts, the bachelors and the diploma. You see more than 2/3. Now, some of the ICT strengths included a high level of data security. EMS strengths, others included that it was easy to navigate and use. It had a very high capacity. We were able to upload many different types of test items, including images and videos. Students were able to even do complex calculations on the system without having to carry a calculator into the examination room. The artificial intelligence was superb. By it, in combination with the human proctors, we were able to catch 41 candidates, representing 2%, who had aberrant behaviors, and these candidates were either terminated or their exam results were cancelled. Another strength was that real-time evaluation. Results were as ready as the exam ended. And then going forward, we were also able to do a diverse types of analysis on the performance, including thematic areas, cognitive levels, and competency domains. And then when we looked at the proportion of test takers that were able to complete the exams without any hitches, that was 94%. And that was very encouraging and successful. 1,862 candidates. Now, this is just a general outlook on the test taker outcome. When you look at the bachelors in clinical medicine, 98% were able to complete without any hitches. 2%, that is 6 candidates, were terminated. None had a challenge. When you look at the bachelors in comprehensive, none had aberrant behaviors, none had challenges. But when you look on day 2, remember I told you the degree holders, candidates did the exam in day 1. But when you look at the day 2, that is where we had challenges. 35 of the candidates were terminated or had their exams, cancelled due to aberrant behaviors. And then we had 81 candidates who suffered or experienced various challenges. That accounted for 4.9% of the day 2 population, and that was 4.08% of the entire test population. So the main drawbacks were a system shutdown, the technological system shutdown on the Kenyan side, because this data was being transmitted from India. So on the Kenyan side, there was a shutdown. This affected the data transmission and affected 4.9% of the test takers on day 2. And like I said, they represent 4.08% of the total test taker population. Because of this also, there was selective disabling of some user buttons on the EMS by some proctors, just a few of them. Now, another drawback we were able to identify was unstable internet connectivity, and this affected test takers who were mainly in remote areas. Now, of those test takers that were affected or experienced various challenges, the 81 of them, all of them were contacted by phone, and 23% could not be reached, while 77% were reached. Of the 23% that were not reached, they were called at least 3 times, and either the phone went unanswered or they were just unreachable. Now, of the ones that we talked to, this is the outcome. Most of them had actually attended the trainings in terms of the meetings and trial mocks. Just a few had not attended, 5%. Now, this is the picture. You can see the mock trial attendance. For those who experienced challenges, 84% had tried on the mocks, had practiced with the mocks, and 65% had actually attended the sensitization meeting. So that means that they did not have any challenges interacting with the system. Now, these were the glaring challenges that we summarized. Unstable internet connectivity, particularly in remote locations. Inadequate ICT literacy. This one we observed among the diploma test takers. Difficult system navigation. This one affected test takers that had not participated either in the mock trials and they had not even attended the training meetings. Panic anxiety. This one affected everybody, all test takers, when the system shutdown took place. And as a result, because many of them were now trying to reach the system, the support system, they were unable to because of the overwhelm. From the ICT and the exam board, it was overwhelming communication time because of the many phone calls that were coming in. And then the exam board also noted with concern that more than 50% of the proctors did not adhere to all proctoring instructions. What are some of the glaring or the major lessons that we learned? Number one is that even with the most flawless technology and preparations, backup plans must be put in place, and this is a mandatory step. Unstable internet connectivity, which was a disadvantage to test takers who were in remote locations. We found out that availability of data was not a problem. And then the suboptimal digital literacy among diploma holders. This should be enhanced. Now, selection of proctors should be done judiciously. This exercise was very much cost effective. AI proctoring should be augmented by vigilant human proctoring. In conclusion, we say that from the experience and our lessons learned, it is possible to proficiently conduct licensure examinations remotely. But for this to be achieved, number one, preparations must be very meticulous with backup for every step. Number two, vigilant proctoring is necessary to augment the artificial intelligence, and test takers must prepare in terms of availability of internet connectivity. We wish to thank the Clinical Officers Council, Board of Directors of the 11th Council for their support. We wish to thank the Registrar of the Clinical Officers Council, Mr. Ibrahim Wako, and we also want to thank the Kenya Medical Training College for allowing us this opportunity to share our experience, which we believe will also help others who would wish to take on this path. With those many remarks, I want to say thank you and God bless you. Amen.
Yeah, thank you, Madam Fire also for that presentation. I wish members you note your questions. You shall ask them at the end of the session because of the interest of time. I want to call the next presentation, which is on telemedicine adoption in Kenya, a systematic review of barriers and facilitators by Riani K and Motier JK. Thank you.
Thank you for the opportunity. To present the results of this study. That is a review of the OCO training since the training began. My name is Dr. Lucy Manyara, and I will be presenting this study on behalf of my colleagues and researchers mentioned here. KMTC is the only government training institution that trains ophthalmic workers. The training started in the 1960s, and over time, a lot has changed in terms of the population needs, the population growth, and the type of training. As KMTC fulfills its mandate to train, the question is, does the training prepare the students or the trainees for the work that they are supposed to do upon completion of the training? Therefore, this was a study aimed at documenting the characteristics of the trainees over the years and also determine the workplace preparedness after their training. This was a cross-sectional mixed study with both quantitative and qualitative data, and we are indebted to the KNH University of Nairobi Ethical Review Board for reviewing and approving this study. This was a huge study, but in this specific analysis, our main outcome measures were the characteristics of students admitted for ophthalmic courses, as well as their workplace experiences as qualified ophthalmic workers. We had two sets of subjects in this study. The first set was the records of students who admitted for ophthalmic training at KMTC since its inception, or since the inception of the training. As you can see, we had 342 students' records, but only 142 had complete records. The second set of subjects were the qualified ophthalmic clinic officer, whose data was collected using an online data collection form. So together, these were brought in for analysis. Getting into our findings, starting with the socio-demographic characteristics of the students and the qualified officers. Out of the 142 student records analyzed, majority, that is over 68%, were male, which is in line with the gender of the qualified ophthalmic clinic officers that showed that over 60% were also male. The age range was 29 to 50 years with a mean age of 31. Out of the 158 qualified ophthalmic clinic officers interviewed or whose data was taken, 60.8% of them were male. Their median age was 44 years and close to 3/4 of them trained in ophthalmology and cataract surgery as a combined course. A total of 114, that is 46 plus 68, or about 80% of qualified ophthalmic clinic officers were deployed or said they were deployed within 3 months of completion of their training. The rest, about 20%, have taken between 4 months to 1 year to be deployed after their training. And in such a country that is in dire need of such services, the employers need to expedite the deployment of the qualified officers so that patients can get the services that is already available to them. From what you can see from this pie chart, about 70% of the clinical or the qualified clinical officers are working in urban areas, with Nairobi County having the highest number of these clinical officers. If you look at the Kenyan map, the vast areas of northeastern and Rift Valley, where there are myriad of eye diseases, the qualified clinical officers are really scanty. We then went ahead to look at the qualified clinical officers, ophthalmic clinical officers, and to see who was working still in the clinical officers' work and those who had moved on to other work. Out of the 142, 132 or 93% of qualified ophthalmic clinic officers are still working or supporting work as ophthalmic clinic officers, despite the fact that some have added responsibilities. 32 ophthalmic clinic officers had other responsibilities, mainly teaching and administration, besides doing the normal clinical work with the patients and also in surgery. Others were coordinating ophthalmic and country eye programs, which is still supporting the eye care program in Kenya. We then went ahead to ask the qualified ophthalmic clinic officers about their perception of workplace preparation upon completion of their training. And they were to do this using a scale from 1 to 5, with 5 indicating that they were very well prepared and 1 indicating that they were not at all prepared for their work. The results indicate that majority of the participants, that's 67 plus 68, which is a total of 135 or 94%, expressed a positive level of preparedness, either feeling very well prepared or somewhat prepared for the work that they were supposed to do upon completion of their studies. And to follow up with this, we asked the qualified ophthalmic clinic officer if they could recommend the course to others. Over 94% would recommend the course because of certain reasons. And some of the reasons here include the fact that there was intense training and close supervision. There was also a comprehensive course structure and practicals, but most importantly, the satisfaction and the good patient appreciation upon treatment or surgery. And so in conclusion, the students admitted for the ophthalmic clinic officer training program have a median age of 31 years. They are mostly male. They're government officers. Most of them are government officers and are mostly self-sponsored. Majority of qualified ophthalmic clinic officers, that is, and specifically this was 94%, feel that they were well prepared for their work upon training, even if majority of them work and were stationed in urban areas. And therefore, this study recommends increased government funding for the trainees in ophthalmic clinic officers. And secondly, putting measures in place to increase the uptake of ophthalmic programs, especially by the female gender. The study also recommends that the government, which is a main employer, to expedite the deployment of the qualified ophthalmic clinic officers upon completion of their training, and also to put measures in place to deploy them in the rural areas to make ophthalmic services accessible to the rural population. At this point, I want to thank KMTC for funding this study and for the KNH University ERB for reviewing and allowing this study to proceed. I also want to express my gratitude to the research participants, without whom this research would not have been done. I would also want to thank the research assistants and all who supported this research in one way or the other. Thank you.
Yeah, thank you for that presentation from Dr. Manyara. There was some bit of a mix-up. So that presentation was on reviewing 60 years of OCO training at Kenya Medical Training College. So and now we are going to have the next presentation. I said we can light somewhere our questions so that we can have them later after the presentation. So we are going to have the next presentation, which is on telemedicine adoption in Kenya, a systematic review of barriers and facilitators by Dr. Riani and Dr. Motie. Thank you.
Thank you for the opportunity to present the results of this study. That is a review of the OCO training since the training began. My name is Dr. Lucy Manyara, and I will be presenting this study on behalf of my colleagues and researchers mentioned here. KMTC is the only government training institution that trains ophthalmic workers. The training started in the 1960s, and over time, a lot has changed in terms of the population needs, the population growth, and the type of training. At KMTC, we built its mandate to train. The question is that.
Sorry for that confusion. Let us get the correct one. Thank you.
Welcome, everyone. Seventh Scientific Conference. Welcome, everyone, to KMTC 7th Scientific Conference. My name is Jackson Kimeu, and I am presenting a research based on telemedicine adoption in Kenya, a systematic review of barriers and facilitators, which was co-authored by Dr. Ken Riani and I, Jackson Kimeu. Kenya faces significant challenges in providing healthcare services, including limited infrastructure and shortage of healthcare professionals, particularly in rural areas. Telemedicine has emerged as a potential solution to improve healthcare access in the country. However, the factors influencing the adoption of telemedicine in Kenya remain unclear. And there is a lack of understanding of the current state of telemedicine adoption. The systematic review aimed to identify the barriers and facilitators of telemedicine adoption in Kenya, assess the level of adoption, and gain insight into the types of telemedicine technologies being applied. In the research, we came up with the following methodologies: a systematic review following PRISMA, and that is preferred reporting items for systematic reviews and meta-analysis. Electronic databases, including PubMed, Medlin, and Google Scholar, were comprehensively searched using relevant keywords to identify studies on telemedicine adoption in Kenya. Also, 25 studies met the inclusion criteria after screening 256 relevant studies initially identified. The included studies conducted between 2011 and 2021 utilized qualitative and quantitative designs and were geographically diverse across Kenya. In the research, we came up with several outcome measures. The study aimed to determine the barriers and facilitators of telemedicine adoption in Kenya. Additionally, the range of uptake reported, the types of telemedicine technologies applied, and the barriers and facilitators identified in the included studies were examined. The review included empirical studies published between January 2010 and December 2021, investigating factors influencing telemedicine adoption in Kenya, non-empirical studies, non-English studies, and studies conducted outside Kenya were excluded. Data extraction encompassed study design, sample size, study population, intervention, and outcomes. A narrative synthesis approach was employed for the data analysis due to heterogeneity among the included studies. In the research, we come up with the various results based on barriers and facilitators, which included lack of horizontal infrastructure, which is low penetration of internet connectivity in rural areas, and also technological infrastructure challenges, inadequate funding, and lack of training and awareness among healthcare providers. On the side of facilitators, we came up with low, strong support from the government, and also public-private partnership, patient acceptance, and many more. Mobile health and teleconsultation were the most commonly used telemedicine technologies among the included studies. Variation in evidence, quality, and risk of bias was observed. In conclusion, this systematic review identified the barriers and facilitators of telemedicine adoption in Kenya, highlighting the need to address challenges such as limited internet connectivity and infrastructure, funding constraints, and the need for training and awareness among healthcare providers. The finding emphasized the importance of government support, public-private partnership, and patient acceptance in promoting telemedicine adoption. Policymakers, healthcare providers, and stakeholders can use these insights to develop effective strategies to improve healthcare access in Kenya. Further, research should investigate the cost effectiveness, impact on healthcare outcomes, and perspectives of patients in healthcare providers regarding telemedicine in Kenya. Finally, we gratefully acknowledge the funding support provided by Kenya Medical Training College for the research. We also extend our sincere appreciation to KMTC for their commitment in advancing healthcare access and their recognition of the importance of telemedicine in Kenya. Thank you.
Thank you for that paper, Jackson. I'm requesting members to still write somewhere their questions. I want to call the next presentation, which is on HIV and associated indicators of COVID-19, cytokine release syndrome, a meta-analysis and a meta-regression by Muduka J, Aruoch K, F, Wabura, Nabeswa R, and Mativo J.
Thank you and welcome to this presentation. HIV and associated indicators of COVID-19 cytokine release syndrome. The predictors for this syndrome are multifaceted, and this condition can be dominant in COVID-19. It might go undiagnosed, and it is the one which has been presumed or clinically proven that is associated with the COVID-19 severity. The effect of other several factors other than COVID-19 cytokine release syndrome have been mapped by several studies. The subjective issue that we aimed at looking here is HIV as one of an infection or a pandemic that has been there long-term at the global level. Therefore, we aimed at ascertaining the risk associated with HIV in terms of predicting the occurrence of CRS, what we are calling cytokine release syndrome, and further identify any other related factors that would influence cytokine release syndrome alongside HIV infection, other than HIV as a standalone. Using systematic review and meta-analysis study design approach, we were able to pull 11 studies, and these 11 studies were therefore treated as the study subjects, synonym to primary study approach. But this was a systematic review which pulled information from published work. And meta-analysis followed by meta-regression was conducted to ascertain the pooled effect of HIV on CRS, as well as meta-regression, therefore, to account for covariates by using what we call random effects model and relative risk as a measure of effect. Since this used data that was published, studies could be published differently based on so many factors, including the size of the study population, and the methodology that was used for that study, and so many factors. And by that, we would therefore conduct what we call publication biasness, which is a way of ascertaining the precision of our results that we aimed to obtain. The trial was registered under Prospero, as it should be a norm in any systematic review and meta-analysis. The findings were clear that up to 48% excessive risk was associated with being HIV positive. And the prediction interval here was between 0.67 to 3.29. Prediction interval means in any setting, when you talk of true distribution, HIV could actually be protective. It could protect some populations by 33%, and in other populations, it could be having an excess risk of CRS as high as 229%. That is subject to any part of any population. If this study was done, if this quest was done in any population, any part of the globe, that those studies should not go below 0.67 and should not go above 3.29 in terms of prediction interval. However, talking of 1.16 to 1.88, this is subject to the sample size that this review used. And that is the difference between confidence interval, which is subjective to the sample that was used in a specific study. In this case, there were 11 studies, and the prediction interval is what we call distribution of true effects. When you look at this forest plot diagram, it shows that the effect was up to 48% in terms of excess risk. And these were the studies that were included in that meta-analysis. You can see most of the studies were on the upper side of prediction, apart from 1 or 2 studies, or 3, 1, 2, 3, that were on the lower side of non-prediction of CRS. Now, sensitivity analysis therefore followed by eliminating some studies that were presumed to cause high heterogeneity. The high heterogeneity means that there was variability or differences between the studies that were included in this meta-analysis. And the following sensitivity analysis, it was found that the risk increased up to 71%. When you talk of sensitivity analysis in this kind of study design, is eliminating studies that were presumed to cause the major heterogeneity. It was at 80%, but when we did now sensitivity analysis by removing 5 studies, these were 11 studies, we removed 5 studies and we remained with the 6 studies. As you can see, this is 1 study, 2, 3, 4, 5, 6. The studies that are not showing their statistical effects or outputs here are the ones that were presumed to cause the major differences. They could be seen here. However, we have deleted, or the statistical output from those studies has not been accounted for in this analysis. And you can see now the shifting from 1.48 to 1.71. And that shows with the precision that HIV would predict CRS. Heterogeneity that was at 80% now reduced to 0%. And it is with the clarity that HIV is a risk for cytokine release syndrome. However, this HIV would predict cytokine release syndrome. We used some parameters that would define this cytokine release syndrome. From the published studies that we included, some of the studies used mechanical ventilation, others used critical care admission, others defined flare-up of CRS characterized by specific biomarkers like interleukin-6, and others also talked about inpatient services. And by default, when you look at critical care services or intensive care unit admission, it was very significant for cytokine release syndrome, and it was associated with HIV at 71% when you look at this statistical output. At the same time, when you look at mechanical ventilation, it was at an excess of 42%, as you can see here. Apart from increased levels of interleukin-6, which is one of the biomarkers for cytokine storm flare-ups. However, in the normal practice, it is not mandatory that if a patient has COVID-19, they must be admitted to ICU, or it does not mean that presence of interleukin-6 defines severity. It is the level of that interleukin-6. Some of the patients were resolving by themselves, the ones that were being treated at home, and that is why we were talking of, asymptomatic stage. We had moderate stage and then severe stage of COVID-19. However, now with HIV, mechanical ventilation, talk of intensive care unit admission, and the subject issue as reported by some studies that we are talking about inpatient services. To this study, we considered the fact that an inpatient service would involve maybe intensive care unit admission as well as mechanical ventilation. That is the subjective issue that we used to define cytokine release syndrome. You know, again, we would use study settings based on where this data was pulled from. Some studies were multiple, others were single center studies. And when you look at this statistical output, it is obvious that most studies that gave the most reliable information subject to this analysis were the studies which used multiple study settings at an excess of 16%, as opposed to single center studies that showed no much correlation. Actually, they were protective up to about 17% when you look at 0.83 here. And heterogeneity for both of these statistical output, it was at 44%. This was 99% variability, what you're calling heterogeneity, but this was 1% with the multiple center studies. So in the context of HIV predicting cytokine release syndrome, as per the findings from this study, multiple center studies or studies that were conducted by pulling data from diverse regions gave the most credible or rather reliable correlation subject to the objective of this study. We did a meta-regression based on the studies that were used for this review, and we looked at the year and the region that the study was associated with. The year, if the study was conducted in 2020, if it was conducted in 2021, or if it was conducted in 2022, for instance, the year was associated with, you know, the prediction of cytokine release syndrome. And it is true, when you consider the early stages of COVID-19, there was not so much of this phenomena being understood. And then most recoveries were not being experienced. However, we had a lot of acute stages of infection, and towards late 2020 and early 2021, as per this study, that is where we experienced most of these studies reporting that HIV is actually associated with the cytokine release syndrome. We should expect cytokine release syndrome to start occurring post-infection with the COVID-19 disease. However, basically, from this output year, the year that a study was conducted contributed to 55% prediction of cytokine release syndrome. This calls for further research quest. Why was there a differential aspect between 2020 all the way to 2022? What were the other factors that would be associated with the cytokine release syndrome? Remember, cytokine release syndrome characterizes the severity of COVID-19 or even the case fatality rate. The case fatality rate in epidemiology here means the mortalities that are associated with the COVID-19. And then 11% actually was contributed by the region a study was conducted from. And from this study, you find that the United States of America, studies that were conducted in the US were majorly associated with the cytokine release syndrome. Probably it's not because that is where the severity of this condition was, but basically it could be defined by the size of the US population, which is over 300 million. Probably there were so many study settings that were involved in US as compared to any other region. And this is what we call meta-regression. And now, apart from now HIV alone predicting CRS, therefore, the year a study was conducted and the region would, alongside HIV infection, of course, end up predicting the same. Now, pulling all the coverage together, we obtained a 78% prediction. This is what we call the variance proportion explained by the covariates. However, we obtained that HIV predicted CRS by 48%, and post-sensitivity analysis, it predicted up to 71%, the excessive risk. There were other factors that would, alongside HIV infection, that would contribute. And this was at using this, we call it pseudo-R statistics. Pseudo-R statistics basically shows the collective influence of so many factors predicting an outcome. If it was at 78%, all these factors could be, of course, the year, the region, possible biomarkers. And that means a research quest is of paramount importance to ascertain if there are variations in terms of these covariates. Based on this study, it was very crystal clear that studies that have been published before, actually primary studies other than meta-analysis like this one, they had a similar statistical output in terms of HIV predicting CRS. You can see we have that 1% excess in a particular study that was conducted by the Dachi. Then Feng et al. At the same time found the same. And this is where they compared multiple center studies against single center studies, whereby multiple center studies that were conducted from multiple settings, actually influenced cytokine release syndrome, just the same way to the prediction of this study. That shows some validity and reliability of the findings. Coming to United States of America and comparing it with South Africa as well as United Kingdom, in this study, actually using fixed effect model, which now narrows down to a particular settings other than the random effects model, which looks at a diverse region, the risk for CRS subject to HIV by a study which was done in USA showed a 42% excess. And this study had a 48%. You can see some similarity. And if this was the case, you can find that the findings were at 1.52 in terms of relative risk. So looking at this green, which is the South Africa, this study found an excess of 12% subject to variations in terms of prediction. Another study almost found the same statistical output. In this study also, in UK, it was protective, at reporting a relative risk of 0.81, which was protective by about 19%. Similar findings were also found in a study conducted by Ujai and Dong et al., which was done in 2021. Basically, on this discussion, we are reaffirming that the statistical computations or the results that were obtained from these meta-analysis were very clear that HIV predicted cytokine release syndrome just as other primary studies. Basically, the recommendation, therefore, from this review is that a public health intervention should be carefully tailored to implementing in people who are having HIV, subject to and adding higher biomarkers, other specific biomarkers, which could predict cytokine release syndrome, and then an intensive and regular focusing on these vulnerable groups and looking at futuristic aspects of viral pandemics should be accustomed towards ascertaining the influence of some inherent conditions like HIV, subject to possibility of predicting cytokine release syndrome. For further readability of this presentation, you can look at the digital object identifier. This work has been published in QRS Medical Journal under Springer, and you can read the entire paper there and see the allometric score and the citations that have been done in this study. I wish to stop there and thank you so much for your time.
Thank you. Dr. Muduka for that paper. I wish to ask members still to take notes of some questions that they would want to ask as we listening to the last paper. The next paper is on association of pregnancy with coronavirus cytokine storm, a systematic review and meta-analysis by Muduka J, Aruoch K, F, Wambura, Kipto M, and Mativo J. Thank you.
Welcome, my name is Dr. Muduka John. I'm presenting research findings on association of pregnancy with coronavirus cytokine storm. Pregnancy is considered a high-risk condition for COVID-19 based on published work, and this cluster of vulnerable population is subject to asymptomatic infection with this condition, and data that has already been published reporting over 75% who have this COVID-19 pregnant women during the pandemic. The effect of several risk factors have previously, of course, been reported in several meta-analyses. However, small sample size studies and premature data has taken precedence. Therefore, this study aimed at fortifying the existing science or evidence by using systematic review and meta-analysis for more improved empirical evidence. We aimed at examining the relationship between this pregnancy status subject to cytokine storm and, of course, account for possible factors that could influence the same. We use systematic review and meta-analysis, and electronic database were reviewed, whereby we pulled over 17 studies. And saying over 17 studies, these studies were past 3,000. However, based on inclusion and exclusion criteria, we narrowed it down to 17 studies where we pulled the information. In this case, we used random effects model and the fixed effects model, as it is the practice in systematic review and meta-analysis. And since we wanted to look at the association between pregnancy status and cytokine storm, we used the odds ratio as the effect measure. Publication bias using the funnel plot was used, as well as sensitivity analysis to account for heterogeneity, as it should be the norm in research quest using this methodology. Basically, pregnancy was found to be associated with an experience of cytokine storm because we use studies which were reporting a comparative aspect of a pregnant woman and an unpregnant woman. And it was crystal clear that pregnancy status influenced cytokine storm by an excess of 147% based on the odds ratio of 2.47, the blue area, at a confidence interval of 1.63 to 3.73. This, the statistical output showing that is the upper table. The lower table now shows the same risk post-sensitivity analysis, which went as high as 7.41 in terms of the odds ratio. And this sensitivity analysis was reliable because the variability between the studies, or what we call heterogeneity, reduced all the way from over 80% to 29%. And this is a good thing in meta-analysis because it demonstrates that the results are valid and the association that is being measured is more reliable. This funnel plot you can see here is subject to updated meta-analysis, which was sensitivity analysis. As you can see, the small circles you are seeing in this funnel means the studies were not experiencing any publication bias as they were published. A further reason to reaffirm that the statistical output of association between pregnancy and cytokine storm was more reliable. If the studies were outside this funnel plot, then would say that there was publication bias, and we will do further analysis to ascertain this precision, probably by clustering the studies based on the region or maybe based on the methodological aspect. So the funnel plot basically illuminates whether there was sensitivity, not sensitivity, sorry, whether there was publication bias or not. Now, subgroup analysis was done to investigate that heterogeneity that we found, which was over 80% during the first analysis before sensitivity analysis. And by doing that, we compared multiple center studies against single center studies. You can see this diamond, the diamonds on the graph here, which are in red, demonstrate multiple center studies, and the small circles, which are in black, demonstrate studies that were conducted using single source population studies, like a study was just done by pulling the information or conducting the research in a single setting like facility A, as opposed to multiple center settings, which pulled data from facility A, B, and C. By looking at this statistical output, still the variability did not change that much when we separated single and multiple center studies, because it was above 50. In meta-analysis, if heterogeneity or variability is above 50%, it shows that there were perceived differences between the studies that the researcher has pulled together. However, then, we went further to do what we call a within group sensitivity analysis. Would account for within sensitivity analysis for multiple center studies as well as single center studies. When that was done, it was crystal clear that single center studies, the variability or heterogeneity reduced up to 2%, which is a good thing, because in meta-analysis, if the heterogeneity, or what we call the I-squared statistic, is below 50, it shows that there was lesser variability, as opposed to if I-squared statistic was above 50%. However, it remained unchanged and extremely very high for multiple center studies. And you can see it has further been demonstrated by this funnel plot, where the diamonds in red are outside the scope of the funnel plot. And we are very clear that most of studies which were giving heterogeneity were multiple center studies. Further to that, previous research has indicated similar association. When you look at studies done in Asia by Kolkova, Zirenia, and other researchers, the same statistical output of pregnancy predicting cytokine storm syndrome or cytokine storm was also crystal clear among researchers who conducted primary studies. Again, with similar conditions like COVID-19, published work by Marcio, which was done in the context of primary study. It showed that COVID-19 disease severity increased during gestation, which is a similar scenario as per the findings in this study. Therefore, this study has added to an extensive consensus, or rather it is in agreement with existing literature, which needs to focus on examining pregnancy status as a possible predictor for cytokine storm, which is a condition or a syndrome which predicts severity of COVID-19. Basically, as per the conclusion, therefore, pregnancy is significantly associated with an increased COVID-19 syndrome severity, which is defined by cytokine storm. Therefore, a recommendation from our findings is that there are possible interactions between the inherent inflammatory cytokines and cytokine storm due to COVID-19 in pregnancy. And in the normal situation, pregnancy status would at first be linked with pro and the real inflammatory processes during the gestation period. However, this study was very clear that being pregnant would actually predict the cytokine storm syndrome. And therefore, we recommend further research which should aim at looking at specific biomarkers which would be associated with the pregnancy. The reason why we were so crystal clear on this association is that we had two groups. One group was pregnant, the other group was non-pregnant. The subject issue that we considered here is that a study that was reporting pregnant women in comparison to non-pregnant women, that was the study that was included for this analysis, and that increased the power of testing in terms of our conclusions herein. This work has been published, and for further readability and conceptualizing the entire idea based on the time issue, you can visit Pediatrics JMIR journal, which is Corpus Indexed and also in PubMed, and you can be able to read the entire paper there, as well as reactions from other researchers at a global level in terms of the validity of this work. And you'll be able to see several studies that have also cited this work for their own research, especially biomedical research, which is looking at advanced levels of random clinical trials. They have relied so much on these findings, a fact that we consider credible relative to the conclusions therein in this study. Thank you so much for your time.
Yeah, so thank you, Dr. Modhuka, for that presentation. I want now to welcome members to have their questions. So the first presentation was on first license examination on COC. So probably from my side, I would want to know what COC did with those students who did not do the exam at that time. Probably were they because of either challenges which were mentioned as drawbacks in the presentation. So were they punished, or were they given another special examination, or they were or were they led to wait until the next cycle of the examination? Because that with that we will be able to learn a lot as also as e-learning department, because we usually have online exams, and sometimes students are unable completely to log in to the examination during exam time. The next study was on a review of the 60 years of OCO training. What I can say is that this is a remarkable study and a well-documented documentation of what the department has been doing of those years, and I would say keep it up. The next study, the next presentation was on telemedicine, just trying to refresh your minds. Telemedicine adoption in Kenya, a systematic review, which used a Prisma approach on barriers and facilitators, and a narrative approach in the analysis. Then the next two presentations are on HIV associated indicators of COVID-19 or COVID-19 storm and pregnancy. Actually, I would I've learned a lot. I would have probably imagined that we would have a lesser chances of getting a COVID cytokine storm in HIV positive or HIV positive patients and also pregnancy because of their low immunity status. But quite these two presentations were very informative. So just to have that, I was just refreshing your minds and want us have a round of questions, and then the presenters will answer their questions. So let us have more questions. Okay, yes, Dr. Magusa.
The presenter who did, I think it's, remind me your name. Yes.
Yes, Jackson, okay.
Yes, it was a very good presentation, Jackson. It's not a question, actually, but I tend to think you are more into scoping review other than other than systematic analysis or systematic review. Yes, other than systematic. That's more of when you're reporting, it would sound much when you talk of we did a scoping review, because there is no much of quantifiable data which would justify empirical evidence. If you just change that to scoping review and then republish a bit, that paper is very good. That's just the comment I have. I don't think I have any other comment for the other presenters.
Thank you. We can have somebody else also comment or have a question. Yes, Okum.
Yes, on the last two presentations by Dr. Muduka, we've noted that CRS mainly happens to people with lowered immunity. Now, maybe on further research, maybe you could do a comparative analysis in case because there is pregnancy and you have seen HIV, and there could be a combination. There could be a mother who is pregnant and is also HIV positive. What would be the scenario? And even in young children, maybe malnutrition, where there is immunity again is lowered. So it's a good area. You can do several other studies, further studies on the same. Thank you.
Thank you, Kumu. Anybody else with a comment or a question? Yes.
If I may, I have two questions. One is to Madam Aswa concerning the COC paper. It appears that attending the rehearsals gives you a better chance of navigating the portal easily, and you have a better chance of finishing the paper. Now, I would like to know whether the timing of the rehearsal has anything to do with the number of people that are able to attend, whether it can be maybe put at a different time to allow for those that were not able to attend last time to be able to attend this time, and whether that could change the outcome. And the other one is to Mr. Jackson concerning telemedicine. It appears that it's also something that we are not able to avoid. And my question is, as the people who are waiting for this knife to be brought back home, how is it that we can best prepare for telemedicine as an institution, KMTC, that includes staff and the students as well? Thank you.
Thank you. Another comment or question?
Thank you. Now, I have some concerns on HIV and associated indicators of COVID-19 cytokine release syndrome. Now, cytokine release syndrome, we understand that it can be caused by other factors. So my question is, when you look at the HIV and the COVID-19 now, are they in any way related? COVID-19 came just like the other day, and here we have cytokine release, which has been there for so long. And if so, were all the subjects which were involved in these studies, all of them suffering from both HIV and COVID-19 pneumonia? Then, was that prediction really associated with HIV or COVID-19 pneumonia? In your conclusion, you said HIV is significantly associated with an increased risk for both COVID-19 and cytokine release syndrome and mortality. Now, does it mean that this is why they said HIV patients were at high risk of contracting the COVID-19? and ends dying of it? And if so, what about those who had diabetes and high blood pressure? Because they were also victims of the same. On the other presentation, association of pregnancy with COVID virus, coronavirus, cytokine storm, you quoted somebody by the name D. Marcio. When did he do his work? Why? Because COVID-19, he said that COVID-19 severely increased during gestation. And we know gestation goes in stages. Which stage? When was this study done? Because COVID-19 is just the other day. Thank you.
Thank you for those comments. Anybody else? We can also have maybe 1 or 2 comments from the online viewers. Do you have any? Do you have any from the online viewers? Yes. Okay. Yeah. So from the online viewers, we have one from Elon Kipto, says, thank you, Mr. Jackson. That was quite a good presentation based on emerging technologies highly needed in the medical sector. But my question is one, you have explained the challenges of telemedicine, but what is the meaning of telemedicine? And give examples of the telemedicine technologies or tools. Then question 2, the population is increasing, and yet there are few medical facilities. How can you articulate this, and what is the plan of the government support, especially those in rural areas in relation to telemedicine? Then another one here from Sami. My name is Samuel, technologies specialist. That was a good presentation, Jackson. Medical healthcare in Kenya really needs to adopt these advanced technologies. But my question is, why do we have very few medical providers practicing telemedicine in Kenya? Then another one was okay, this was on Joash. Thank you for a very educative presentation. Can we get this presentation in soft copy? Yeah. Thank you. So I want to call upon the presenters to answer. We can start with the first presenter. That is Madam Violet Aso.
Thank you very much. I'm going to start with the first question that was raised. What did the Clinical Officers Council do for the students who faced various challenges during the examination? Now, what happened is after we went through all the recorded challenges and those that had been reported to us, we decided to give them a special exam. So all candidates who had challenges, all the 81, were welcome to take another exam, and that was conducted in November. Now, those were not the only beneficiaries of that particular special exam. We also looked through, because the EMS is able to record all events for all candidates. We looked through and saw who was not able to start the exam entirely, who tried to log in and did not even go beyond question 1, 2, or 3, or 5, but there's evidence they logged in. All those were also welcome to take the special exam. So it was an opt-out, really. So those who did not do it is because they did not want. And so those who did not show up for the special exam had to wait for the next cycle, which was, we just did it in May, just the other day. All right, so the question number 2 from the student, could the timings of the trainings, right? and the mock trials. So we had three trainings. One, we put everybody together, and then we realized the mass was too huge. So we broke it into two. So we had 2 days or 2 sessions of trainings, and students were welcome to join either of them, and both of them if they were still not conversant. So the first meeting was a sensitization meeting where we trained all the students and inducted them into the online exam business and everything that was expected. We took them through all the requirements and the regulations. And then we scheduled 3 mock trials. We had mock questions that looked exactly the way the exam will look like on the platform. The first 2, a candidate was free to choose either of the 2 or even do both, because they were scheduled between 9 in the morning up to 5 in the evening for 2 days. So a candidate was free to choose or even attend all of them for both days. However, the last one was mandatory. All candidates or test takers, we call them test takers, were supposed to attend the mandatory one. Because in the mandatory one, which is the last one, we also involve the proctors. So though it is usually done a day, 2 days before the main exam, so that in the day in between, we are able to contact those who have registered for the exam and did not come for the mock trial to find out what is the problem. Besides that, they have an email address to communicate with for the support team. And we also have telephone numbers and phones that they can call to report any challenges. Those who do not do that, the support team is very dedicated. We'll usually call them and find out and tell them, you did not attend the mock. What happened? Did you have any problems? And things like that. And then things are sorted out. So that is at least the way we try and make sure that everybody is inducted and they're able to interact with the system and they don't have trouble on the last day. Like you saw in our study, those candidates who had trouble navigating through the system and even logging in, because we encourage the candidates during our meetings, sensitization meetings, that the laptop you intend to use for the exam should be the same laptop, preferably that you use for the mock trials. And they're given the specifications for the laptop. So those who do not attend those meetings, they do not come for the mock trials, are the ones who end up having very serious problems on the day of the examination. In fact, some of them, even when they're given instructions, close that tab, do this, they don't get it. They just don't understand what you're saying because they are not familiar with the language that is being used. And I think with that, I didn't have any third question.
Yeah.
Thank you.
Thank you, Madam Aswa. And just maybe to also add on that, thank you for that good answer. Probably because we are looking at copying from those who are doing well. Probably when you're doing that, maybe you can even provide more experiences, like even those device requirements that you have realized probably are having trouble, including cost versus efficiency. So to say, like, for example, what is the cost of one student doing taking a tests, an online test, would inform decision makers going in the future whether to take that route or not. Yeah, so that's a comment. I know probably you don't want to answer that.
I can still say something though,
okay.
that we looked at the cost implications, comparing we call them size or magnitude of exam. So this magnitude of exam we did in September, it was the first time. We compared it with a similar magnitude of exam that was administered physically, the pen and paper. And we saw there was a unit cost reduction by up to 38%. Yeah, so.
Okay, thank you. Seems like you want to comment on that. Okay. Okay.
Thank you. I'm noticing that what is happening with Clinical Officers Council on matters examination is also akin with what is happening with nursing in terms of nursing council examination. So my comment, rather my suggestion would be, yesterday listening to the DDA, she requested for specific actionable recommendations that which the college can pick up and implement. And when I listened to the ICT guru speak, he pointed out that those softwares and systems that which encompass so many things together don't seem to deliver. And Ken, looking at our scenario, we seem to be suffering from the problem of having too many things in the system, including examination, that has not picked up. Now, with this, I am expecting that the finding of I'm imagining you're using the DigiProctor. Yes, it's also similar to what is being used by the Nursing Council. And I'm imagining that the campus, now that these things are actually finding their way into the scientific conference, can also trade and borrow a leaf from these two councils in terms of strengthening examination systems in the campus, because this DigiProctor, I also happen to have taken part in some of the processes involved, and they have got enhanced systems of checking the students, the DigiProctoring, including also the physical proctoring by lecturers. Then number two, rather a question to you. You mentioned one of the major challenges faced by the students during the taking of the test items from the DigiProctor as internet connectivity for those learners who are in remote areas. So my question was, I was wondering, are you allowing students to take this examination from individual places of where they stay, or you having them into a center? If that is the case, then it seems some of these centers are not well scrutinized, such that during the time for test taking, the centers could also be having problems with the internet. So what would be the recommendation even for the council, that which even KMTC can borrow in terms of mapping out and locating suitable places and centers for taking examination? Because I think, clearly speaking, this one could be one of breakthroughs in terms of examinations across department in KMTC. Otherwise, the work was good, and it could be an eye opener if properly packaged and presented to the campus as we requested yesterday. Thank you.
Thank you. Do you want to comment, Madam Master? Okay, briefly, because of time.
Thank you. I'll be very brief. As opposed to the Nursing Council, and by the way, we did our benchmarking with Nursing Council also before we settled on this, but we went it a little bit differently. We did remote. Them, they do sit in. It is electronic, but they gather their candidates together and they provide all the necessities. For us, we said no. If you are going online, people don't travel. People do the exam at the comfort of their home. However, we tell them what they must put in place for preparation. So the challenge that we noticed of internet connectivity did not affect many, actually. It's just around 7 candidates, I think, because it's about 4% of the entire population. And you saw we had 1,984 candidates, okay? One of the things we were asking the candidates when we called them, because we called all of them one by one, those who were able to reach the 77%, we were asking them, among other questions, if we gave you a chance after telling us their story of events on that day, if you gave you another chance, because we were already planning for the November special exam, what are you going to do differently? And they say, I will move to a place so and so, there's better internet there. I think this laptop was not so good because I changed it on the day of exam. So this time I'll do so. I think it is something that can be worked around. But again, whether to gather the candidates together or let them do it remotely, again, depends on what the institution would prefer. Thank you.
Thank you.
I know. I think this point is very brainstorming. I need to add a point on it. I also have been doing some ICT support for the NCK exams. And yes, the presentation was very insightful as well. Number one that I've pointed out for the last 1 year is that the candidates who are coming to do the exams, they are normally very in panic, right? Then also matters to do with the internet connectivity and the infrastructure
laptops that are being used. My recommendation will be, especially for KMTC, if we can come up with the infrastructure labs purely meant for examinations, right? And then we don't need to tell candidates to come with their laptops. They have to get in the examination room, find everything there. Connectivity is there, which is very much robust. And then the laptops are what kind of equipments are being placed there. Yeah, so I think that is my input.
Thank you. You can comment. You also had a question on telemedicine adoption. Kenya, quite a number of questions, please.
Okay, thank you. I think I had several questions. I will start the one that my colleague has, and it was about the adoption of possibility of adoption of telemedicine in KMTC. This is a nice one, and I'll put it this way that through the KMTC strategic plan, reviewing some of the smart health technologies that we can be able to adopt in relation to medical healthcare, telemedicine, telehealth, and the rest, like the way Mr. Joash has taken us through. Simply, my advisory will be, we need to include this particular kind of courses in the normal curricula, such that when we are producing our medical practitioners going on the ground to deliver, then they are equipped with the right skills. So it's just a matter of embedding these technologies within our curricula. The next question was from online. Someone had asked about what is all about telemedicine and some of the tools and examples. Telemedicine involves use of telecommunication technologies to deliver medical services to patients who are in remote areas by bridging the gap between the medical providers and the patients who are located in different locations. And then some of the examples that we have like mobile consultations, which involves consultants and patients doing either video conferencing and data conferencing. We also have what we call telcare, which involves remote monitoring of patients. We also have visual visits, whereby doctors can be able to remotely consult patients. A very good example is some countries, they normally practice what we call, trying to consult expectant mothers, not them visiting the hospitals physically, but they can be consulted remotely. The other question was about due to increase of population, and this is very crucial, and Mr. Joash will agree with me that the healthcare sector is expected to grow at a compound rate of 15.8% by the year 2030. And therefore, due to increase of a population and also high rate of patients with chronic complications, then adoption of these technologies is very crucial in our country. Issue to do with rural areas, I'll put this in line with the government. The good thing with the government is that it is highly supporting what we call digital transformation agenda. For instance, I remember back in 18th April this year, there was an agreement between Communication Authority and the Minister of ICT, that is ICTA, for driving a project of implementing the last mile connectivity to 19 counties in Kenya at a project of around 5 billion. Yeah, and I remember even our presenter said yesterday from the Ministry of Health, Bwana Joseph, is indeed already they have done 10,000 kilometers. So in the next 2 to 5 years, the government will be able to come up with around 100 kilometers. And now in relation to patients living in marginalized areas and rural areas, because I understand several medical providers in Kenya, they are providing telemedicine. And a very good example is Aga Khan Hospital. Now, these patients who are in remote places, they'll be able now, to get this particular kind of services. I think those are the questions. The last one was about, we normally have very few medical providers practicing telemedicine in Kenya. Unfortunately, despite the Kenya Medical Dentists and Practitioners Council approving licenses to several hospitals in Kenya to practice these kind of technologies, still we have low adoption of the smart health technologies in Kenya. And one of the biggest challenges is lack of crucial regulation policies of smart health. So thank you.
Thank you, Mr. Jackson. Do you want to ask whether Dr. Manyara has a comment? Dr. Manyara, on the OCO training at KMTC? Just 1 minute.
Can repeat the question. I think I didn't
There's
hear
no
the
question, just maybe
Yeah.
a comment.
Or a comment on OCO training.
1 minute.
All right, I don't know what comment to make, but he's still on with the training. I think we are making it better and better. And following Josh's presentation, I think our next thing we're going to do is to do the logbook, the ODK or Red Cup. I think that's what we are going to do, and it's going to review. I don't know, the word has disappeared, but it's going to change our training. Yeah, thank you.
Thank you so much, Dr. Manyara. Then we have Dr. Mabuka to finish with the remaining 2 studies.
Yeah, I'll be very brief, and thank you so much for those questions. On the aspect of Bwana Churchill in terms of areas of conducting research, it was a comment, but I think I feel indebted to mention this for the sake of knowledge. That actually is ongoing. From that study, we have already picked on other parameters that we are still working on. Actually, we are running a random clinical trial as we talk, which was informed by the first study on HIV. And by virtue of doing that, and for the knowledge of every other person, to have an impactful study, you need to realign yourself with the WHO research priorities. So we looked at, we could have worked with any population, children below the age of 5 years, but we were working with a phenomena which was confusing everyone, even the scientists. And the recommendation was from WHO, look at vulnerable populations, and they put them there. So we used our wisdom, and then we saw HIV and the pregnancy. Because we saw most of people had done a lot of diabetes, and diabetes would not bring a lot of impact, because even from there we had started seeing people dying of hypertension and diabetes. So vulnerability informed us to do that. To respond on the questions by my sister there, it is true cytokine release syndrome. Even now, when you have a severe cold and flu, I'm not a medical officer, but I have little knowledge on that. You might present with some kind of inflammatory responses or inflammatory processes like that. I know we have medical doctors here, they can ascertain to that. However, when I talked of prediction interval, that is what I meant a nutshell to answer that question. We did not cast it on stone that those who have HIV would develop cytokine release syndrome as if it has not been there with other conditions. It has been there, it's going to continue to be there. What we are looking at is that this differential aspect of this cytokine release syndrome, which is actually associated with COVID-19 severity. And it is the one that was leading to most of these case fatalities. You might have seen concept of fatality somewhere. I would admit, it's good to admit liability. That was a typing error, because there's a study that has looked at cytokine release syndrome relevant to mortality, and it is still published. You can just type my name, or you can type Francis Mushiri, you can type Kelly Oluoch, and then you type annals of epidemiology. You'll be able to see that study of relativity between CRS and mortality, because that is what we are devised to map the two predictors. Now, this risk of 48%, it is just a risk. It is not a concept of we are casting it on stone that if you have HIV, you must develop CRS. It is just a risk, because the study population here was studies that were having 2 arms. We had comparative studies. The studies that we included in this analysis had one group exposed to HIV, the other group not exposed to HIV. So we had already controlled the study. And those who are HIV negative also had the COVID. So that is a good thing about it. Even those who are HIV negative had the COVID, as same way for those who are HIV positive. We have already controlled the ground before we even go further. And we realized when you talk of 1.48, we have already given them one. So everyone could experience cytokine release syndrome up to 100%. We agree, whether you're HIV positive or not. However, it has gone above for those who have HIV, and that's what we call relative risk. Remember, we used the relative risk, which is the risk ratio, which shows to what extent can someone who is exposed to HIV can be more succumbing to cytokine release syndrome. That is one. On pregnancy, I talked of Middle East respiratory syndrome, taking you back slowly to the East, because before you do such kind of a study, you need to be adept with a lot of knowledge so that you know what you're exactly presenting. I can attest to you that the COVID-19 that we're experiencing now, or that we experienced in the recent past 2 years, has been there. Only that the science had not established it in clarity. It was there as Middle East respiratory syndrome, and it killed over 50 million people. All right. And having done that, Mashio was doing a study like any other researcher. He was doing a primary study. Actually, he did it in the lab, and he took biomarkers and this, and he realized women who are pregnant were having a higher associative factor in terms of developing cytokine storm. We are not actually saying that this cytokine storm must appear in pregnancy, because in the same case, we controlled that by a cluster of studies which are reporting both pregnant cases and non-pregnant cases. And further again, to get this clarity, when I talk of sensitivity analysis, you can see at first, if I go back to HIV, we had 1.48. When you talk of sensitivity analysis, you do that is like eliminating the outliers. What you call sensitivity analysis in this kind of design for primary studies, what we call taking care of outliers. And when you saw that funnel plot, it showed only like one study that was outside. All the studies were inside. And when we now started comparing which study settings were having more association, you could see the diamonds which were outside the funnel plot. Here, we are not predicting by what we are imagining. We are putting data which is coming clear under Prisma checklist. And before we got the trial license for these studies, those were some of the very pertinent questions that we answered. And I can see you are very observant. That is very commendable. For why and when this study was done, the one which had now similar findings to this one, I would tell you it was done in the event of Middle East respiratory syndrome, and the same researcher during COVID, he did another primary study to see whether there was. So that study, those two studies that I was citing were done by the same person. For you to see when they were done, I can tell you he did this study in 2021 for the one for COVID. The other one I cannot remember because I did not put the year. However, go to that citation. You'll be able to see the years that studies were done by Mashio were published. And that was a very keen observation. Just for your take home, go and read about prediction interval. You'll be talking about the same HIV pertinent to my study subjects, which were 11 studies. However, I'm reporting prediction interval. You can see now I'm shifting back from 1.16 all the way to 0.67. That means actually in some countries, when you have HIV, it could protect you against cytokine release syndrome. But which countries are these? Now that is what we are doing to map out what are these factors which are leading to maybe HIV protecting people from CRS. Is it probably they are adhering well to ARVs? Is it probably they are advanced or something like that? And thank you so much for those questions.
Thank you so much, Dr. Muduka, for the responses. And because of time, we want to end this session at this point. We want to ask our members to continue interacting with us on our online chat. You can type your chat there, or you can email your question to our secretariat. So I want to thank you all for having me on this session. Now I want to give this session back to our Deputy Registrar in charge of research to give us guidance for the next steps. Thank you.
Thank you very much, Mr. Kinyua, for taking us through this session. Very interactive session. I'm sure we have learned a lot. We have taken more time than we thought we would, but we did not want to close anyone out. We do not want to close out questions from within and from without. So I really want to appreciate all members of this team here as physical participants. I want to thank those who are following us virtually. From morning, you logged in on time, and we have been able to do this for the last several hours. Thank you for your patience. Even when we had challenges, you still stayed on with us, and I'm sure we have really learned a lot today. I also want to appreciate our plenary presenters this morning, the speakers who are with us, Mr. Mohammed, Dr. Mohammed, Dr. Maina, and Mr. Kiptanui. We appreciate you, and thank you for your insightful and very informative presentations. So we will do this again tomorrow. Let us meet tomorrow at 8 o'clock in the morning. We will begin our other sessions, and we hope to do this and up to 1 o'clock when we can be able to close. So I will now wish to invite Madam Aswa. Please close for us with a word of prayer, and until tomorrow, thank you very much.
Let us pray. Our dear loving Father, we thank you and we bless you for this day. We want to thank you for gathering us together here, even as we asked you yesterday. We thank you for the discussions that we've had both here and even online. We want to thank you for the interactions that you've enabled us to have. We pray that, Lord, even the things that we have learned during these sessions, we shall put them into good use, and they shall be of benefit, not just to us as people who are training, but just to us as people who practice, but to the entire country and the world as a whole. And so, Father, we want to thank you for giving us this opportunity, because we count it as noble, and we want to say thank you. As we break out today, Father, we pray for your blessing over our lives. We pray that you direct our steps in everything that we do. We pray that you grant us journey mercies back to our homes. We pray that you bless the food that we are going to eat. And we thank you even for your continued provision of our lives. We pray that you keep us safe and join us together again tomorrow, even to the glory of your name. We thank you and we bless you. For it's the name of Jesus Christ we pray and believe. Amen.